for his, quality ENT practice, having best uh, equipped setup, I would say, in our country. Thank you very much, boss, for being with us in this journey. And I could hear voice of Prakash Mukherjee just now.
Yeah, good
Hello.
morning, sir.
Good
Dr.
morning,
Satish.
sir. Good
Yeah, yeah.
morning. I came to know
Um,
you being in US. Have joined us.
yeah, I
So
don't want to miss any of the opportunity when you are there. And that's why I requested Farooq to give me the link. Though the timing is here, it's around 11 or night. So, but still, I will try to be as much as possible with you.
thank you. Thank you for your commitment, being there in midnight, joining
Yeah.
us. Pleasure to meet SP Singh sir here today. He is a legend in this region for ENT and trained so many ENT surgeons here. Thank you, sir, and all the delegates. It's a pleasure being with you today. So, like Farooq had mentioned, a lot of interesting cases lined up today for the surgical demonstration and discussion. The first one to begin with, the time was for the radiology to discuss. And this first case to begin with is an interesting one. So, few words about the radiology because I've seen a lot of junior colleagues here. This is most important part of the surgical exercise when we begin. To have a complete three-dimensional anatomy in our mind of the area we are going to deal with. And that is how we get from the radiology. And the radiology of choice for the non-inflammatory diseases of the paranasal sinuses or the inflammatory diseases of the paranasal sinuses is the CT scan, which gives us excellent bony anatomy. What we all in the paranasal sinuses is simply a bony labyrinth which is surrounded by critical structures all around, sometimes with some millimetric distance. It is so critical to deal with those areas in the periphery. And CT gives us a complete three-dimensional map, like a Google map, in some millimetric distance where we are going to deal with. So the first onus on the surgeon falls upon what kind of CT scan do we order. See, if you write simply a CT scan PNS, radiologist will do in a couple of seconds with thick sections, 5 millimeter, 4 millimeter in coronal, whatever view, unless you ask some specific things. So they can finish in couple of seconds and give you a printout. To me, that contains no value. See, as I mentioned, paranasal sinuses are surrounded by important structures all around. We need to have a dynamic information of the surroundings as well as the cellular details of the paranasal sinus labyrinth because the cellular details in every individual is different. So we need to know exactly for that individual patient which we are going to operate what kind of anatomy that patient is having. So that the first onus to order a CT scan and what simply we can order as a some millimeter. You can see on the screen. I hope the screen is there on your view. See on the left lower corner, it is 0.6 mm sections. CTs for the PNS is always shot in the coronal in the axial plane. We can just ask for CT PNS 0.6 mm sections. That's it. Don't need to write anything else. Yes, you can add on both in bony as well as soft tissue windows. And then with your own software, the DICOM, you can reconstruct and get the dynamic anatomy detail. Let me show you, first of all, what kind of dynamic anatomy we can get. See, this is axial section, and this every time I click, I move by 0.6 millimeter so that I don't miss any structure more than 0.6 millimeter in dimension to view when the image changes. See this? This is axial view. Now, there are certain information which is given best in the axial view. Certain information is provided best by the coronal sections and certain by the sagittal. So, it is again on the onus on the part of the surgeon to explore each and every anatomy best visible in that particular section so as to get a complete three-dimensional dynamic information. Now, let me reconstruct to all planes the same axial section which we got from the radiologist, reconstructed to all planes. And this is such an amazing teaching, tool for the students that you can corroborate each and every finding on this software in all planes. For example, this is an intersinus septal cell. See this in the midline, and you can easily bring your cross hatch and see where exactly the intersinus septal cell seal in axial and sagittal planes. See, these are nasal bones here. You can see in all planes where exactly the nasal bones are there and how it is related to the paranasal sinus labyrinth. How anterior they are, you can see in the sagittal and the axial plane. Where the frontal sinus is, you can see where the frontal sinus is, and you can correlate in all the three planes. So this is an amazing teaching tool for the students to understand three-dimensional CT scan anatomy. Number one. Now, secondly, certain structures are seen better in the soft tissue windows, like surrounding soft tissue. See the infratemporal fossa muscles and surrounding areas, surrounding fat, the orbital details. See the interior of the orbit is completely, best seen on CT scan on axial plane, and that too on the soft tissue windows. Soft tissue windows will give you fine details of the soft tissue anatomy as well beside the bony anatomy. And see in the, as far as the pathology is concerned for this particular patient, see in the sinuses, we can see heterogeneous hyperdensities that is most likely suggestive of a fungal disease. So that you can pick up on a soft tissue window. So ideally for a CT scan, we need to have both bone and soft tissue windows to get complete information. That too again you can reconstruct in three planes and you can have a three-dimensional imaging of every information you have on the CD, on the DICOM. See this? This is heterogeneous densities in the frontal sinus. You can see the fungal material in the frontal sinus everywhere. That is how you can get. So, bottom line is we have to order CT scan properly, order some millimetric section what the machine can give for the particular radiologist, ask for 0.5 mm, 0.6 mm sections in DICOM format, and then you reconstruct. You can download this software from the Google and you can run on your own computer. So this is the way you can get dynamic information. Now, the value of dynamic information and seeing the CT scan yourself, analyzing or observing or, reporting CT scan. Now, what is dynamic? What does a dynamic CT means? You can follow each and every anatomy on your own. Like, for example, in this patient, as I mentioned in the beginning about the intersinus septal cell. See, when you begin from most anteriorly, what you see the frontal sinus. You can see the frontal sinus on this side, opacified, and the opposite side absolutely normal. This is the intersinus septum cell, most likely, which is deflected on the left side. This is soft tissue window. Let me show you on the bone window a little better. See this. Now you can say this bone very clear, intersinus septal cell. This is the most anterior aspect of the CT scan what we are looking at. See the most anterior picture. This is the frontal bone, frontal sinus on this side, and this is intersinus septum. This is the nasal, cartilages below. Now, as we go behind, what we come into picture, this is the nasal bones. We have seen just now before. This is the nasal bones on two sides and the internasal suture. Now, as far as the cellularity in the paranasal sinuses is concerned, the most anterior cells When you go from anterior to posterior, the most anterior cell you will come across are the intersinus septal cells. This is always same. The most anterior cell what you come across is the intersinus septal cell. Now for the intersinus septal cell, they communicate to either of the frontal sinuses. So how to know? That is the value of dynamic CT scan. That's what I was going to tell you. Now see, coming from anterior to posterior, keep an eye on the intersinus septal cell. See how big the intersinus septal cell is. What has this intersinus septal cell has done? It has pushed the frontal sinus opening, the frontal sinus outflow far laterally. See this? See this intersinus septal cell so big, it pushes the frontal sinus outflow far laterally. Today, Dr. Farooq has lined up today and tomorrow number of sinus surgery cases. Uh, he asked me several times to keep this time, the theme on sinus surgery, showing variety of cases, not one or two, so that we can get idea of variety of cellular situation and how to deal with that. So this the first case being so interesting. See this how big the intersinus septal cell. Now in dynamic CT will tell you how it is communicating with the frontal sinus outflow on the right side, not to the left side. So the dynamic CT will tell you where exactly it is opening into the frontal sinus. See, and this is your frontal sinus. This is your frontal sinus, and this frontal sinus is draining through the frontal recess into the frontal recess here. So this intersinus septal cell is communicating to the right side, and this is best seen on a dynamic CT. So the second important thing besides ordinary CT scan, what we get from getting in DICOM is to have dynamic information. And third important is a complete information. That is most important. When your patient comes with a printout with one or two printouts, you can get 10 or 20, 30, 40, 60, whatever number of slides. Now imagine to have complete details in all planes. How many slides you need? On the CTs, can you see? Here on the 168 slides here, 168 here, bone and soft tissue. That amounts to 336. 336 in axial, coronal, and sagittal. More than 1,000 slices. And even if you get a printout of more than 1,000 slices, it is number one, so impractical, so cumbersome to carry 1,068 whatever slices printout, number one. And number two, to see them for a surgeon to see all those printout, which is so difficult or rather impossible to correlate. And third thing, that is most important, that it is not going to be dynamic. So simply you can get this information on a pen drive or CD, and you can run on your computer with complete dynamic information, and that is the ideal way to see the CT scan for that particular patient. Now, as I said, what happens sometimes in a practice, and you feel sometimes sad also when patient comes to you with classical symptoms of sinusitis, classical endoscopic picture of polyposis, with undoubtedly clear diagnosis, with a one or two printout of CT scan in hand. And, we have to order another CT scan to subject the patient to radiation again. So it should be like something for all of us to adopt a policy to order the CT scan in DICOM, so as it is never required to be repeated, never required a patient to be subjected to a radiation again. CT is radiation as contrast to MRI. In contrast to MRI, CT gives bony details, MRI gives soft tissue details. So in paranasal sinus inflammatory disease, CT is number one choice. For other tumors and other things and other skull base and other pathologies, the MRI is the choice of investigation you order. So once it comes to order a CT scan, it should be a generalized policy, and we should start adopting that we should order in a DICOM format. Now, as I said, there are certain information which are given best in the coronal plane. And coronal plane is easier to understand by the surgeon as well. To interpret the findings, it is easier by surgeon as we get the same information in the same plane in which we operate. This gives you the information in the same plane in which we operate the patient. So, to begin with, we must extrapolate as much as information we can get from the coronal CT scan, and then we can reconstruct into other planes and see whatever best is visualized in the axial and sagittal plane. So quickly, in this patient is a right-sided, you can see, complete opacification with right-sided intersinus septal cell. This is bone window. We have seen on the soft tissue windows some heterogeneous opacity suggesting fungal material. Now, as we go behind, see, this is frontal sinus. The beak is there. If I reconstruct to coronal, what I mean to say by beak, see, we come in the nose from here with endoscope. And frontal sinus is strategically situated like this, anterior-superiorly. And this is the thick beak, which forms the floor of the frontal sinus. See this beak? When we come from anterior to posterior, a beak comes. Now imagine, you follow the beak, where the beak ends. Where the beak ends is the frontal sinus drainage. So simple. And this is what we are going to exploit in surgical session as well. When we operate, this is going to be one of the, best and the reliable landmark for the frontal sinus to identify and treat frontal sinus is follow the beak. Beak is a thick bone, I would say thickest bone in this region. You can easily feel, you can palpate and follow it. Where the beak ends is the frontal sinus outflow. As simple as that. So, in coronal, like if I come from anterior to posterior, see the anterior most are the nasal bones. Then I go behind it, the beak. Now, as long as beak is there, above is the frontal sinus. As long as beak is there, above is the frontal sinus. Now, as I go behind, see now the beak is ending. These are the frontonasal processes. Now the beak is ending and see what is this. This is the frontal recess. Now what you see in the picture is the frontal recess, not the frontal sinus. How can you differentiate? Let me go back. See what is this? See, this is intersinus septum. Sinus with the floor. Now, the sinus is ending. See, the frontal recess is coming, which is formed by the ethmoids. And see in the middle, this is the cribriform plate with the crista galli above. So now, the things have drastically changed as we go behind. This is anterior, this is beak. As I go behind, the beak is ending and the cribriform starting, and this is the beginning of the ethmoids. So this is the beginning of the ethmoids here, and this is no more the frontal sinus now. This is structure which is behind the frontal sinus. We have left the frontal sinus anteriorly. See, let me go back anteriorly. This is anterior. Now this is proper frontal sinus. I am going behind, the cribriform plate coming into the picture. We have left the frontal behind, and this structure looking like a frontal sinus is not exactly the frontal sinus. This is now the supraorbital recess. Can you see? Hello, am I audible?
Yes, very much.
Yeah. So feel free to interrupt me anytime. So now this structure looking like frontal sinus is actually the supraorbital recess. I hope it is very clear. Now, let me reconstruct in all planes and see what I was saying. The anteriorly is frontal sinus and posteriorly is supraorbital recess. Mhm. Mhm. Let me reconstruct and show you. Yes. So this is frontal sinus. Now, as I go behind, now this is frontal recess. See now, anterior to posterior, see in the sagittal plane. Look in the sagittal plane now. Anteriorly, this frontonasal process, the nasal bones, then is the beak, then is the frontal sinus, and then behind the frontal sinus, here behind the frontal sinus is the frontal recess. That is the frontal sinus outflow. See where the frontal sinus outflow is. That is the frontal sinus outflow. And behind that, this is the beginning of the cribriform plate. That is the level from anterior to posterior. This is the level where the frontal sinus ends and this cribriform plate begins. Look at the sagittal plane.
Yes, very
This is
clear.
the area where the cribriform plate begins. So anterior to posterior, we need to understand where exactly we are going. And that is seen best on the axial section here. And you can corroborate with the sagittal section. Now, as we go behind, see now, this was the beginning of the frontal recess outflow. That is supraorbital recess. See, this is orbit. This is orbit. You can see the normal orbit on the opposite side. And this supraorbital recess is encroaching above the orbit. This
Yes.
pneumatization is sometimes even beyond this. This
Yes.
goes and
Yes.
goes beyond and beyond and can pneumatize this bone, the orbital plate, the part of the frontal bone here. This can pneumatize this bone more and more. And we have seen this pneumatization even far laterally, even up to the zygoma.
Yes.
So this pneumatization of the orbital plate of the frontal bone above the orbit, see, this is supraorbital recess, and this anatomy is behind the level of the frontal sinus. We have left the frontal sinus far anteriorly now. And see, again I am going back. This is true frontal sinus. As long as frontal sinus is there, we don't see maxillary sinus. Can you see?
Yes. Yes. Yes.
Now I am going, this is frontal recess coming. And see below the appearance of the maxillary sinus.
Yes.
So once you see the maxillary sinus in picture with the structure looking like frontal sinus, it cannot be frontal. It is
Yes.
frontal
Agreed.
recess
Yes.
because we are far behind now. We are far behind to have seen the frontal, the maxillary sinus in view. So this cannot be frontal sinus. This is simply maxillary, the ethmoidal sinus, and this is supraorbital recess going above the orbit. And see, it is indenting on the orbit. Sometimes it can lead to, because of
Expanding
the
it
obstruction,
also.
mucoceles here. And we have seen segregated, sequestered mucoceles in the superolateral part of the orbit, many a times. So this is supraorbital recess.
Hello. Hello, Dr. Satish. Hello. Hello. आवाज नहीं आ रही. Hello, Dr. Satish. No.
Yes, boss. Can you hear me?
Yes. So how will you differentiate? How we can differentiate between supraorbital recess and supraorbital cell? There are
Supra, yeah.
there is supraorbital cell sometimes, na. So
Yeah.
how
See,
we
if
should
it is a
differentiate?
shallow recess like this on the opposite side, see this?
Yes. Yes.
Once it is not very pneumatized, you can simply call it as a supraorbital recess.
Okay.
And once it is extensively pneumatized, we call it as a supraorbital cell or supraorbital pneumatization, whatever. It's terminology. But recess is a shallow one
Okay.
when it is not extensively pneumatized. Now, we have seen this is beginning of the cribriform plate here now. See this as I go behind?
Yes.
Every movement brings me 0.6 mm behind.
Okay.
And see here on down here, this is 0.3 mm now.
Yes, 0.3 mm cut.
You can't miss any structure more than 0.3 mm in dimension. Now, as we go behind, see, this is expanded because it is full of disease on this side as compared to the opposite side. Can you
Yes.
see?
Yes, yes, very
Opposite
clear.
is opposite is characteristically normal. You can see all the way, and
Yes.
that is classical of allergic fungal sinus
Understand.
disease. Allergic fungal sinusitis is characteristically found in younger people. This is a 12-year-old patient, 12-year-old, unilateral with heterogeneous hyperdensities on CT scan. You can see that is good enough to, suspect allergic fungal rhinosinusitis. Now, as we go behind, you can see the configuration of the cribriform plate now better. That's the
Yes, very
horizontal
clear.
lamella. That's the vertical
The
lamella.
vertical.
Vertical lamella, see, forming the roof here,
Yes.
skull base, and you have to be careful at that point. Now, see how it is ballooning because of the mass effect, because of the fungus within and the polyps, how it is ballooning and compressing on the septum on the opposite side, septum to opposite side, and giving a DNS. Can you see? The
Yes, very
severe
clear.
deflection of the septum because of the mass effect. You can see here. Now, having seen all this coming from all the way anterior to posterior, we have not seen anything like any idea of anterethmoidal artery so far.
Yes,
Reason
yes, yes.
being, this is to shatter the fear of everybody.
Now, yes, now there is
See this?
appearance of
Yes, I'm
yes,
going
yes.
back. See,
Right.
going back to show everybody how far that anterethmoidal artery courses from orbit to the skull base. See this? Going anterior to posterior. Now going posterior, cribriform plate, cribriform plate. My focus is on cribriform plate, cribriform plate, cribriform. See how posteriorly I'm going. The
Yes, yes,
bottom
yes.
line is you don't have to worry when you work anteriorly in the ethmoidal roof. Now see, as we go behind on the opposite side.
Yes.
See this? On
Yes,
the
yes. Very
opposite
clear.
side where you can see where the anatomy is not distorted, the
Anterethmoidal
beaking
artery.
of the medial wall of the orbit. Beaking of the medial wall of the orbit and this orbitocranial canal leading to anterethmoidal artery and nerve to this through this lateral lamella, which is the thinnest part of the skull base here, into the olfactory fossa. So this is the point where the anterethmoidal artery is passing.
Enters.
Now compare to the opposite side. Compare this level to the opposite side. Suppose let me put it here at the same plane. Can you see?
Yes.
In the same plane of the opposite side here, my level of the artery is here, and see how much of the pneumatization and the disease superior to the level of the anterethmoidal artery between the artery and the skull base. Can you imagine?
Yes, yes, yes.
So this artery on this side is intermingled in the disease process. It is lying in the mesentery and it is lying far low below the level of the skull base. See this?
Yes, very clear.
On this side, the artery is definitely running in the mesentery, definitely much, much below the level of the skull base, and that can be a challenge, and you have to be careful. Got my
Yeah.
point?
Yes,
There
yes,
cannot
very
be a
clear.
better situation to deal with anterethmoidal artery than this in a sinusitis condition. On this side, it is running in the bony mesentery. Here, you don't even see any bone. All soft tissues, which is not visible, like an opacity only. The disease artery, all looking like a similar soft tissue. You cannot discriminate here. And now, surgically, you have to be careful to prevent, damage to the anterethmoidal artery. If required to coagulate, we will coagulate in a planned way. The fear. What is the fear here when we deal with the anterethmoidal artery? See this. This artery leaves the orbit from here. If this happens to get transected completely close to the orbital exit, it can retract into the orbit and can lead to
Interorbital hemorrhage.
intraorbital hematoma.
Yeah.
Intraorbital hematoma is something like an emergency you need to deal with to prevent permanent visual loss. It has a potential to give permanent visual loss. if it is not dealt with immediately. So, if this artery happens to retract into the orbit, it can keep bleeding inside. And since the orbit is a bony compartment from all around, it cannot accommodate more than 5 ml of extra blood. And if this artery keeps bleeding, can the pressure can compress on the optic nerve and the vessel supplying the optic nerve and can lead to visual loss. So, you have to be careful while dealing the disease on the side close to the orbit. You don't need to be close to the orbit. Pack mat karna, Ramesh. You need not to be, or you must not to be close to the orbit while dealing with. In case you deal with the artery in the middle of the course here and happen to transact, doesn't matter. You pick your bipolar and coagulate. That's it.
Yes.
But you have to be careful close to the lateral. That is what I am going to show you in this particular case when we get the anterethmoidal artery. Okay. So this anterethmoidal artery, the bottom line is it crosses the anterethmoidal roof most posteriorly. Most posteriorly. See this. The moment I go behind this, the anterethmoidal roof has gone and the postethmoidal roof has started. Can you see? What I am trying to say again, let me show you. This was the artery here. See this? This was the artery here on the left side. Now, as I go behind this level, see now the anterethmoidal roof has gone and the postethmoidal roof has started. Just before that was the cribriform plate. Can you see here?
Yes. Yes. Very clear.
Yeah.
Immediately after that, the cribriform is gone. That means that artery runs through the posterior most part of the anterethmoidal roof. And immediately after that, in few millimeters, the postethmoidal roof starts. Can you see? That is the level of beaking of the artery on this side. This side. You see here? And this is the cell above. See this? On this side. Yes. Now, as you go behind, now the postethmoidal roof starts. See this disease on the right side, expanding the entire postethmoidal compartment.
It's very clear.
On the opposite side, there's a normal postethmoidal cells, though they are bigger than the anterethmoidal cell. See, such a big cell in the postethmoid. As you go behind, this is all postethmoidal roof. See this? The thick postethmoidal roof as compared to the anterethmoidal roof. And because of this thickness, the postethmoidal artery which runs through the postethmoidal roof, we rarely see prominent or we rarely see in mesentery. Because the roof of the postethmoid is normally relatively thicker.
Yes. Very, very, very thick.
Now, the most important part will come in surgery when you work in the postethmoid, as you need to have complete, picture in your mind of transition from postethmoid to sphenoid. So, how to differentiate when that you cross the postethmoid and enter in the sphenoid sinus? Because if you are not very sure, if you are not oriented and accidentally enter into the sphenoid, since the sphenoid has a lot of critical structures running in the walls, you can damage if you are not oriented that you are in the sphenoid. So, you have to be very careful and should exactly know where, when you are working in the postethmoid, that you have not crossed the limits. So, how do you see on CT scan? I will show surgically some catch points, but how do you see on CT scan which is postethmoid, which is now the sphenoid coming? See this bone in the roof? This bone in the roof all the way from pterion to pterion. This is frontal bone. Frontal bone forms the roof of the ethmoids. See this frontal bone forming the roof of the postethmoid. Can you see here?
Yeah.
Now, I am going behind. Now I am going behind. See what is this? The frontal bone is gone. It has left.
It's a sphenoid bone.
Yeah, it is a tilted picture. And see now, what is this bone which has come?
This is
sphenoid. Lesser wing of sphenoid.
That is lesser.
So this is sphenoid. This is not complete from pterion to pterion. Now, once the frontal bone is left and this bone has come, whatever sinus below is the sphenoid sinus.
The sphenoid sinus.
See, this is the rostrum here.
Yes.
This is the, intersphenoid septum, never in the midline. And there is a very, very
Balloon is-
interesting situation in this
Yes,
particular
yes, yes,
patient.
very
Can you
interesting.
see this cell in the cell?
Yes, yes, yes.
So this inside cell, whatever we are seeing, is the postsigmoidal cell.
Yes, synod
And see, whatever sphenoid is, it is pushed behind and it has become very small on the right side. Why? Why? Because see this. This is postsigmoidal disease. Can you see?
Yes,
See the continuation of the postsigmoidal disease. The postsigmoidal cell is ballooning because of the mass effect and going inside the sphenoid. Can you see this?
yes, 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 yes.
So this is postsigmoidal cell in continuity. See, this is postsigmoidal cell anteriorly, and follow
Yes.
this cell. Follow this cell. This is postsigmoidal cell, and the sphenoid is there around. Can you see
Yes,
very clear?
yes, yes, very clear.
This cannot be seen on printout. Imagine, boss, you see this kind of CT scan on a printout given to you. This cannot be correlated so well dynamically, and one can, if you don't realize what is sphenoid, what is postsigmoid, one can, is likely to give injury to the surrounding if it is disoriented. So this dynamic CT is so important. Now, at this point of time, let me reconstruct all three planes to show you what I'm trying to say, the difference between postsigmoidal cell and sphenoid. See this? What I'm trying to say, this is the postsigmoidal cell. Can you see?
Yeah,
See?
much expanded.
See on the sagittal. This is postsigmoidal cell, which is pushed beyond the anterior wall of the sphenoid sinus. See this?
Yes, 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 very clear.
Can you see this postsigmoidal cell?
Yes,
And
Yeah.
push the sphenoid to a smaller size. Can you see?
yes,
See
yes.
this? On the axial also you can see. See this postsigmoidal cell which is pushed so behind on this side because of the mass effect, because of the disease inside. Compared to the opposite side on the axial plane, see how important it is. This is the level of the anterior wall of the sphenoid on the opposite side. Can you
Yes,
see?
yes,
Yeah.
very clear.
See the level of the anterior wall of the sphenoid on this side. See the difference. This is the level of the anterior wall of the sphenoid on this side. Can you see this? And see here the level of the anterior wall of the sphenoid at this level.
Yeah.
Because this is pushed by this postsigmoidal cell which is ballooning towards the sphenoid sinus. Is that clear?
Yes, very clear.
And
Yes.
sphenoid sinus is pushed to such a small sinus. See this?
Yes, yes.
Sphenoid is very small in this particular case. See this?
Yes.
That's what I was showing on the. See this? This is the postsigmoidal cell, and this sphenoid is a very small sinus behind.
Yes.
So you have to be very careful while working in the sphenoid sinus. Now, about there, on both sides are the impressions of the optic nerve. Can you see?
Yes. Yeah.
This opposite sphenoid is more pneumatized as compared to this sphenoid on the right side. And this sphenoid is pushed, whatever it was, by the disease postsigmoidal cell into the sphenoid sinus. The cell entering into another sinus beyond its territory. That's the important finding in this particular patient. So this was a basic, idea of the CT scan of this patient. Anything more if you want in detail, I can elaborate on
No,
any plane.
I think everything is clear now.
Because we have a number of cases of sinus surgery lined up. We'll see in every patient what different anatomies, what different pathologies, and accordingly we'll discuss. So our case is ready for the surgical part. If you say, we can go ahead. Or any questions we can take. Any questions, sir?
Any question? Any confusion? Hmm?
Hello, sir. Hello. Hello.
Yes, sir.
Sir, vital apex looks wider on the right side, sir.
What,
Is it
what?
so, or just an incidental finding? Or vital apex looks wider on the right side.
Orbital
Apex of the
apex.
orbit. Yes, sir.
Okay, let me go to the apex of the orbit first.
Yes, sir. This.
No, it is not wider. The image is tilted.
Oh, tilted, sir.
Aha. See this.
Oh,
This right side image is little posterior than the left side. See on the left side, see this frontal bone disappeared first on the left side
yes, sir.
Yeah.
and later on the right side.
Yes,
So
sir.
this is
Tilted.
little
Image is tilted.
tilted. The right side is coming little behind. So that is orbital apex.
Okay, sir. Thank you, sir.
It is not widened by any disease process or anything. And for that matter, in sinusitis, AFRS and all this, even if it affects the orbit or orbital apex anything, it would rather push and narrow it because of the mass effect rather than widening it.
Okay, okay,
Widening
sir.
will happen when something goes inside the orbital apex and expand.
Yes, sir. Thank you, sir.
Now, these patients, as far as the preparation is concerned, see, we will discuss variety of sinusitis situations. Sinusitis in itself is a complete subject. There are variety of endotypes of sinusitis now discovered, and every endotype has a different underlying pathophysiological process. And this is one of the different endotype, that is allergic fungal rhinosinusitis. So let me wash up and start in a couple of minutes. We'll continue discussing.
Dr. Farooq, can you hear me?
Hello. Sir, Farooq sir is not there.
Okay. Can somebody tell me how the patient presented? What was the clinical history by the time the Dr. Satish Jain starts?
Okay. I will tell someone, sir.
Yeah.
Hello.
Yeah. What was the clinical presentation in this case?
This patient.
Yeah.
This patient had a nasal obstruction, discharge, and some headache also, what they have mentioned.
Right.
And on endoscopy, there is polyposis on the right, in the right nasal cavity.
Okay.
Now, what CTs can we discuss? We discussed with the radiologist earlier number of times and prepared a pro forma for them.
Yeah.
To give details of each and every point we want from our surgical perspective. So we prepared a detailed pro forma for the radiologist to fill in for everything, for all variety of cells, the kind of disease and kind of finding in each and every sinus for the radiologist to fill up. You know, it would take radiologists not less than 1.5 to 2 hours to fill that pro forma.
Yeah.
More than 400 points, and they straight away refused.
Yeah.
Radiologists can't afford to spare this much of time to fill up such a big pro forma. So again, the onus is on the surgeon to understand how to read the CT scan and interpret that from surgical perspective.
I think, Dr. Satish, everybody will agree with you. Interpreting your own CT gives you a better view because radiologist is just concerned with a broad pathology, whereas we as a surgeon have to see nook and corner and all the detailed structure of it.
Exactly, sir. So most of the time the radiologist is blinded with the clinical details
Right.
and they just behave like a clinician, technician to report whatever it is seen on the
Right.
pictures.
Yeah.
So finally, again from the surgical perspective, are you getting the endonasal picture, sir?
Hello.
Yes.
Yes,
Are
sir.
you getting the endoscopic picture?
Yes, sir. We are getting.
Yeah.
Sir.
Yeah.
So this is the primary picture without decongestion or anything. And what I'm doing, the initial preparation. See my initial preparation, I'm using this marrow cell. We have cut marrow cell into 7 or 8 pieces and soaked in saline adrenaline to apply topically. See, just I'm trying to apply the saline adrenaline on the mucosal surface. That's it.
Have you
Yeah.
have you done any dilution?
Yes, this is 1:2.
Okay.
Because this is young patient.
Okay.
In elderly, we can do 1:4 or even more diluted. But in young, we can use even pure topical as well. 1:1000.
But
without dilution.
earlier you don't use to dilute. I think
Yes.
earlier you
So
don't use to
yeah,
dilute.
this young patient 1:2 is hardly anything. But many a times in young patient, we use directly undiluted 1:1000. Because the moment you apply on the mucosal surface, the vasoconstriction prevents its systemic absorption immediately.
Yeah.
So it is pretty safe. The topical application is very, very
Very
safe.
safe.
This is very, very important for the surgeon, this kind of preparation. Why we are focusing on the preparation? And this preparation is just the intraoperative part. Our preparation should begin days or weeks before surgery rather. The idea is to bring the mucosal condition back to normal to deal with this inflammation, ongoing inflammation of the disease to the mucosa, which otherwise bleeds a lot in the inflammatory condition.
But the
So-
response, hello Satish, but the
Yeah.
response of a steroid is so big that most
Yes.
of the polyp disappears most of the
Yes.
time and patient doesn't turn up for surgery.
No, you see, you may have this concern, but you have to tell your patient, prepare accordingly. See that you can operate him right now, but this is not a good situation for the patient's perspective, as it is going to bleed a lot. And in that bleeding, if the ongoing bleeding is too much, it is difficult to identify the landmarks and the chances of complications are more. So we will give some medical treatment to make you absolutely inflammation free, and that will be the optimum condition for surgery. And patient, you have to tell patient that you may feel like not getting operated, but that will be the ideal time to operate upon. So it is the counseling which matters. See this, what I am doing, just topical application on the mucosal surfaces. This is my intraoperative preparation. Pre-operative preparation, like Ashwini boss said, should be to reduce the inflammation, steroid. See, this is inflammatory disease, not infective disease. And polyp is a T helper cell 2 mediated inflammation, purely eosinophilic inflammation, which requires steroid as a tool to reduce inflammation. Steroid is the only way to reduce inflammation in these patients. So that's why the oral steroids work like anything to reduce the inflammation and overall bleeding. The goal is to make the surgical conditions perfect by means of reducing the intraoperative bleeding. Secondly, intraoperatively, what I am doing is one aspect, applying the adrenaline topical to the whatever mucosal surface I see. Rest is done by my anesthesiologist, where I expect the heart rate to be lower, below 70. It was, So our
Is there
anesthetist
is there any relation of resting pulse rate and with the operative pulse rate?
yes. See,
Because they
what I
don't
mean to
agree for
say-
reduction of less than 1/3, more than 1/3.
what I mean to say is if the pulse rate is low or below 60, whatever, around 60, the overall cardiac output would be less.
Yes.
and the overall bleeding will be less, the capillary bleeding. Because this, in sinus surgery, is what you come across the bleeding is capillary bleeding, not the arterial bleeding.
Yes, yes, yes.
Not like tumors. We have a Jain case tomorrow. There you will see the arteries feeding the tumor.
Yes, okay.
This is capillary bleeding, and to reduce the capillary bleeding, the cardiac output is the key factor. Number one. It doesn't mean that you operate in the hypertensive situation. You can operate in the normotensive situation with a good field, with keeping the cardiac output towards the lower side. So that is one of the protocols. Another is, that is again the anesthetist prerogative, what kind of anesthesia they use to prevent vasodilatation. Vasodilatation will invite more capillary bleeding.
Yes.
So, worldwide, there has been a consensus on using the TIVA, total intravenous anesthesia. The beauty is you can manipulate the conditions much better, preventing vasodilatation, using low, acting beta blockers and all that. They use remifentanil and esmolol and other things with all those in the TIVA. But in our countries, many of these things are not available. And you see, a lot of people use sevoflurane, a lot of people use propofol, a lot of people use clonidine. There are many ways to, bring to the same condition. So that is the anesthetist prerogative to get you the best operative condition with least bleeding and less vasodilatation. So can you see the change in the picture now?
Yes, yes.
See the polyps? This cavity is roomy as compared to the other one we have seen because of the DNS and because of the mass effect. The DNS is because of the mass effect, but we are not going to operate on the opposite side at all. This is a strictly unilateral disease, and this disease, as I said, there are a lot of endotypes of the sinusitis. This endotype is different from others. This is purely type 1 hypersensitivity to the fungal antigen to this patient. So, a fungus, we all know, is ubiquitous in air. Whenever we inhale a lot of fungus, and that is expelled by the ciliary activity, mucociliary activity into the nasopharynx and then to the gut and expelled. In patients who are allergic to that particular fungus, if that fungus happens to get entrapped and pushed in the sinuses, can invite the eosinophilic reaction and lead to this kind of a picture. So this is pure type 1 hypersensitivity to the fungal material. And for any hypersensitivity, anywhere in the body, the treatment of choice is steroids. And that's how for this condition also, the treatment of choice is steroid. But see, how can you give oral steroid for longer period?
How much? How long? How long do you prescribe
See, the
steroids?
hypersensitivity is lifetime unless you treat that underlying condition, which is difficult. So you give oral steroid, patient will respond like anything, but in your hearts, the adverse effects of the oral steroids for long run. So you can't give oral steroids in long run, and you have to switch to the topical steroids. And here the surgery has multiple roles in this particular situation. Number one, to remove that fungal material, the antigen, which is inciting this eosinophilic reaction. You will see when we open the sinuses, the fungal eosinophilic material. So we have to remove that antigen basically, which is inviting all this reaction, eosinophilic reaction. So the first goal is to remove the inflammatory load and the entire antigenic stimulation. And number two, to make the sinuses, the opening of the sinuses wide enough where the topical steroids can penetrate and avoid the need of oral steroids in the future. So that is the role of sinus surgery in this particular situation. Every endotype has a different underlying pathophysiology, and you have to deal with that differently. And this is a different endotype, as I said, AFRS. Now, from the surgical perspective. See, the tool I am going to use now in my hand is the shaver, my Jomed micro debrider. Can you see?
Yes, yes, yes. Very clear.
Chal, Neera.
So 0 degree blade, na?
Yeah, this is a straight tri-cut blade, 0 degree blade you can see. And I again congratulate Farooq for this wonderful setup who has a all world-class equipments, the state-of-the-art Jomet micro debrider IPC system, the state-of-the-art Carl Zeiss Vario microscopes, state-of-the-art cobblator, and so many other gadgets here. See now what I am doing is under
Shaving.
vision. See, follow your blade with your telescope so that whatever you see close up. You have to shave the polyps, not other structures. I hope the picture is good.
Very clear. Very nice picture.
See the fungal material in between.
Yes.
Now, with this much of the massive disease, see this, the normal anatomy is distorted in the middle meatus. Normally, what you see here, you see the uncinate process, see the fungal material. See all this fungus. Huge. We have seen on CT scan everywhere what the fungus.
So this is which cell anatomically which cell you are dealing with?
You can't say, boss, right now because the entire anatomy is distorted. That's what I'm trying to say now. See what you have seen your middle turbinate. See this?
Yes, that is middle terminate.
It's pushed medially towards the septum. Can you see?
Yes.
Septum is deviated, and because of this mass effect, the middle turbinate is pushed medially. See here, the most medial anatomy. Now, the uncinate process is one which is, distorted. Now, how to identify the uncinate? Let me tell you.
This is bulla, I think.
Yeah, this could be the bulla which is, ballooned up due to the disease process. Can you see?
Yes, yes.
This most likely the bulla, and now I can see some anatomy coming up in my, which I'm going to share with you.
Now uncinate can be delineated very easily.
Yes,
Very clearly.
yes, because it is pushed. It is pushed laterally by the disease.
Yes.
The uncinate is pushed laterally by the disease. See that?
Yes.
Coming into picture, I will show you. And we have seen in this particular patient, the maxillary sinus is pretty clear. That is hardly affected. If I'm correct, I don't remember. But as far as I remember, the maxillary sinus was pretty clear in this patient. See, that was the bulla which was ballooning. See that?
Yes. Yes. Yes.
Ballooning, and the disease is ballooning the bulla, the frontal recess, and the supraorbital cell area, postethmoids, and further behind. Now, at this point, I will further again apply my Merocell to keep my field good. Topical Merocell you can repeatedly apply on the mucosal surface to improve your surgical. Hope the surgical field is good for you.
Yes, yes. What is blood pressure and pulse rate right now?
Blood pressure is 120 to 78. As I told you, that we are operating, always operate in normotensive conditions.
Okay.
And the heart
Normotensive.
rate or anesthetist is bringing down.
Okay. Presently it is?
Right now is in 90s, but he'll bring it down soon.
It has to be.
See, just apply, never ever press this marrow cell hard on the mucosal surface.
Okay.
It will rather be counterproductive in giving venous congestion.
Okay. That another takeaway point. You don't have to apply
Just
pressure.
apply gently on the mucosal surface to apply adrenaline. You are not applying pressure. That is not our goal. See the field now. Second way is to
Irrigate.
keep irrigation in between. See the saline wash. I hope the picture is good now.
Excellent. Excellent. Picture is excellent.
So that now this is the uncinate process. Why I
Yes.
call it uncinate here?
Because
That's the only. See, this first prominence belongs to the nasolacrimal system.
yes.
See, this is fixed anatomy. And this is the mobile structure. Can you see?
Yes, yes, very clear.
See, this is everted because of the
Disease.
See, this is uncinate. That's the only mobile structure in the entire lateral nasal wall. That's the only mobile structure in the entire lateral nasal wall. And here, what I'm going to do is, I will do infundibulotomy. We call this step, what I'm going to do next is the infundibulotomy. Infundibulum is immediately lateral to the uncinate process. See this. For junior colleagues,
Yes.
this is uncinate. Behind the uncinate was a bulla, which is all distorted. In between them is a narrow slit-like space, hiatus semilunaris, which opens medially into a three-dimensional
sinus.
space, laterally into the three-dimensional space, that is infundibulum, into which the maxillary sinus ostium opens. So what I'm going to do is, I will bite through the uncinate to open up the infundibulum, and this uncinate is the anatomy of the uncinate is important to understand. This is the vertical part of the uncinate. See this? This goes up and forms the medial wall of the agar negi to insert, go laterally further onto the lamina pepracia. That's the vertical part. That's the horizontal part. See, follow the horizontal part. This goes to a variable distance
Yes.
into the inferior turbinate or the perpendicular plate of the
Plate of the
palatine bone.
Palatine bone.
So now I will just bite through the uncinate at the junction of vertical and horizontal part here. See this?
Yes, yes.
Turn your forceps down and bite through. Advance, further advance until you get the hard bone. See now I get the hard bone here. See this?
Yes, yes, yes.
Which I am not supposed to bite through. If I bite through the hard bone, I'll bite through the nasolacrimal system and that would be a disaster. So when you use the reverse biting, you have to be very, very careful. This feel, that is the feel, palpation, the feel of the forceps when you bite through that, it is not biting through the nasolacrimal system. Now at this point, see what I have done, they created this window. This is the horizontal part of the uncinate. See below?
Yes, yes, very clear.
Fracture the horizontal uncinate. Fracture the horizontal uncinate. Gently, and create this middle meatal enterostomy. Can you see now?
Yes, yes.
Now, rest of this you can either remove with your shaver or you can use your through biting.
True, but
Sharp tools have value in sinus surgery in terms of mucosal preservation. See this?
yes.
And creating this middle meatal enterostomy. See this secretion? See this?
Yes, yes. Do you advocate this balloon sinus surgery?
Never, boss. That is, to me, to our concept, doesn't serve the purpose. Our purpose is to remove the inflammation and to give adequate, wide openings to penetrate the topical steroid in future. If that purpose is served by anything, you can go ahead. If that is not, that is useless. So that is my middle meatal enterostomy. What is it? See this? A simple middle meatal enterostomy. I told you the uncinate and the lateral wall here was pushed little laterally. See this? Because of this disease which was ballooning in the middle meatus. See this?
Yes, yes, yes. Very nice.
Interior of the maxillary sinus. We can anytime go back, or if you want later on, I will show on the CT scan the same finding, how the maxillary sinus was pretty clear and how this medial wall was pushed laterally. Now, having done this, the next step, this is the upper part of the uncinate. See the remnant.
Yes.
This is one of the most important anatomy now. Because
Yes.
this is again, we know the uncinate is pushed laterally. Pushed laterally means close to orbit. A laterally pushed uncinate means more closely placed to the orbit. Got my point?
Yes. Very.
And at this point of time, what I'm trying to do, I am removing this upper part of the uncinate to reach to the lateral wall of the entire sinonasal corridor. That is orbit. Our lateral wall of the entire corridor is what? Orbit. See, when we make this entire sinonasal corridor, the lateral limit would be just irrigation. Yes. See this, the lateral limit of this entire corridor would be orbit.
Yes.
This upper part of the uncinate is the closest structure to the orbit,
Yes.
medial wall of the orbit. So while removing this uncinate, be careful under vision. And in this particular patient, when the uncinate is lateralized, it is more closely placed to the orbit. See that?
Yes.
The moment you remove, that is the medial wall.
Yes.
That is the lamina papyracea. See there.
Yes. 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 Very clear.
So be careful at this step. Remove uncinate in toto, but at the same time be careful not to violate the medial wall of the orbit. If you happen to, for junior colleagues, it can be, a sort of depressing thing to get orbital entry at the beginning of the surgery. It can ruin your temperament, but
Nothing to worry.
you have to be able to
Manage it.
manage that. See that the medial wall of the orbit very clear?
Yes. Very clear.
You see the lamina very clear?
Yes.
And see how the upper part of the uncinate is so closely related to the lamina.
Yes.
See this?
Yes.
See, I am removing everything under vision. Uncovering the lamina completely. See that?
Yes. Yes.
That is the lamina. This looks like your Agarnici cell now.
Yes.
All distorted. That's why I'm saying looks like. That is your medial wall of the orbit. Very clear?
Yes. Very clear.
That is your maxillary sinus. This was your bulla, and above that bulla, that looks like your Agarnici.
Yes.
And see all
Yes,
this
yes,
fungal
discharge.
material. All this fungal
We-
material.
Yes. We will get very wide frontal opening.
Yeah, already widened by the disease.
Yes.
Already widened by the disease. After every step, just wait, give some time for the conditions to make the conditions better. See this. This is not wasting time. This is rather saving time, I would say.
He's
Not only
investing
saving time, but saving from complications also. See this. We have done this lower part. We have seen the orbit, the medial wall of the orbit.
Yes.
Now is the time to go up and see the frontal recess.
Yes.
And for that, I will take our favorite 70 degree. This is the ideal telescope, I would say.
Satish,
Yes, sir.
actually there are three types of 70-degree available with the stars. I know.
Mm.
One is sideway, another is downward, another is upward. Which one you
Upward
advocate?
is upward is the sinoscope, downward is the laryngoscope.
No, this is, this is not laryngoscope.
Huh?
No. This is only for sinus surgery.
Yeah.
The light is from side. No, one
Yeah.
in the
I got your
light,
point.
but laryngoscope is different.
Yeah. So this 4 telescope, we should keep the upward pointing for the sinus surgery, I can say.
Yes, because in that you get now your instrument, it will not obstruct the instrument movement.
Yeah, your cable will not obstruct.
Yes, that is a very big point.
Yes. So this is your 70 degree now. सोच का नहीं है है ही नहीं इसको. This is 70 degree here. Can you see? That is 70 degree. You see your medial wall of the orbit very clear now?
Yes, very clear.
Your middle turbinate very clear here.
Yes,
See, the middle turbinate is here, medially.
yes,
The bulla is below.
yes, and that is
Again, see
that is
everything. The beauty of the 70 degree is you get at this point above in the angle all the structures in one view. All the structures
Yes.
means your middle turbinate medially. See this?
yes,
And in the entire work of the frontal recess, I will keep this middle turbinate intact as my medial limit. Got my point?
Yes.
During the
Because-
entire surgery, I will keep my lamina papyracea intact and in view as lateral limit. See this? I will stay between these two medial and lateral limit to go up into the frontal recess. Okay?
Yes.
Now, in order to go up in the frontal recess, I told you during radiology, the frontal recess comes when the beak ends. Beak forming the floor of the frontal sinus, when it ends, the frontal recess comes. Got my point?
Yes.
So, let me show you where the beak is.
Yes.
See, this is axilla.
It's axilla of middle turbinate. Yes.
So, I am staying between this is the simplest way I am telling you to deal with the frontal sinus. Never get disheartened once you see the variety of frontal sinus situation. See this. What I am looking at, beak. See this.
Yes. Looking at the beak.
Can you see the thick bone?
Yes.
See the thick bone there up.
Now it's visible.
Let me clear it. And the bottom line is stay between medial and lateral limits. See, this is thick bone.
Yes.
This is your medial limit. This is your lateral limit.
Yes.
What's my point?
Yes.
Stay anteriorly close to the beak. When you stay close to the beak anteriorly, your anterior ethmoid is miles away. Miles away. That is far behind. See, stay close to the beak. See what I am saying? See this?
Yes. Now enter the frontal.
Stay close to the beak and where the beak ends. See this?
Frontal
Can you see
sinus.
this?
Yes.
That is your
Yes,
frontal.
frontals.
Now see what I have seen above. This is my frontal sinus. See that?
Yes.
This is
Very
thick beak.
Hmm.
And this is the intersinus septal cell medially.
Yes.
In this particular patient, we know from our radiology. What's my point? Now
Yes.
again, reorient yourself. This is my beak, which I have discovered. This is my lamina papyracea. Can you see? I have discovered. This is my middle turbinate. I have discovered. Now I have to stay between these three landmarks and play whatever you want to. See
So
this?
all the landmarks of facial research are very clear.
Frontal recess. So if you stay between your limits, you can't cross them, you can't violate, and you can't give complications beyond. Say this. What? See now where the fungus is coming from?
Frontal sinus.
Frontal. Frontal is up there.
Yes. And inferior one is the part of bulla.
Yeah, in bulla I have left below. We will see later, posteriorly, when we work around the anterethmoidal artery. So now, as far as I am working anteriorly, there is no question that the anterethmoidal artery anywhere being close to it. Because I am working in the anterior direction, anterethmoidal running in the posterior most part of the anterethmoidal root, far behind.
Yes, yes.
Don't get terrified from the beginning about the anterethmoidal artery. From this territory, it is miles away. See now the frontal becoming more and more clearer.
Yes, very clear.
In the simplest way, anybody in the auditorium can do this, keeping this 70-degree, keeping all the three landmarks in view. See this? Middle turbinate, lamina peperecia, this is lamina, this is middle turbinate, and this is beak. Can you see?
Yes, sir.
Just see the frontal outflow, like Ashwini boss has mentioned, it is already going to be wide. See this, all fungal disease we saw on the soft tissue CT scan. See that? See, we are just following the CT scan.
Yes, sir.
This is all fungal disease. See
Will you
this?
will you send it for histopathology, sir?
Yes, for academic purpose you can send. Otherwise, it is not going to make any
Typical of
difference.
fungal disease.
Yes, so that will fulfill your diagnostic criteria as showing the fungal stain positive. दूसरा वाला देना कैसा है 70 change the 70. See the interior of the frontal now. Hello.
Yes, sir. Now we are getting the picture, sir. Yes.
Here comes sometimes the role of hydrodebrider. You can wash off with a water jet more effectively.
That's a hydrodebrider, sir.
Yeah, I use hydrodebrider mostly for this purpose only.
Very sticky in nature.
Yeah, this is pure chocolate butter sauce. You can use a high power suction, you can flush. In between, you can debride to break, whatever. There are various strategies. If you have hydrodebrider, you can remove in less than a minute. This is all fungus.
Yes, sir. Most of the disease has come out, sir.
Why it is still a lot of there. What is this medially?
It's interfrontal cell, sir.
Yes, that is intersinus septal cell. Remember on CT scan?
Yes, sir.
That is intersinus septal cell. See that?
Yes.
So intersinus septal cell narrows the frontal sinus outflow from medially. Side biter, frontal.
It is type 3, sir.
What is?
It is
No,
which
no,
type of
this
cell,
is-
sir?
This is intersinus septal cell. This is not frontal cell.
Okay, sir.
Frontal cells are different. Now I am flushing this cell. Oh. No. Let me wash. See, I am going to flush this cell
Yes, sir.
thoroughly here. See this?
Yes, sir.
See this still fungal debris coming out. See this?
Yes.
Clear?
Yes, sir. Clear, sir.
Now give the side biter. I am using see this what the tool I'm using is a side biter.
Yes, sir.
What a tool. What I am doing, communicating this.
Making a single cavity.
Yes. No other tool can work here. See this?
Sir, how it looks externally? That
Suddenly
instrument.
there is trans illumination.
No,
Ajay,
sir,
that
the
instrument.
instrument, yes, sir.
I will show you. Is that true biting forceps working from sides?
Yes.
Ashwini boss will definitely like this. See this? It's a
Ye-
frontal punch,
Yes,
but
sir.
it's side biting.
Okay, sir.
So you can communicate your septations, you know.
Yes, sir.
And now see how beautifully this frontal intersinus cell, sinus septal cell looks like. I'm communicated so wide to drain into the frontal sinus. You see now?
Yes, sir.
Is that clear?
Yes, sir. Very clear, sir.
Now, still our frontal has a lot of fungal disease.
Hello, Satish. There is another
Yes, boss.
septation. There is another septation lying above. Will you like also that one to connect?
If that obstructs our outflow, let's see.
Okay.
See this disease in the frontal. See there? See, that is scallopings. Can you see? Boss, those are scallopings which need not to be removed. See that? Everywhere scallopings. Can you
And that
see?
is, yes, that is scalloping.
And here, see behind. See, that is anterior frontal sinus. This behind here is the frontal recess. Now see the picture. That is your intersinus septal cell medially. Can you see?
Yes, yes, very clear.
This is your frontal sinus.
Yes.
And
without
behind
stress.
here is going to be the frontal recess. See here going to be the frontal recess. Let me
Yes.
reverse. So let me uncover the frontal recess more. Supraorbital
Or
recess. Sorry.
supraorbital recess.
Yeah, let me uncover this supraorbital recess more. See this? I am using my reverse forceps now. That is the adenoid blade. So-called adenoid blade. See the supraorbital recess now.
क्या गाड़ी का गाड़ी का इस्तेमाल जो लीगली अलाउ है वो है actually this is adenoid blade. Is it
Yes.
adenoid blade? Yes.
Yes,
But
we
it is
never
never
recommend
used
for
for
adenoids.
adenoid surgery. But never use it for adenoid surgery as advocated by Satish
Yeah,
Jain.
yeah, because this is rear facing. It becomes front
Never
facing
use. Never use.
when you use here. Now see how the supraorbital recess is opened up.
Yes, excellent.
I am going with a 70-degree high up above the orbit.
Yes.
See this going above the orbit.
Yes, yes, yes.
This is above the orbit. This is orbital bone. This is above the orbit. That's the supraorbital recess, the frontal sinus, and the intersinus septal cell. Can you see all three?
Yes, yes. It means supraorbital recess is always an extension of frontal sinus.
Yeah, it pushes the frontal sinus medially from laterally. It narrows the frontal outflow from laterally, and this intersinus cell, septal cell, narrows the frontal outflow from medially.
Okay.
And this supraorbital is posterior to the frontal sinus. See? It is always posterior to the frontal sinus. Let me completely uncover this because this is a huge recess. See how big would be the drainage pathway now and how big would be the pathway for penetration of local steroids also, topical steroid also. That is more important. Reverse. Reverse. See this?
Farooq, Dr. Farooq is there? Is there?
Yes, Farooq is there in the OT, boss.
No.
Boss?
Yes. Today we have not seen any blockage of your suction. That's why I am more interested.
Yeah.
Why today there was no complaint of suction till now. But most of the time you will always complaining
That
of
is the
suction.
best thing. I always look in wherever I go for operating. The first thing I see
Inquire
is
for the
suction.
suction. And that is the question, which suction he is using.
See now, the supraorbital recess completely flushed.
Yes, absolutely absolutely wonderful.
That is the beauty of the reverse blade. Now, still, see this. The entire
Yes.
centimeters wide opening we have made and we have not uttered a single word, discussed a single thing about the anterothymoidal artery.
Yes.
Absolute fearlessly we have done.
Yes.
The reason
is-
is we are working far anteriorly, and I told you the anterothymoidal artery comes,
Behind the front.
runs through the posterior most part of the anterothymoidal roof.
Yes.
This is frontal.
Yes.
Supraorbital cell, frontal sinus, supraorbital cell laterally here, frontal sinus anteriorly here, and medially this intersinus septal cell. Everything clear.
Yes.
We must know when we deal with the frontal sinus, we must know the cellularity, the drainage pathway, and the orientation by a dynamic CT scan. Now see what we have seen below. That was the remnant of bulla. We didn't bother about the anterothymoidal artery as long as this bulla was intact. See this?
This is intact bulla technique.
Because my anterothymoidal artery is covered by this bulla
Yes.
from anteriorly. See, this is our maxillary sinus.
Yes.
With 70 degree, I am showing the interior of the maxillary sinus. See, this is absolutely perfect.
Absolutely perfect. Except.
See, this sinus is
Yes.
fine.
Yes.
That is the orbital surface. That is the lamina papracia.
Yes.
And now, if I rotate, this is your bulla. See, we have done the entire frontal sinus work and didn't bother about the anterothymoidal artery at all.
Yes.
Reason being, I have left this bulla intact. See this. Now, once I elevate, we'll show you something at the skull base. Correct.
I think this intact bulla technique was propagated by Dr. Sethi from Singapore.
100%. I always remember he propagated lot many concepts of sinus surgery in our country by a number of workshops, almost more than a decade before,
Yes.
almost for 2 decades. See this.
Yes.
This I am taking out. That is the bulla, and that is the upper attachment of the bulla. Can you see?
Yes.
There. Now see. Because this
0
was
degree.
distorted. This was distorted.
Yes, yes, this was distorted. So this is bulla, na? This is part of bulla.
it. Yes.
Yeah. Some extra smart
There
say.
is some bone in it. So it comes. See this. Lot of fungal disease around. I told you in this region. From CT scan. Lot of fungal disease here.
Most important question That's not me.
See this fungus.
Anterior model set. These are all part of anterior model set.
See, lot of fungal disease behind.
तो सर posterior sphenoid में
Yeah, I am going toward the anterothymoidal artery territory. See this.
Yes. This is all part of
That is the upper attachment of the
bulla. Upper attachment of bulla.
yes. See how much of the fungus around. This is still the bony cell.
बुल्ला ही मिलेगा याद रखना
And on.
then we make it multiple cell
Yes. See so much of the fungus removed. Give me a through cut. Now I will take this through cut to take away all these bony openings. That is the upper attachment of the bulla. See what I have broken. This upper attachment of the bulla to the skull base. पकड़ नहीं रही. See, this is the upper attachment of the bulla to the skull base. See this? All upper attachment of the bulla to the skull base. Through biting. Now I will look at the roof after removing this bony remnants. See all these bony remnants. This is through biting. See, it cuts like butter. This is Karl Storz through biting. My favorite. Flushing with the lamina laterally. All these cells with so much of mucosal disease. True biting and microdebrider is preferred at all these places because it is mucosal preserving. You don't pull anything, you cut. You pull anything, can lead to problems. Can make the mucosa, pull the mucosa, and that is the region of the anterethmoidal artery. Let me uncover this completely. Yes. Can you see this beaking of the orbit here? Hello?
Yes, yes, dear.
This is the beaking of the orbit.
Yes.
And 3 here, the vessel is going towards the lateral lamella.
Lateral.
Reverse.
The anterior
And this
thmoidal
is
artery.
always caudal to the supraorbital recess. Always.
Always. Yes.
This was our supraorbital recess. And immediately caudal to that is
Anterethmoidal
anterethmoidal.
artery.
Yes, exit. I am using my reverse again.
यहाँ पे ध्यान देना स्कोप जो है ना
See, this is supraorbital recess. Very close up view.
पिक्चर नहीं देता है ठीक है कैमरा तो ऑटोमेटिक पिक्चर देगा जैसे दिखाई पड़े वैसे कुछ नहीं होगा
So flush all these septations at the level of the skull base. If you leave these septations, this becomes avascular bones and can invite infection. Always flush them and leave everything covered with mucosa. More and more mucosa preserving. See that?
Yes.
That is complete, anterethmoidal skull base work. See, so far, this work now I have done with the 70 degree.
Oh, it's wonderful.
Wash. Wash. This is all done with 70-degree mob them. So you don't have to terrify yourself with a vessel or anything as long as you have gone through the CT scan. You know where what is related to, and this is the final picture of, see that wide opening. This is supraorbital cell.
Yes.
That is the
Supraorbital cell or supraorbital recess? This is supraorbital cell, no?
cell, quite deep. It is not a shallow recess. Had this been shallow, we would call it recess. And that is your, you can see the vessel running if you want to see.
Yes.
Can you see?
अब काट के मत दिखा देना भाई. यहाँ palpitation हो रहा है लोगों को.
Nothing will happen. Only thing, it should not be transected close to the orbital exit. Reverse. Don't worry about. If it is transected in the middle of the course, see this? Nothing will happen. You can just simply bipolarize. Because we intentionally transect it many a time in a skull-based surgery, in transcribiform approach.
Yes, you have to transect it. There is no way out.
Now it is very clear. So now let's change to switch over to 0 degree now. There has always been discussion about the final required size of the frontal sinus opening. There is no final size in terms of millimeters or centimeters.
Yes.
It should be flush to the limits. That's it. Whatever size, final size will be dictated by the size
the
given by that size of
anatomical
that
situation.
anatomy of that particular person. See that?
Yes, yes.
The frontal above with the 0 degree. That's the Porteous model cell where we remove the fungus from. That's
There's
the
small
additional
fungal
artery.
wall right there.
And now the work posteriorly, that is very, very crucial. And in this patient, it is very important. Now, before going behind, what I will do, I will define a landmark. See, I will define a landmark here at the medial orbital angle. And that is the orbital floor.
पोस्टर में गई वॉल दिखाई पड़ रहा है. ठीक है, देखो उसका पीछे जो एक्सटेंशन मीडिया जा रहा है ना, इसको वो लोग पोस्टेरो मीडियली कर सकते हैं, या ये जा रहा नहीं. ठीक है, ऐसे करके. ठीक है, ये तुमको वही होगा अपर लिमिट ऑफ.
What I am trying to define here is the orbital floor.
That is the limit of the same that vascular sinus of most of the उस लेवल पे, उसी लेवल पे मोस्ट ऑफ द टाइम रहता है. लेकिन याद रखिए ना, दीज आर रिलेटेड एनाटॉमी है ना, मोस्ट ऑफ द टाइम विल बट नॉट ऑलवेज. ठीक है, तो इस अगर याद करो कि इसी के सामने ही हुई होगा, मैं विल डू द डैमेज. ठीक है, वो नहीं करना कभी भी नहीं. वहां पे भाई सतीश ने बताया था किसी लेवल पे होगा.
See now,
मोस्ट ऑफ द
what I am trying to define here is the orbital floor. Orbital floor is a wonderful landmark.
Orbital roof. Orbital floor. Sorry, yes, orbital floor.
Or maxillary sinus roof.
Yes, maxillary sinus roof.
See, that is the level. And that is a level important for many regions.
Yes.
When you work behind, because when you go behind, our concern is not to accidentally enter into the sphenoid sinus and damage the structures there. So this landmarks helps you all the time how to go behind at what level. See this. That is the orbital floor. There was some osteotic bone which I have removed. That is your medial wall of the orbit. You can see. See this? Completely widened for free flow of steroids, topical steroids later on. See this? Now, where to enter into the ground lamella for the posterior and at what level you look for the sphenoidotomy. For these 2 points, this orbital floor landmark is crucial. So first of all, where to enter? And see, this is middle turbinate. See this?
Yes, very clear.
This is a very good landmark. Always respect it, and the best respect for that is stay away from it.
Yes.
Stay away from it. We never bothered about the middle turbinate all the time. We kept in view, but did nothing to it. Now see, I'm entering into the posterior here at this point of the level of the orbital floor. See this?
यही था बेस लैमेला, यही अभी जो कटा ना, यही होगा बेस लैमेला, यही
and go medially. Stay medially. Stay medially here. See this? All this distorted bone. This is your superior turbinate. Can you see?
Yes, yes, very clear.
And medial to that is the nasal septum. See, this is nasal septum.
That is
See, 2 important anatomies here. Before completing my posterior work, I know this posterior cell is pushed behind. I may get disoriented while entering into the sphenoid sinus if I am not aware of it. So what is the safest entry to the sphenoid? At the level of orbital floor, go between the middle turbinate and the septum. See this?
Yes.
This cell has gone far behind. See this? Keep an eye this level of the orbital floor and see the septum there medially. Middle turbinate undisturbed.
Yes. You can remove the remnant of the superior turbinate in the lower third. Now, where to enter for the sphenoid sinus and why to look for the sphenoid first without completing the posterior thyroidectomy? The reason is I have to make a medial entry into the sphenoid sinus through the ostium. Yes.
And this level of the ostium is always anterior to the critical structures.
Yes.
Whatever optic, carotid, whatever malformation there. See now the instrument I am using, suction periosteum elevator. Now, what is the value of this landmark? If I go above this level, suppose, and look for the sphenoid ostium there, sphenoid ostium is never along the floor.
Yes.
It is more closer to the roof as compared to the floor.
Floor, yes.
If I don't take this landmark in consideration and look for the ostium up there, I can enter into the planum sphenoidal.
Yes.
And can get a CSF leak. That's a disaster. So, see this level. Stay in this level or below and slide. See this. Slide along the septum.
Yes.
See this.
Yes.
Slide along the septum and I am in the sphenoid sinus. Can you see?
Yes, very clear.
That is sphenoid. See that?
Yes, yes, yes.
Glide along the septum. That is most important. Don't glide along the turbinate.
Glide. Yes, glide. You better go to
glide along the septum in the plane of the maxillary line. See that?
Yes.
Having seen the ostium now, Now, and see the ostium and the interior of the sphenoid.
Yes.
Having
Too
seen
soon.
them now, you can remove anything anterior to it. Now you got your level. See my point?
Silver
I
up.
can now remove anything anterior to it. See the
एनाटॉमी
cell.
सेल था ना तुम्हारा जो ओनोडी सेल था ना पीछे उसके ऊपर से ऐसे जाना जो साइड वाला क्या ना
Now my job has become much easier.
दिस इज नॉट पार्ट ऑफ द स्पिनर अरे ये जो सामने से कोई हट रहा है ना
Now my job has become much easier.
यस
See, that is the post-sigmoidal cell.
यस 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 दैट इज पॉसिबल
It's on CT scan.
is trying to remove the bone बन ठीक है
And now mucosa I can divide. If you pull the mucosa, that will give raw area.
पूरी एनाटॉमी कर ले तो सीटी स्कैन से दिस इज पार्ट ऑफ पोस्टेट साइनस ठीक
See,
है
that is the bone which was extending behind. Remember?
Lateral to the sphenoid side.
And frontal, the
Laterally
sphenoid
था ना,
sinus is
laterally था ना
the
तुम्हारा
small
cell.
sinus on this side. We remember.
बस वो नोडी सेल नहीं वाला ऐसे ही मुझे प्रॉब्लम
See now? Things are becoming more and more clearer now.
yes
See, maxillary sinus, this was the post-sigmoidal cell which was pushed behind. And see medially the frontal sinus. Sphenoid sinus. See all sinuses in one view. Give me, Harrison. Now I will punch out and widen this opening. You can use Stemberger punch.
Hello.
You can use Harrison punch. You can use a side biter. Side biter means a side through cut biter.
which
Or you
instrument
can-
which instrument you prefer
Anything
Punch.
depending upon the,
availability
Hello.
here let me show you. I am using a Harrison. You can use anything. You can even use a drill if it is too thick a bone.
no
But the Stemberger punch is also a good alternative. See the opposite sphenoid sinus here.
yes
Can you see?
yes 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 yes
See the opposite one.
yes
Hello.
Because this sinus was very slow. And see, I prefer a medial opening. When you work in the sphenoid, stay as medial as possible.
ये क्रॉस सेल नीचे में भी उसके नीचे यहाँ पे ये है पा ये
See
है
the sphenoid below, the
Yes.
smaller one.
यस 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 हो गया ना टाइम पूरी क्लियर ना
Hello.
या
Can you see very clear?
yes very what is that rounded projection there in the opposite sphenoid
Yeah, I will remove this. This is the anterior part of the anterior wall. And widen. See how the sphenoid was pushed by the post-sigmoidal cell. That's what I was again and again telling you during the CT scan. I knew from the CT scan how it is going to behave. Now see the beautiful sphenoid from this side. Okay, there. See the sphenoid on this side
yes
or the sphenoid on the other side? Is that very clear or not?
very clear no doubt
That is opposite side. And this side has become so small
नहीं यार,
because of that cell. That we knew from CT scan also earlier. And now see all walls flushed, completely flushed. So that completes our sinus surgery on this side. We'll just give it a complete wash, flush it.
हो जाएगा.
Our next case is induced, probably. And that's a hemithyroidectomy. I suppose. So one table will keep endoscopic cases, other table for other cases. See, everywhere it is mucosalized. Can you see?
Yes, yes, very nice.
Now, what we have achieved, you see in your office, in your OPD, with 0 degree, and you can see all sinuses in front of you.
Yes, wonderful. That's
No,
superb.
no need to get CT scan or anything done for this. At the same time, it gives you opportunity for the topicals to push
Each
inside.
everywhere.
Yes. That is more important a goal over there. So this kind of work if done, what all is needed for the patient for the future is to treat for allergy by means of immunotherapy, topical steroids, whatever. Even suppose in the worst of the scenario, patient lost for the follow-up and doesn't do anything and develops the polyps again because of the same underlying pathophysiology. Since the bone work is completely done, this is full house test. We have already reached to the limits. See everywhere?
Yes, yes.
The skull base behind the orbit laterally, the skull base medially, everywhere. Everywhere we have reached to the limits.
Satish, Dr. Satish, please show some important structure of the sphenoid sinus.
Yes. So what I was trying to say, since we have reached to the limits everywhere,
Yes.
in the worst scenario, the patient lost to follow-up, doesn't do anything and develops polyp.
Just
You can
use.
just spray and debride the polyps and again start the topical steroid. That's it.
Yes.
A patient will never require a formal sinus surgery again.
Yes.
So nothing is already flushed to the limits. Nothing is left for the future sinus surgeon to do any kind of bone work or anything.
Hmm?
No
Yeah.
bone work is left for the
This is
future surgeon.
comprehensive. Comprehensive first.
Now see inside the sphenoid.
Some important structures.
Yeah, here, since this side of the sphenoid is not very big,
Yes.
what you see, the intersinus septum is eccentric coming to this side.
Yes.
This is the clival recess.
Okay.
This is the sala. And above here should be the optic, which is hidden over here. And we don't intend to see that.
And what is the vertical structure going in the right sphenoid? Right. In the right, there's a vertical structure.
Yeah, this is the lateral wall, part of the lateral wall. Since it is very small, the structures are not prominent. We will see in the next cases where we see a big sphenoid, you will see all structures there.
Okay.
More than pneumatized sphenoid,
Better than
more prominent would be the intrasphenoidal structures. So that's the final picture.
Yes, wonderful.
So we leave it here. We'll pack it with the same aerosol pieces, remove them after a day or two, and then topical steroid is start. Now this patient, what all this patient requires is a topical steroid, nothing else. This mucosa, most of the mucosa is preserved on the wall. See,
Yes.
if you try to remove the mucosa, you have removed the mucosa. Why this surgery is called functional endoscopic sinus surgery? Because this function is served by the mucosa, that is mucociliary clearance.
Will you do septoplasty in this case because of DNS? For
Not
DNS?
really. Not really. The reason being, this is a strict unilateral disease. I don't want to implant anything on the opposite side at this stage. It is rather recommended not to do any septoterminoplasty for the opposite side in these strict unilateral AFRS. Secondly, what I was telling, if I happen to remove the mucosa, suppose
Sometimes,
yes,
sometimes I have seen you removing the middle turbinate in cases of AFRS.
yes.
So
If it
what is that indication? When do you remove the whole of the middle
This middle
turbinate?
turbinate was behaving like a good boy.
Good boy, yes.
It was already
So
placed
good.
close
Good
to
boy
the
should never be
septum.
punished.
It was not a floppy one. What we want for the future, for this surgery to remain successful, a topical should penetrate deep into the sinuses uninhibited. If your turbinate is floppy and it becomes a sort of obstruction, or it can become in future, for the topicals to penetrate, better you do a partial resection. Because in any case, our goal is to make the topicals penetrating deep into the sinus. Then only in that situation you can remove it. Secondly, what I was telling, that mucosa, all this mucosa should be completely preserved as much as possible. Because if you don't preserve the mucosa, the raw bone will be inviting the crusting, infection, lot many things, and then it will heal by secondary intention, and then the function will not be served. So it will all be a problem, and then it will not be fess, it will be mess.
Mess.
So
Question?
preservation of the mucosa is the key for a better outcome, successful outcome. And
Nanoplasty surgeon से पूछे पड़ेगा.
Excellent demonstration, Dr. Satish, as usual.
thank you,
Hello,
sir.
Dr. Satish. Hello.
Yes, sir.
Dr. Satish,
Yes, sir.
it was an excellent demonstration as usual. You make it look so simple to do, and it's really very simple.
Thank you,
Really
sir.
very
Thank
simple.
you. It is not difficult, sir, if you follow the
Yeah, in your hand.
Satish, Dr. Satish.
Ashwini, it
There
is in the hand
is a
of
question
Dr.
from
Satish.
audience, boss. There is a question from audience. Dr. Satish,
Yes, sir.
it is not related to face, but what is the lower limit of septoplasty in today's scenario? Today's
What is the lower limit means?
lower limit of age for
Age,
septo.
see, age is not a bar. As far as you do in younger population, a limited work, a pure strict septoplasty, not SMR. So if obstruction is the indication, we have done even in 4-5-year-old children for obstruction. But a limited septoplasty, not a extensive work, or not SMR for that matter.
But most of the time, people say that we are doing septoplasty. Actually, they are doing SMR. This is the real situation, no? People
if
start with
obstruction is the indication, you have to clear
people
obstruction.
start with septoplasty, and it gets ultimately converted into SMR.
Yeah, but in children, doing SMR can be harmful, because the ossification center in the septum in children, particularly in the upper part, can be something hazardous for the rest of the growth, and it should be avoided. But a limited septoplasty, correcting only deflected part and replacing it back, can be a good option to open up the airway.
Okay.
So, any question before we move on to the next one?
No, sir.
Hello.
Yes, sir.
Yes, sir. Any other question before we move on?
Then actually, there are a lot of PG students here, and they want some question to be asked from you, and they will try to answer it.
Okay, you want me to ask the question?
You ask the question, and they will answer it.
Okay. So my first question is not about the simple or difficult. What is the indication for surgery
Only for PGs.
only for PGs? How can you clinically decide when this patient requires surgery of a sinusitis case with a CT scan and endoscopy picture in your hand? When to go in for surgery and when to go in for conservative management? What is the, dividing line? How do you decide in a clinical practice? Because ultimately, you being a clinician is going to take a call whether this patient will require surgery or not. Because not understanding this fact is a problem. Not many patients requiring surgery are being unnecessarily operated. And many of these patients who require surgery as an answer are being unnecessarily treated with steroid or antibiotics.
Good morning, sir. It's Dr. Navles from the DMC final year, sir. MSc
Hi,
ENT
dear.
final year. Yes, sir. So basically, if the patient is having nasal obstruction, symptoms of nasal obstruction, then conservative management will not suffice. That in that case, we would like to do surgery, sir.
We are talking of sinusitis, not DNS. So, on the endoscopy, what you are talking about nasal obstruction, what is the endoscopic finding?
There will be, sir, inflamed mucosa, sir. So it may lead to obstructive symptoms, sir. And there will be heaviness in the maxillary area because of the closure of the osteometal complex.
Our sinus surgeries aim to improve the ventilation and drainage of the sinuses. At the same time, removing the inflammatory load of the sinuses. At the same time, allowing the topical steroid to penetrate into the sinuses. You said the patient has obstruction, how sinus surgery is going to help him with congestion. Sinus surgery is not aimed to relieve congestion or to improve the nasal obstruction unless there are polyps obstructing the nasal cavity. That's why I asked, what is the nasal endoscopy finding?
Yes, sir. Thank you, sir.
Anybody else? So, what I mean to say, why I asked this question? We should be very clear in our mind which patient requires sinus surgery and which requires conservative management. The reason being, those require sinus surgery as an answer should not be unnecessarily treated by antibiotics, steroids, or XYZ drugs.
Sir, excuse me, sir. Sir, does inspissated thickened mucus secretion refractory to medical treatment is also an indication of surgery?
See, surgery is not based only on the clinical findings. Yes, clinical findings are important. At the
Yes, sir.
same time, you have to corroborate with endoscopy and CT scan.
Okay, sir.
Now, tell me, patient is yours, findings are with you. What are your findings to take a call for sinus surgery? All three.
Sir, one will be, sir, inspissated thickened mucus secretion collection of eosinophilic mucin.
On endoscopy.
Yeah, sir. Yes, sir. On endoscopy and radiologically also, sir, secretion or pacification involving maxillary sinus and all.
Okay. With no polyps?
Sir, with polypoidal, sir, polyposis changes.
Polyps in the middle meatus or not?
Yes, sir.
And patient symptomatology.
Sir, patient symptoms will be like, sir, nasal obstruction and sir, heaviness in the maxillary and antrum area, maxillary area.
Hmm. See now, let me elaborate your point.
Okay, sir.
All these things you have mentioned is important. Now, how to take a call? Such patient who has a opacification, some eosinophil secretions, on endoscopic, some polyposis, how to take a call for surgery? If such patient is coming to me, and if I give him a course of oral steroid for say 2 weeks,
Yes.
he'll be relieved of all his symptoms.
So, excuse me, sir. Which one will which steroid will prefer?
Yeah, prednisolone, simple.
Prednisone. Yes.
So if that patient, your patient, what you have seen and what you have recommended surgery,
Yes, sir.
if that patient happens to come to me with all these findings, with
Okay, sir.
minimal polyposis, some opacification and some symptoms,
Hmm.
if I happen to give him a course of oral steroid, an oral steroid will definitely improve him, like anything.
Yes, sir.
And he'll be grateful to me and he'll go back to you and curse you that you are unnecessarily operating on those patients. That doctor is much better. He's treated with the drugs only. He's too good. How will you deal with him? See, if I give oral steroid and the oral steroid tackle the inflammatory load and he becomes symptom free,
Okay,
that
sir.
is not the final answer. My take for the surgery will come if the patient becomes symptom free with the oral steroids and then you switch on to the topical steroids. Now, if his inflammatory load is less and can be tackled with the topical steroids only, you don't need surgery. If he again becomes symptomatic, if the again problem reverts and requires or needs oral steroid against to control his symptoms, you can't give oral steroids again and again. So the patient for the surgery, the candidate for the surgery would be the one who will who will need or who requires oral steroids again and again in say 2 to 3 months. A patient needing oral steroids again and again to control his symptoms is the candidate for sinus surgery,
Okay,
so that you can convert the need to from oral steroid to topical steroid.
okay, sir.
That is the indication.
Thank
It's
you, sir.
not that first time you see and
Yes,
advise
sir.
surgery.
Okay, sir. Thank you, sir.
Sir, good afternoon, sir. Sir, in the previous surgery, sir, yes, sir, you removed the debris, fungal debris from all the sinuses. But is there any role of septoplasty after removing the debris, or the septum will come to this normal position after removing the these?
Yeah, you can expect a little bit,
Yes, sir.
but see, once you treat the inflammation, now the overall inflammatory load has been reduced.
Yes, sir.
Now the topicals will penetrate better and the inflammatory condition will become better.
Yes, sir. So for how long we should give the topical steroids, sir?
That depends upon the pathology, the allergic
Yes, sir.
reaction.
The
That
reactions.
you have to monitor. You can start with the topical budesonide, then as the healing, takes over in
Yes.
6 to 8 weeks, you
Yes.
can keep reducing the doses,
Yes, sir.
the strength of the topical, the doses and frequency, and keep a close monitoring on the mucosa with a 0 degree.
Oh, sir.
If the mucosa remains good with
Yes.
the even after reducing the steroid, you can keep reducing.
Yes.
The moment symptoms come, you have to increase the dose. See, now the final regulation will be with a topical steroid without a need of oral steroid. That is the beauty which we have achieved through this surgery. That's why we have operated upon this patient. That is one of the most important goal now, to make the topical steroid penetration. वो हो गया पहले वाला Hmm. Hmm. Devendra. Hmm. ऐसा ना समझ गया बढ़िया अल्टीमेट पेपर बहुत बहुत ज्यादा बहुत अलग फाइंडिंग है तक मेहनत कर सकते हैं और भी टाइप की नाम देना हम्म पेट्रोल पंप ये वाली बिस्किट कौन सी वाली कोई फिक्स नहीं है दूसरा ये हो गया फोटो लेता है उसके बाद अब जो नेक्स्ट कौन सा लेंगे यस ये इसका कौन ये चूप ठीक है इसकी एंडो फाइंडिंग क्या है इसकी एंडो है पॉलिप्स है पॉलिप्स पॉलिप्स है पॉलिप्स है ना हाँ जो अनयूजुअल था बस वो मैंने बता दिया तो बाकी सब नॉर्मली सर हेलो जी हम्म तो मॉड्यूल है ना Ramesh? Hello? Hello?
Hello. Yeah, yes, sir.
Yes, sir. So our next case is already induced, prepared to demonstrate the surgical steps of thyroidectomy. Though this patient is planned for hemithyroidectomy, having a solitary thyroid nodule on FNSC's Bethesda category 3, sonography again not showing any classical features of malignancy. All these investigations are important. See, in thyroids, the main role of surgery, minimum magnification है क्या ये? ये minimum magnification. In thyroids, the role of surgery is to remove those solitary thyroid nodules which are either malignant or doubtfully malignant or potentially malignant, whatever. So selectively remove those, not to remove every thyroid swelling. That's why workup is very, very important. And since this was a hard nodule in the middle-aged patients, the doubt of malignancy is always, looming around. Are you getting the picture there, microscopic picture?
Yes, sir.
So this is microscopic picture. This is superior. This is inferior to reorient you. This is on the right side where I'm standing, and this is on the left side, and this is the solid nodule on the right side. Can you see this? Hello?
Yes, sir.
Now, once it comes to surgery, thyroid is a fascinating surgery in terms of preservation of the certain critical structures to improve the quality of life of the patient, to improve the overall outcome. Number one is the recurrent laryngeal nerve. Preserving recurrent laryngeal nerve is important to protect the voice. Preserving parathyroids to prevent hypocalcemia. A permanent hypocalcemia is more hazardous than the disease itself, than the thyroid disease itself. And external branch of the superior laryngeal nerve also, which has an impact on the overall voice. So all these structures are running in close vicinity of the thyroid. So removal of the thyroid lobe requires identification and preservation of all these structures. As I said, why we are operating on either malignant, potentially malignant, or doubtfully malignant lesions. And in case after this hemithyroidectomy malignancy turns out to be malignant, most of the malignancy are well differentiated cancers, and well differentiated thyroid cancers are amongst those cancers which have best long-term prognosis if properly followed up and treated post-operatively. So in case the malignancy, it turns out to be malignant, you have to convert to a total thyroidectomy. That's why intraoperative frozen has an immense value sometimes to dictate not only total thyroidectomy but the neck dissection as well in case the malignancy turns up. So that is a different point of discussion. Here we are going to discuss the surgical, steps of thyroidectomy. So in the midline, I'm in the midline. This is up, this is down. What you see in the midline, the anterior jugular veins. Can you see? So am I audible?
Yes.
Between the anterior jugular veins, see this, lift this subcutaneous tissue. Lift this subcutaneous tissue into the midline raphe. Lift up this subcutaneous tissue. Yes. Now, once you lift, you can automatically see the midline raphe coming. This is important to ascertain to avoid unnecessary injury to the muscles. Can you see the midline raphe opening up?
Yes, yes, very clear.
And see at this point, leave this. See this.
This is the
See this raphe on other side. This lateral muscle is the sternohyoid muscle,
Yes.
and this is sternohyoid muscle on this side. This is sternohyoid on the opposite side, and see the midline raphe. So first goal is to enter into the right plane, that is into the midline raphe.
So this is your midline approach. Now, some people advocate lateral approach for thyroid
Yeah,
surgery.
there are many ways to do the same thing.
So when
What
do
we
you like to
believe-
that?
Yeah. What we believe, this is a simpler approach for the novice surgeons. See this. This
Yes.
lateral muscle is the sternohyoid.
There is muscle also inside. There is also another one muscle.
The deeper muscle,
Sternothyroid.
based on the thyroid. This is thyroid gland. See, this deeper muscle is the sternohyoid. This is more fan-shaped muscle spread all over the gland.
Is there any precaution to be taken when we are dividing the lower end of a sternothyroid?
Lower end of?
A sternothyroid?
Nothing.
When we are splitting this, sometimes there is a vein that comes.
So you take veins, they join below. Yeah. So that way you have to be careful. Now see the surface of the gland very clear now?
Yes, very clear.
Now I am getting muscle. See this now? See the first layer of muscle is here. See this.
Yes.
This one. And this is the second underlying muscle, that is
Thyroid.
sternohyoid. See that?
Yes.
Now I am getting deep to the sternothyroid. Can you see?
Yes.
This is an important step to get into this plane. See this? You
Yes.
can open up this plane to work blunt with your and get into the paratracheal
But
avascular plane. See this?
yes.
I have delivered this, out. Only thing, sometimes there is a middle thyroid
Thyroid
vein
vein.
which can come across, and you have to deal with that. See now?
Middle thyroid vein is generally very small and very short. Precise like it.
Yes, but it is not always there. See now? I am getting into the paratracheal plane. See this?
Yes.
See? Opening this plane blunt. Such a huge solid nodule. See this?
Yes.
Bipolar secretary. Hello, everybody.
Yes, everyone.
See?
Hall is full.
Such a huge solid nodule. Bigger the nodule, bipolar. I hope the picture is good.
Very good.
Bipolar नहीं चल दिया. Somebody bipolar, please. So bigger the nodule, more will be the prominent veins, more will be the overall surface oozing. And you have to be prepared. Bipolar is a good tool. Harmonic scalpel is a good tool in this surgery. It saves your time as well.
Not working.
Yes.
Surface vessels should never be monopolarized.
Yes. They open up the vessel.
Surface are very, very good.
See this? Avascular paratracheal plane. Yes. Sometime, if your nodule is big, gland is big, you can give a cut on this muscle. A release incision on the muscle. On this, I can always cut these muscles to get into the plane much better. See?
Yes,
And
yes.
if you have to cut this muscle, always cut from above.
Yes.
Because these muscles are supplied from below by the lower division of ANSA,
Survive.
lower
Yes.
loop of ANSA hypoglossal.
Thanks a lot.
So if you want to cut, you can cut from above and re-approximate later. If you want to.
This is carotid, na? Inside a structure.
We'll see. Let me first get a better hemostasis. Put it down. We great vessels, lat. या इधर भी दो नीचे हम नेटवर्क लगाना है इसको इधर से आ रहा है देखने देखने तो लगा watch please. See veins on the lower surface as well. पकड़ So now the conditions are much better. The picture is much better. Field is much better. See now. See now. We are trying to get into the, or we are rather into the avascular paratracheal plane. नहीं रखते यार कवर कर ले इसको कवर विद yes. Now see if I get into this plane. See this? See this avascular plane? If I open up this plane, this is avascular, and now I will see the great vessels.
Yes.
See the carotid artery?
Yes.
As I mentioned, we need to protect certain structures. We need to protect certain structures, and recurrent laryngeal nerve being the first one. How to identify To do that, we need to find certain more structures as landmark. See, this is part of the step muscles. क्या हुआ बंद क्यों कर देते हैं मोनोपोलर बंद हो गया चौड़ा तुमने Oh. Exposure of the paracecal region. I hope the picture is good.
Very good.
Now, the first thing I want to see here in the middle of the neck, a horizontal structure coming from deep to carotid is a vessel known as inferior artery.
Major thyroid artery.
First, oh, can you see the carotid artery below here?
Yes, yes, very clear. Very
See,
nice.
this is carotid artery now, better, you can see. See that?
Yes.
Now, the first structure I want to see now, and that's the beauty of the microscope. The artery is same here. Artery is not good. See this? It's already. I can see this vessel. Yes, you see. This is inferior thyroid artery. Can you
Yes,
see?
yes, very, very clear now. Excellent.
So, for junior colleagues, the first structure we need to see is the inferior thyroid artery for many reasons. One, this is principal supply,
Parathyroid.
but to the parathyroid. This gives vessels to the parathyroid and preservation of the parathyroid. The anatomical preservation is not the only thing which is required, but it is the
Vascular,
vascularity
vascular
which needs to
preservation.
be preserved. चल रहा है यार क्या प्रॉब्लम है यार को पहले क्वार्टरी सही करा यार
हाँ यार
Okay, so this is inferior.
नहीं करने आता था
This vessel runs in close proximity to the recurrent laryngeal nerve. Number one, helps in vessels going to the parathyroid to identify the parathyroids clearly, because identification of the parathyroid is a difficult task. For which these two things will help us. One is microscope, another is vessel on the inferior thyroid artery to follow. Now, where should be the recurrent laryngeal? Recurrent laryngeal nerve would be below the level of the inferior thyroid artery where we see. That is the right place. You know, by and large, our superior thyroid parathyroids are above the level of the inferior thyroid artery and inferior parathyroids are below the level. Now, how to identify and where to identify the recurrent laryngeal nerve? Recurrent laryngeal nerve should ideally be identified in the lower neck. In the lower neck, not superiorly. Lot of people use the superior landmark, Zucker candle and all those. We condemn. The reason being, this nerve in the lower neck lies in a trunk.
Yes.
As it courses above, before penetrating the larynx, most often it divides into branches.
Yes.
If you try to look for the nerve above and happen to see a branch and ignore other, you can end up during the nerve. So always look for the in the right side, you're operating on the right side. Again, look for the trunk below, because in rare circumstances, when there is a subclavian artery, abnormal subclavian artery, normally this recurrent laryngeal nerve, after given off in the thorax, it wings around the subclavian artery on the right side to come in the neck. If there is abnormal anomalous subclavian artery, then this vessel, this nerve may not be recurrent. It could be a direct laryngeal nerve. So again, that can be confirmed when you don't find a nerve in the lower part of the neck. In the lower part of the neck, we open up this nerve in this triangle. See, this triangle is Lorenz triangle. There's a carotid artery laterally, the trachea, the airway medially, and above by the inferior thyroid artery. So open up this triangle. Open up this triangle, and this nerve runs in close vicinity. I can see the nerve. See? So simple. Can you see the nerve?
Yes, very clear.
Can you see?
Yes. It is looking like rope.
So it's so simple. First identify the inferior thyroid, then look below to it in the Lorenz triangle. Parallel to the nerve, you have to open up. This nerve has a close relationship with this artery. This nerve can run deep to the vessel. This nerve can run lateral to the vessel. See this? Relationship of the nerve and vessel. This nerve can run through branches of artery, or this artery can run through branches of nerve, whatever. So you have to open up this space. So we have seen the nerve. We have seen the nerve, we have seen the vessel. See the nerve. Can you see the nerve?
Yes. But it needs little more focusing, better focusing. That's all. Oh.
Now, having seen the nerve, my next focus would be to look for the thyroids. Now, parathyroids are so inconsistent. The variation of thyroids is so common to identify. How to identify the thyroids now? I see, by and large, during the embryonic descent, the superior parathyroids are their arrest. The inferior descent is arrested in a more, I would say, a common position. The superior parathyroid, I will show you, they are normally found just above the level of the laryngotracheal groove behind the plane of the recurrent laryngeal nerve, the superior parathyroid. They are more constant in location. Inferior parathyroids, their descent can be arrested anywhere. Sometimes even low down in the inferior, in the superior mediastinum, sometime in the thymus, sometime in the thyroid gland capsule, sometime in the anywhere below the level of the inferior thyroid artery in the paratracheal groove. So how to identify? There are many ways people are trying, but see here, the simplest way, and I have seen that. See that? Let me magnify and show you. The vessel going from the, it is so difficult to identify physically the parathyroid. Sometimes you may get confused with the fat, you may get confused with the thyroid tissue itself, you may get confused with the lymph node. So how to identify? Sure, see this. This inferior, this branch, see this. See this caramel color gland embedded in the fat. See this fat above? Hello?
Yes, yes, very clear.
Can you see this gland
Yes, yes, yes.
with a
Bharat.
network of vessels over it
Yes.
embedded in the fat? Can you see?
Yes.
Now remove this. See this? This is thyroid tissue looking like some may confuse it with a parathyroid.
Yeah.
Got my point?
Yes.
This is thyroid.
Yes.
Could be a reactive node, whatever. See this?
Yes.
This is not parathyroid. See, the color is so confusing. Mostly it is caramel colored. As the person become older, it becomes more and more yellowish. In younger, it is more and more brownish. This is simply a lymph node, not the parathyroid. So don't get confused. It is the microscope which gives you added advantage. See this? Where is our parathyroid? Our parathyroid is here. Can you see? Can you see everybody?
Yes, yes, very clear.
The vessels from the inferior thyroid are coursing over the parathyroid and making a plexus over it. Can you see the bunch of vessels?
Yes, yes, very clear.
This is the most definite way of identifying a parathyroid. If you can trace the vessels over it, there are such small capillaries which are difficult otherwise to visualize unless you use the microscope. That's the beauty of microscopic thyroid surgery, where you have the, advantage of microscope to additionally identify the vessel. That is the most definite way. See my parathyroid
Yes.
with vessels over it and embedded in the fat. See
Right.
this?
Yes.
That's it. Once you see out of all 4 parathyroids, if you are doing a total thyroidectomy, even if one is preserved, patient may have a temporary hypocalcemia, but
Later.
one parathyroid can maintain the calcium level in long run and it will never be a permanent hypoparathyroidism. Yes, in case, suppose, had I devascularized this gland, see this caramel color gland?
Yeah.
Had I devascularized it, it would have turned jet black. It would have turned jet black. In that situation, what can be done to prevent permanent hypoparathyroidism if you are doing a total one? You are not sure of the other glands? Remove this. Once it is jet black, it is of no use without vascularity. Remove it. Get a frozen section done to confirm it is parathyroid. Take a sliver of tissue from it to get a frozen section done. Once confirmed as a parathyroid, then mince into small pieces like liquid and transplant into one of the forearm muscle like brachioradialis or anything else.
But frozen section is not
must.
available. It is not available in most of the places.
Then you can't.
Most
Then
of
you may
thyroid
implant any thyroid metastasis or anything else. Never do without a frozen section. Never recommended.
Is it available in Bhagalpur, Farooq, Darbhanga, Muzaffarpur? Bihar side.
Ashwini boss. Hello.
Even it is not available in Patna. Do you know? It is not available
Ashwini
in whole,
boss.
it is not available in whole Bihar and Jharkhand right now.
Not available in Patna even?
No, it is not available in Patna.
Surprising.
Yes,
Hello.
Farooq sir.
Ashwini boss, it is not available. You have said it rightly. So we do not have the pleasure to implant it in case needed. Without frozen section, it is not possible.
So your next investment should be in
Ashwini
this.
boss. Ashwini boss.
Yes, dear.
We have a luxury of frozen section round the clock. That way. Now, see this, follow this nerve. My nerve is here. Deep to the vessel. See, my nerve is there. Now for the superior parathyroid, see, as I told, they are more constant in their location. Superior ones are more constant in their location and they are behind the level of the recurrent laryngeal nerve. See this inferior one. See this inferior one is anterior to the plane of the recurrent. अरे यार बिना चलाई चल रही है क्या हो रहा है? Huh? No?
Hello.
Direct कर रखा है.
Dinesh.
Excuse me, sir.
Yeah.
Excuse me, sir. Actually, I want to say that in our setup where frozen section facility is not there, could we test parathyroid by putting inside a normal saline so that it will sink easily? Otherwise, adipose tissue usually floats in that normal saline. Is it the
Not
practical
really.
best to do?
Never. Never. Even a metastasis of thyroid will sink.
Hello, Mr. Dinesh.
Hello?
Mr. Dinesh,
Yes, sir.
am I audible now?
Never
Yes,
do
very
that.
clear, sir.
Sir, Mr. Dinesh, we have the pleasure with us of having with us Dr. Afzal, who is a very good ENT surgeon based in Zuleika Hospital, Dubai. So, Afzal, welcome to the show. And please greet Dr. Satish Jain, sir.
Hi,
Good,
Afzal.
good afternoon, sir.
How are you?
I am fine. Thank you so much, sir. Amazing to watch you, sir, again. And n number of times I would have watched, but each time you are learning new things.
Okay,
Amazing.
Afzal. So
Session.
nice to hear from you, and we always miss you in Jaipur.
Me too, sir. Dr. Farooq, you have organized a wonderful workshop and you are rocking. Keep it up.
Thank you, Afzal.
See, this is my inferior thyroid artery. See this one? See the main artery? That is a branch to the inferior parathyroids. This is visible only if you do operate under microscope. Now I'm following the recurrent laryngeal nerve above. I told you most often it divides into branches. See what I'm trying to say you. I can show you the branches. See, this is the projection of the gland, that is the extension of the gland behind. Can you see here?
Correct. Sir.
Hello?
Yes, sir. Yes, sir.
Yes,
This is
sir.
called organ of Zuckerkandl,
Yes, correct.
and nerve is medial to it. But you know, that could be a branch only. And see here. See here, the nerve is divided into two branches. See this. One branch going here. See this? One branch going there. See this. Can you see or not?
Yes, sir. We do.
So never use landmarks which can put you in trouble. Always see the nerve in the lower part of the neck where it runs as a trunk. See this? See the nerve?
Correct. In the right, there can be one non-recurrent laryngeal.
Yeah. What?
In the right side,
Yes.
there can be non-recurrent laryngeal nerve as well. So should be careful always.
That is difficult to pick up pre-op because we don't generally advocate a CT scan before thyroid surgery. CT scan, a contrast CT can pick up anomalous subclavian artery and then you can suspect. Now, in case you don't have a CT scan, the best way is what I've said, find in the lower neck. If it is not available in the lower neck, then be suspicious of a non-recurrent laryngeal nerve, and then this nerve will come like this from above.
Correct.
As a direct branch of vagus like this from above like this. In that situation, any horizontal running structure in the upper part, you have to be suspicious of recurrent. So you become more careful.
Correct.
That's the whole idea. This is Zuckerkandl. Now, where is the likely place of superior parathyroids? Why I have not disturbed? See, this is the level of the recurrent laryngeal nerve.
Sir, please.
Superior parathyroid. disturbing, but let me tell
Please
you
centralize. Please centralize, Satish.
Yeah.
yes,
Thank
sorry.
you, sir.
Yes. So superior parathyroids, the likely place for them is, see this recurrent laryngeal nerve going up. You can feel the cricoid, you can feel the trachea starting here. That's the cricotracheal groove. In the cricotracheal groove, behind the plane of the recurrent laryngeal nerve, see here behind the plane here, the parathyroids are located here, embedded in the fat. See the fat, can you see here?
Absolutely.
Unlikely place embedded in the fat. With a lot of vessels over it. Parathyroids is very vascular structure, you know. See this. See this. That is the superior parathyroids for this particular patient. See this.
Yeah.
Here. But
Yes.
I am not disturbing because this is now away from my field. This is behind the plane of the recurrent laryngeal nerve at the level of cricotracheal plane. So you need to know where exactly it is so you can avoid injury to it. They are more constant in their location. You know, superior parathyroid, since they are constant, they are important structures. They help us, they save the surgeon from a permanent hypocalcemia during a central compartment neck dissection, as the central compartment neck dissection is always below this level, and we can keep the parathyroids intact, because in central compartment most often the inferior parathyroids are violated. So I have seen the inferior thyroid artery, inferior parathyroid, the superior parathyroid, recurrent laryngeal nerve, it's both the branches, see both the branches. And now the last structure, not the, is the identification and preservation of superior laryngeal nerve, the external branch, which is very important, particularly for the professional voice users. Very important for the professional voice users. In a normal individual, even if you have injured, you may not realize, the patient may not realize it well. But for the professional voice user, his career is gone. Because that is important now to raise the pitch of the volume. See the surface nerves.
Sir, in fact, there is a name for this nerve of Gali Kursi. She was a opera singer and she lost her career after thyroid surgery.
Oh, what was the name?
Gali Kursi.
Really?
Yes, sir.
Now, how to identify this? This sometimes is very, very difficult. But you know, let me pull the gland on my side now. See this? See this? Pull the gland on my side. This external branch is a branch of superior laryngeal nerve. Superior laryngeal nerve is given off just below the jugular foramen in the uppermost part of the neck. And this external the superior laryngeal nerve comes from that part in relation to the carotid to run towards the thyroid notch. At the level of the thyroid notch, it gives two branches. One goes inside as the internal laryngeal branch, sensory, and the other one goes outside. Can you see this now?
Yes, yes, sir.
It is very, this patient, I lifted off the thyroid lobe and it is much above that. Sometimes it is much below, then it is difficult to save. See this?
Yes.
That is the nerve, external branch going into cricothyroid. This is cricothyroid
It's a
muscle.
cricothyroid muscle, yes.
So it is automatically lifted off. So I have seen now all the structures. See this? See the recurrent
Centralize the
laryngeal now?
picture. Satish, Dr. Satish, centralize the picture, please.
Yes.
Yes, thank you.
Now here, below. Now above. See that? I hope you can see both the nerves in same view.
Yes.
That's the external laryngeal nerve. See this one?
Yes.
And that's the internal laryngeal nerve or recurrent laryngeal nerve. And now I can ligate this vessel close to the thyroid and
Sir, this will be in Cerny type 1, sir. What level this, sir?
pardon?
This ESBLN is in Cerny type 1, sir. Cerny classification.
This is
What?
type 1 is more than a centimeter below.
Okay.
Your lobe is more than a centimeter below the nerve.
Okay.
That was Sarnia's classification. If it is, then it is difficult, then it is type A, and 2B is very close to it.
Absolutely.
Now see this vessel, inferior thyroid, finally. I will take it close to the
Gland.
gland. It gives a lot of branches to the, structures, lot of structures, including trachea. So this vessel should be ligated to the thyroid.
हमको भी दे दे यार.
So as the world is more and more cosmetically getting oriented, there is a role of any endoscopic thyroid surgery, sir, according to you? I mean, transvestibular.
Money is the only obstruction.
So many. No, in the present scenario, not indicated for malignancy or larger lesions. Number one, you can do for small, less than 3 centimeter nodules, benign, which mostly do not require surgery. Otherwise, and third is that is not the standard of care to, complicate, because in thyroid, this preservation of structures is much more disease itself.
Was that a lymph node, Satish, in the lower part?
Hello?
Was there a lymph node attached to the lower part of the gland?
Node?
Is there a lymph node attached to that lower part of that is part of the gland? Yes,
Nodes
that
have
one.
already removed.
Yes.
But this look very soft. I don't see. See my nerve view. Vessel, the parathyroid. Now is staying away from the mouth.
Superior thyroid तो लगता है कि था ही नहीं लगता है. Superior pole में vessel था ही नहीं. Vessel ही नहीं था इसमें.
And I can remove it easily now. In the pretracheal fascia plane.
Hello.
Yes, sir.
Superior thyroid vessels was not visible very prominently in this case, I think.
Yeah. Depends. Many a times the superior thyroid is very, very prominent. Many a times not. In this patient was definitely not. Being here, but not prominent. You're right. would have shown you. Catch this, catch this. This could be having a branch of superior thyroid into it. See this? Caught here. Otherwise, we identify the external branch in relation to the superior thyroid vessels. Normally.
Yeah.
But not very significant.
So in case,
Otherwise, yes, sir.
sir, if there is a retrosternal extension, what would be your approach, sir? Like, if not to a great extent, but early.
Majority of the retrosternal extension, you can remove transcervical.
Yes.
Yes. In case, particularly in malignancy, in case it goes below the level of the brachiocephalic vein,
Right.
then, and in a malignant situation, it is better to take a stenotomy approach to save critical neurovascular structures. So, brachiocephalic vein is the guide. Any lesion below the level of the brachiocephalic, we do stenotomy.
Mhm.
We have removed lesions, malignancies, much gone intra-sternal, intrathoracic with stenotomy approach, even gone beyond the level of the arch of aorta easily. The stenotomy gives you an open book approach in that situation. But majority of the superior mediastinal extensions, you can remove
With
transcervical.
Okay, sir. Is it with more retraction, or is there any technique, sir? Different technique?
Yeah. Yeah. So I told you, if it is not malignant and if it is above the level of the brachiocephalic, you can pull out with your finger.
Oh.
Staying in the right plane, you can pull out. But for malignant lesions, you have to think twice, because the idea is not to do anything blindly without any vascular control below.
All right.
If you happen to damage the big vessel intrathoracic,
Yes.
you may lose the patient. And sternotomy approach, I tell you.
Mhm.
We do quite often sternotomy. Sternotomy is a very, very fast approach, technically simple.
Correct.
See now, finally, this is the lesion. Hello.
Yes, sir. We are here.
Opposite gland looks normal. And this is the time. This is hemithyroidectomy because we remove the lobe.
Plus isthmus. And the isthmus, yes.
Yes, lobe and this is isthmus.
Yeah.
See what I am removing is the isthmus.
Correct.
Ligate kar dena. And there will be final ligation after this. You can see all the structures in plane. See the recurrent laryngeal now?
Yes. Very clear.
So you can see the final hemostasis under vision.
22 cases has been posted for this workshop,
Oh, amazing.
and only 2 have been done.
Dr. Satish,
Yes, sir.
how you
They will be about
maintain
that.
the drainage of the parathyroid?
Maintain the
Drainage.
drainage.
Yes.
Yes, that's an important question. Let me tell you. Sir is asking about the venous drainage. Is it?
Yes, yes.
Yes. So that's an important thing I forgot to mention. That's a very, very important thing. See, I am coming to show you that, sir. See, see my parathyroid there. See the level of the parathyroid here.
Yes.
Never ever go below that and violate the venous return. Can you see the vein?
Yes, yes.
All the veins draining from below. See my parathyroid there?
Yes.
And see the deeper veins draining.
Okay.
So never ever violate the veins draining below.
Oh,
That's why you ligate the inferior thyroid vein close to the gland as close as possible.
yes.
If you violate the venous drainage, the resultant congestion can make it non-functioning. Your
Yes.
point is valid. I forgot to mention that.
Okay. Thank you.
So we can take questions anytime before we start the next one. Next one is a FES again.
Dinesh? Hello, Mr. Dinesh. Ashwini boss?
Yes, sir. Yes, sir.
Yes, sir. Yes.
Am I audible now?
Yeah, pura.
Yeah.
It seems the auditorium seems to be full.
Yes. ताली बजाए क्या?
सर का
Amazing.
मैजिक ही ऐसा है कि कोई छोड़ना नहीं चाहता है. And there are many people logged in worldwide. Can you tell me the number of people logged in, Dinesh?
Sir, approximately 2,600 people is live.
अरे वाह.
Oh my
on
God.
the link.
This is only sir's magic. Is that wonderful?
This is charisma of Dr. Satish Jain.
Yes. So the next case is a unilateral FES. So sir is going to elaborate on the CT scan of the patient. Just in a few minutes it will start. Case has already been induced and we'll be starting the case in around 10-15 minutes.
Hello.
Dr. Satish,
Yes, sir.
there is one different type of question for thyroid. When a patient comes with thyrotoxicosis, what care and at what time should it be operated?
What is for? Can you repeat, sir? I could hear you.
Thyrotoxicosis cases.
Yeah.
If we have to operate it, what precautions should be taken and what time should be proper to operate upon it?
See, first of all thyroid toxicosis patients do not require surgery. There are two types of thyroid toxicosis disease. One is grave disease because of the antibodies, and another is thyrotoxicosis, generalized.
Yes.
Now, the treatment of the thyrotoxicosis have been redefined, and very few percentage of the patients require surgery for that matter. Radioiodine has become a number one answer to thyrotoxicosis or the grave disease, you can say.
Okay.
Surgery has never been in a present scenario a number one choice. But yes, in patients where the radioiodine cannot be given, in many other situations, the radioiodine doesn't work, toxic effects, whatever, not tolerable, then surgery is taken up. Now, once surgery is considered, you have to give iodine to reduce the vascularity first, pre-operatively, along with the beta blockers. Number one. And we load with the vitamin D as well, because in thyrotoxicosis, once you remove the gland, the calcium is released from the bones. So vitamin D supplement as well. The gland is more vascular. You have to be more careful in surgical exercise. There will be more overall bleeding. Preservation of the structures is more critical. All those things, and the gland is as compared to the benign tumor is more adherent. So overall, surgery is little more challenging, not
Yes.
possible. So you have to
Okay,
take
right.
care of all these aspects.
Okay, thank you. Thank you.
Now, coming to the next case, any questions before we move on? Ashwini boss,
Yes, dear. Hello?
do we go ahead with the next case?
Yes, yes, yes.
Next,
Non-stop. Non-stop.
yeah. So like I mentioned earlier, Farooq has lined up variety of sinus surgery cases, so that we can see different anatomy in different patients.
Yes.
So
Frontal is
this next
clear.
patient, again an interesting one. What is the endoscopic finding? Polyps. As polyps on endoscopy, on CT. See this. I am not going in those details we have discussed earlier regarding the CT scan. We'll touch upon newer findings and interesting findings only. So this patient as a frontal sinus, you can see the left one is a bigger one as compared to the right one, and left frontal sinus opacification. Still the beak is intact with intersinus septal cell. This is intersinus
Yes, yes,
septal cell.
yes. Uh,
This
Opening
one
to the
communicating to the left sinus.
left side. Yes.
And see the
This
frontal
is,
recess.
yes.
That's the cribiform plate. The disease in the anterethmoids. That's a mucosal hypertrophy.
Yes.
Anterethmoids blocking the dependent sinus, frontal sinus.
Partial obstruction.
Intersinus septal cell, a small one.
Mm.
Then see this. Unusually, the lateral wall of the maxilla is more laterally praised.
Yes. Difficult to open.
And the orbit is more medially prominent. Can you see?
Yes, yes, yes.
See, if I draw a line, see the line at the medial edge of the orbit. It is so, as compared, if I draw a line at the lateral wall of the nose here, see this, the medial is so medially prominent. You have to be careful to prevent an orbital entry.
Yes.
That's the important point here. Don't know why the lateral wall is so pressed laterally. They don't know the nature of the disease. What he has said, the endoscopically there is polyps.
Lights power gone here. There is no transmission. Power cut.
Generator, no?
Hello? Hi. Hello?
Yes, boss. Can you hear me now?
Yes, 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 yes. Very clear. Actually, in this situation, it is difficult to open, relatively difficult to open the maxillary sinus.
Yeah. So you have to be careful while opening the maxillary sinus. See this.
Yes.
See this wall is so close to the orbit.
Yes, yes.
If you are not careful, one can easily enter into the orbit at the beginning of the surgery.
Yes.
So this lateral wall is more lateralized, close to the orbit. This is the uncinate process here. And this entire, full of polyps.
Yes.
Very unusual kind of polyps, I would say, pressing on the medial wall, the lateral wall of the nose.
Lateral wall.
Yeah, see this, it looks like the septum is deficient also over here.
Is the polyp going through to the opposite side? It appears to be homogeneous.
Septum looks deficient.
Yes, okay.
Let's see in the soft tissue window. See this?
Yes, soft.
It looks like going through and through.
Yes.
Can you see?
Yes, it looks like going through and through the septum.
See, this kind of ballooning, this kind of unusual lateralization of the wall, the pressure effect,
Yes.
this generally doesn't happen with a simple polyposis. Generally,
Yes. Yes. So what is your another provisional diagnosis?
could be the mass lesion, but we can't say because we don't have a contrast, and I have not seen the endoscopic picture.
So
Sometimes, even if you see endoscopy, even if there is a mass lesion, on surface is a prolapsed mucosa, looks like polyp.
so do you think these patients need MRI?
Yes, they have to be more thoroughly evaluated for symptoms also, symptomatology.
Okay.
Because sometimes, the symptoms are overlapping. Even if you have tumor, you have overlapping symptoms with sinusitis, but some characteristic thing can be easily missed. So you have to focus on the symptom. What is the age of this patient? Haru? Oh, see, boss.
Yes. Yes, dear.
60. He's 60.
Okay. Age 60.
60 years, unilateral disease, mass effect. Got my point?
Yes. Yes. Got.
Could be something unusual.
Yes.
I have not seen the nose yet. It could be something unusual. See, it has gone through and through the septum.
It is going through the septum. Yes.
This bone is more prominent.
Yes.
Because of the mass effect,
Yes.
uncinate is generally pissed off in between.
Yes.
But here the uncinate is very prominent.
Yes.
Got my point?
Yeah.
So let's see what it turns out to be. But this is something unusual, I would say. Enterethmoidal group of cells are involved. Posteriorly, it is pretty clear. See, disease is occupying the complete posterior nasal cavity as well as nasopharynx. Can you see? Coming to the opposite side in the nasopharynx. See this? From here coming to the opposite side in the nasopharynx. Can you see? Hello?
Yes,
Hello?
yes, yes, yes.
See, coming to the opposite side in the nasopharynx. Here the septum is gone. So it looks unusual.
Again go for the soft tissue window, Satish, please.
Yes. See, from this side it is going, occupying the nasopharynx and pushing towards the opposite nasal cavity posteriorly. And this is the region. See where the septum is gone.
Yes, yes.
See, septum is gone, has pushed. Beyond that, here is this unusual bone. See this unusual thick bone. See, in polyposis, the contrasting is that in polyposis, the bone is thinned out.
Yes, in polypony.
This is unusually thick. Moreover, the patient is 60 years and unilateral disease. So, all raising suspicion of having something else. Any history of bleeding or something? Anytime? So, do we go ahead or? Because that's the only positive finding in this patient, and I'm quite suspicious about it. Ashwini boss?
Yes, sir.
What is your take?
I cannot say, but it may be simple granulomatous tissue, more likely to be some granulomatous disease. Because no bony destruction as such of the lateral wall of the maxilla, medial wall of maxilla, sorry. But the septum is definitely destroyed.
Was there any history of epistaxis in this case?
Yeah, that's what I was trying to figure out, but they say no. This could be a mass attached to the septum also.
Septum, more likely to be tied to the septum. कितना पीछे?
Septum or uncinate over here or something like
That
that.
when uncinate has been pushed little down.
So let's see. Is that ready? Ready? Next. Mobile. Mobile. Hello. Hello.
Yes, sir.
Hello?
Yes, sir.
Yeah.
See the
Gosh. This is not normal polyp.
yeah.
पॉलिप नहीं लग रहा
हाँ polyp है और big है तो polyp है और
Look, polyp only.
general
malignant
word.
भी नहीं
Polyp is
लग
a
रहा
general word. Polyp can be malignant, polyp may not be malignant. What is the endoscopy picture on other side?
Other side is nothing.
Yeah, that is coming from posterior part. Yeah,
So far looks like
हम
polyp
चीनी वाला
only.
चाय पी लो बहुत चीनी डालते हैं हाँ
So far looks
दुश्मन
like
की तरह
polyp only.
पिलाते हैं
So,
चलो So are you going to take biopsy first? Hello, Dr. Satish?
oh,
Are you going to send this for biopsy?
first scene,
Or is it simple antroconal polyp?
it's like little angry polyp, you can say. So let me debride it first.
Okay. जो होगा देखा जाएगा.
Yeah, could be endocrine polyp also.
Yes. नहीं, ऊपर से आ रहा है. It is coming from it is actually frontoconal polyp. Have you seen the case of frontoconal polyp? होता है. Frontoconal polyp, antroconal polyp, spinoconal polyp. देखो spinoconal polyp देखा ना. हाँ सुन लियो. ये तुम्हारा फ्रंटोकोनल पोलिप ही निकलेगा देखना. नहीं नहीं तो इससे भी कर सकते हो. क्या क्या कहते हैं कोलेटर वहां से बड़ा बढ़िया मतलब मीडियम नहीं होगा. वो प्रोसाइज मैक्स हो रहा है और सुपरफिशियल टच कर रहे हैं.
I am just debriding the luminal component first. So far it is polyp, little angry, could be.
राइडर्स कोलेटर. हाँ वो सरफेस पे अंदर मतलब मिलेगा तुम्हारा फ्रंटोकोनल पोलिप. ये हो सकता है कि फ्रंटोकोनल पोलिप पीछे में थोड़ा सा वाइटनिंग था मेडिकल साइंस में. चलो एक एनाटॉमिकल बताओ. एक एनाटॉमिकल एब्नॉर्मलिटी बताओ. तुम्हारा परपेंडिकुलर ब्लेड
Still removing the luminal component only.
क्यों एक ही साइड से दोनों साइड का स्ट्रेचिंग दिखाई पड़ेगा. बड़ा हो. हाँ ऐसे आ गया. नाक है यार निकाल दो छूटेगा पता चलेगा. एसी पॉलिप नहीं है हो सकता है तो polypoidal.
Could be. See, this is polyp only.
Yes.
This was nasopharyngeal component, find out.
Yes.
This was looking like an infected AC polyp.
Did not AC polyp. You have a frontocolon polyp.
See here, we pressed on the septum to push it. See this?
Yes.
On CT scan, you cannot see, confirm. See, the septal bone it. So far what I have done, remove the luminal component. See this? See the septum was pressing onto it. So funny. See the way it has pressed on the septum to the level of the opposite side, but not transgressing it, not penetrating it. Can you see?
Yes.
And this is suction.
Is it rising from the anterior fontanelle only?
Don't know yet. Let's see. Let me see it better. Yes, wash. So now we have a better picture. See, nothing in the lumen. And how it was impinging on the septum, which has given a false impression of going through and through. It is actually not going through and through, but pressing, it was impinging. See the septum? Hello?
Yes.
It eroded the septum, yet not transgressing through the mucosa.
Yes.
So funny. And that, to pick up that is beyond the capacity of the CT scan. Now, where it could be arising from. This is part of the uncinate process. You can see that's the middle turbinate. See, the uncinate process has swollen up. Can you see?
Yes.
The uncinate, I told you the uncinate is hypertrophied on CT scan. This is something which is attached to the uncinate. And that I will take as a part. So, this part. So it looks polyps only. What is it? See this? I have removed this lower part of the uncinate to open up the middle meatus completely. See now. So I have opened up the middle meatus completely.
बाबा बुढ़ारी में भी कमाल दिखा दिए भी। कह रहे हैं बाबा बुढ़ारी में भी कमाल कर गए हम लोग के लिए।
See the polyp.
यस पॉलिप नहीं यहीं तक है पॉलिप अंदर में भी है।
See this
यस यस नाउ इट इज
intracoinal polyp.
यस ENT let us see. It is not enterocolon polyp was going from the nose to the antrum in this case. Hey, it is not like that.
Yeah,
Polyp
you may
from
be
the
right. Nobody can prove.
no, so it is 70 degree we can see na. Inside the antrum we can see the attachment. Na?
Yeah, we will see. Now this is quickly. We have seen the frontal in detail in the last case. Now see what I am doing? Defining the lamina.
Yes.
That's the lamina here. That's the bulla. And here I will keep the bulla intact. Open up the axilla.
That way.
Open up axilla thoroughly,
That-
still with a 0 degree.
Yes, that is agar nasal.
Open up axilla thoroughly. See this?
Yes, large agar nasal. This is part of agar. The interior wall of उसके
And
पीछे.
see this? See this?
Yes. Exhale up.
This I am taking away to enter into the frontal. Simplest of the situation. Still with a 0 degree only.
Yes.
Again, flush with the orbital wall. Flush with the orbital wall and follow the beak. Can you see the beak there? This is beak.
Yes. ये बहुत सेल है.
Now give me 70 degree for a while to show you the anatomy there. The section. See what I have opened up. Frontal sinus. Can you see the frontal?
Yes. We can see the septations.
So I opened up with a 0 degree only because this was a straightforward situation. This is beak. See, this is beak, this one.
Yes.
Where it ends is the frontal. Can you see there?
Yeah, very clear.
Now, this projection of the beak, I will take away. So you can see better and more, steroid can be propagated inside, though it doesn't look like that kind of eosinophilic disease. This is bulla. I can quickly finish off.
सेक्शन का नाम बताओ फारूक. We are
Amazing.
yes, really amazing.
बॉस
Section.
अश्विनी बॉस.
हाँ यार.
बॉस ये सेंट्रल सेक्शन है.
Always buy one.
कितना प्रेशर रखवाया है जी?
700. 700 पे है. मैक्सिमम सेट किया हुआ है.
Recommend 1 hour.
So we are having a central section pipeline
for sinus surgery.
Most of the central section doesn't work in face. First,
the conductivity of the blade
I'm
as well
blessed,
as
sir. इसका रूटीन सर्विसिंग कराते रहते हैं, हर एक महीने में एक दो बार आके आके देखेगा इंजीनियर, सब ओके करता है. That is why we are having good.
Now see what I am trying to say. This beak projection, it inhibits the visualization of the frontal. See, this is the anterior projection of the beak.
Yes, very clear.
And it prevents the topical also from entering so freely.
Yes.
So what you can do? Articulate it.
Will you like to take out the anterior part?
I will show you my favorite tool here.
Yes.
That is the articulated punch.
Articulated frontal punch.
See this.
Yes.
9 articulations. And see this. See this.
Yes.
It will remove this projection of the beak. To see the frontal much better.
Yeah. To reach the anterior limit of section.
More. See this?
Yeah.
What a tool it is.
Wonderful.
I showed you in the last case one side biter for the frontal. This is another tool for the front. There are so many tools. Hydrodebrider. See now the frontal much
Yes.
better.
Yes. Very, very clear. Personally.
Okay. See, this is the projection of the beak. And what a tool it is. See the frontal sinus now.
Yes.
So I don't need to do anything much there because frontal was not
involved.
Not involved. It was just redundant secretion because of the blockage.
What is the situation
This is the ground lamella, which I am not again going behind.
There's no need to.
That is not involved.
Yes. What is the situation of maxillary sinus?
Yeah, that's what I am going into.
The polyp are going from nose to sinus.
Likewise. Now with the 70
Very, very interesting case. Really, very, very interesting case.
is a part of the uncinate.
Yes.
What is it? No?
Have you
Part
sent
of
it
the-
for biopsy, Satish Jain? Letter of Satish?
Yeah, we have already taken that for biopsy.
Okay.
And all, no?
What do you think?
See the interior of the maxillary sinus?
Yes, yes.
The remnant of the lower uncinate. Remnant of lower part of the uncinate. So it looks absolutely fantastic.
Yes.
So it looks like arising from the uncinate only.
Yes.
There was hardly anything beyond. The uncinate was swollen up, you know.
Yes.
See both the surfaces of the mucosa on either side.
Yes.
See the mucosa on either side of the maxillary sinus enterostomy. See this?
Yes.
And that will allow it to heal faster.
Is there any perforation of the septum in this case?
No, I had shown you. I will show you again.
Yes.
It was impinging on the septum because the pressure it has little bit of the mucosal, loss, but not perforation. See this, both side mucosa.
Yes.
You can invert this inner mucosa to join the outer one for the faster healing. See this?
Yes.
That's it. Now give me 0 degree. So the final work is done. And this old man will be relieved. You know. See the frontal recess there? That's the ground lamella. Ground lamella, the maxillary sinus. See this enterostomy? Wide one. And see this frontal, this mucosa of the septum. It was impinging onto it. See this? Gave pressure necrosis but never involved. Can you see, sir?
Yes, yes.
From opposite side?
Opposite side is normal, intact.
It appears to be perforated.
So this is absolutely fine.
Just give a look from the right side.
Yes. Rest is all well.
Yes.
Okay. Was an interesting situation,
Yes.
doubtful situation.
Will you give any packing in this case or not?
Yeah, for a day or two.
For a day. Miracil packing.
Yes, simple miracle. You know what happens? For such a patient going to have a good outcome, even the slightest ooze in the postrum will ruin his temperament. You have almost given him 100% result.
Have you used Eon's new Miracil?
Not really.
No, I have not used, and they are claiming that
See this.
yes.
This mucosa, it
Oh,
was pressed.
bungee.
See this mucosa, redundant mucosa, it was pressed from opposite side, like this. See this?
There is perforation.
Yeah, thinned out mucosa, but it is far behind and not really useful. Okay?
This is
So that's all about this case. That is all about this case. So in the first phase was different finding, second phase was a different one, and Farooq has lined up so many phase cases. So we are expecting more, variety.
हेलो 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 हाँ देयर इज ए वर्किंग लंच है ना यू कैन टेक योर लंच फ्रॉम द काउंटर एंड सिट इन द हॉल हाँ सर यहीं पे आके खा सकते हैं
Yeah, excuse me. The lunch will be provided after 10 minutes. Please wait.
जब तक आप लोग हेलो
Yeah, hi, excuse me, everyone. The lunch will be served at your place. So please be seated. So sir is going to start next case.
इसके साथ जीके के इसके बाद है मुझे देखना सारा कुछ वही देखना है कल भी नहीं आ पाऊंगा कल तक बस हाँ
किधर है जोन?
स्पेलिंग मिस्टेक हो गया केस आया तो मान लीजिए कि 30 तारीख को नाइट 12 बजे के बाद तो खुला जाएगा 1 तारीख को जाएगा बैठे 7 से 9 बजे 3 घंटा बाद तो गेट निकल गया हम फिर से मीटिंग कर बजे आ रहे हैं 6 बजे केस आया 30 तारीख हम बोल रहे हैं कि आपका कैसे 30 तारीख का कैसे बच्चे बोले 1 तारीख को उस समय हमको लड़के ले रहा था नाइट ड्यूटी करते डेट चेंज करके लेकिन तो सब समझ गया
ऑलरेडी सर्टिफिकेट बना हुआ था उसका ठीक है, उसका साला वैसिलिटी का सर्टिफिकेट बना हुआ था। आया है वो फॉर्म लेके रेलवे कंसेशन को, हम देख लिए साला कि ऑलरेडी सही है, सर्टिफिकेट बना हुआ है, रेलवे रजिस्टर्ड कर। अब साला हमको ये पता नहीं था कि साला ये जो है रेलवे वाला कंसेशन को सर्टिफिकेट है। हमने देख लिया टेक्नोलॉजी का बना हुआ है उसका, इसको देख के हम जरा अप्रिशिएट कर दिया उसको। हमने बोला चलने का है, हमको बोला अप्रिशिएट करना है। वही तो साला जज का इसका था, बेटा का बघेला जज है वो, यहाँ दरभंगा। साला हमको दौड़ते दौड़ते साला हम परेशान हो गए। अरे साला हो गया, केस कर दिया उसको, चल गया साला रेलवे बोर्ड। रेलवे बोर्ड ने साला चिट्ठी आ गई। अब साला हम तो हमको क्या पता साला सब है ना जेरोक्स वाला क्या होता है ना, पहले जो हाथ वाला नहीं चलता रहता है, हाथ वाला साइड में स्टाइल वाला नहीं करता था, वो सही फॉर्म था वो भी नहीं। हम तो पढ़े नहीं, हमने कैसे कर लिया, हम अपना साइन करके उस वाले से तो मांग रहा था फॉर्म दे दिए करके ना कितना लाया लाया तो फिर जो है सब उसको वो मांग रहा है कि सर्टिफिकेट कैसे इशू कर दिए है ना। आपको है ENT का डॉक्टर, आप जो है उसको सलाह दीजिए आपकी दीजिए आपकी उसका सलाह वाला हम कर दिए। पहला पढ़ भी नहीं किया पूरा, पूरा फॉर्म कैसे कराने आया क्या है सलाह
ये तो था बॉस को गलत फॉर्म साइन करवा लिया रेलवे का, कंसेशन फॉर्म बोल के डिलीवरी फॉर्म साइन करो और बॉस को लेटर के लेकर आ रहा है कि आप कैसे सर्टिफिकेट दे दिए।
अरे बॉस को सर्टिफिकेट बना हुआ था हम देख के नाम हम ला लिए देख लीजिए कोई का जज का देखा था इन्होंने रेलवे को कर रहा था अंदर से ना एप्लीकेशन कर दिया हम बोला घेर के ये साइड तो फॉर्म था तो सर्टिफिकेट था रेलवे का, ये कोई नया नहीं था क्या है समझ हम साथ
एक चीज और करता है बॉस, ये सर बैठा रहिएगा ना, ये उन्हीं का स्टाफ हमें बोलेगा, हमको सर्टिफिकेट देने नहीं आगे बोलेगा सरकारी डॉक्टर करता है कि नहीं बस परिचित है लाइसेंस तो बनना है, हमसे दूसरे चले लेगा, आपको बोलेगा मेरा परिवार है कितना परिवार है, ये महीना परिवार है 300 रुपये ले लेगा, आपसे बोलेगा मेरा परिवार है मैं करता हूँ बोलेगा मेरा भाई का है क्या का बोल के बाहर जाकर पैसा ले लेगा, तो लाइसेंस वाला जो बनता है
हम सब
Hello. Hello, OT.
Yes, sir.
What is the next case?
Hello,
Hello.
Ashwini boss.
Yes, dear.
Yes, boss. We are about to begin in 4 minutes. The next
Which
case
case?
is
What?
going to
What
be
the case? What the case?
parotidectomy.
Okay, superficial.
Hopefully so. Superficial. So in about 5 minutes, roughly, we'll start the parotid. Has the lunch been provided?
तुम 2 दिन में सबका 2-2 किलो वजन बढ़ा के भेजोगे यहाँ से।
अरे बस
है कि नहीं?
ठीक
उससे
ठीक ठीक ठीक
उससे
बस
अच्छा फैट का इंजेक्शन ही लगवा देते सबको। आधा किलो फैट इंजेक्ट कर लो। ऐसा होगा ना
सब पूरा तैयारी के साथ दूसरे लाख जैन सब पूरा तैयारी के साथ लाख दूसरे देखे तो हमको बताइए नहीं परेशान हो गए हम करे तो क्या करें क्या खोल दे
होगा इन लोग का प्रोडक्ट होगा। देखो तुम्हारा भी कोई प्रोडक्ट नहीं पे पीछे छोटा छोटा बच्चा के तो बच्चा पेट अच्छा खासा होगा।
स्टेट कॉन्फ्रेंस के बराबर हो गया
वही देखता है सती लंबे स्कूल में ऐसा तो भाई तो पढ़ाता उड़ाता भी है।
क्वेश्चन उसके बाद जब तक उसको डेकोरेट नहीं करेंगे
पूरा मतलब फेस तो पूरा दुनिया को चला सिखा दिया बोल बोल के
फेस नहीं सर फेस है थायराइड है
हाँ फेस खराब सर्जन कभी गर्दन का सर्जरी करता था। हम लोग आए थे इस समय ना तो हमको नेक में ऑक्सीजन लगाने में डर लगता था लगा कहीं तरह थोड़ा ट्रीटमेंट न करते सही बात
बहुत
हमें उस तरह का अवार्ड मिलना चाहिए। भारत सम्मान जो सम्मान होता है वो सब सम्मान का मिलना
सही बात
चाहिए। कम बड़ा बात है सर, आप 2,500-3,000 ENT सर्जन को ट्रेन करते हैं।
Hello. Hello.
Yes. Hello, sir.
Hello.
Yes, sir.
So let me put the microscopic picture. We have already started.
Yes, yes.
No, sir. We can see the laptop, sir.
Oh,
Yeah.
can you change?
Now,
Yes, now the picture is there.
Let me know when you get the microscopic picture, please.
Yes, 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 yes.
just focus, sir.
Just focus.
Yeah. So my associate has already started. Just put an incision. Let me tell you something about it. In parotid, incision has an immense role. Not only from cosmetic point of view, but for other purposes as well. Number one, see my
Yes, this is
incision.
modified Blair's incision.
Yeah, it has gone behind the canal, behind the tragus,
Yes.
and then the cervical component. Number two, the flap which we raise is important. It should go to the level of the parotid fascia so
Okay.
as to prevent Frey syndrome.
Yeah, Frey syndrome.
Superficial SMAS, muscular aponeurotic tissue
System.
should the full thickness of this tissue come so that at the end of the surgery, the nerve endings of the parotid postganglionic fibers should not come in contact with the subdermal nerve endings.
Okay.
The thick SMAS should be there. Number two. Number three, while raising the flap, it should not go beyond the anterior margin of the parotid onto the masseter muscle. Otherwise, all the nerves, after passing through the parotid, go onto the masseter.
Yeah.
Surface of the masseter. After preserving the nerves here, one can end up entirely, damaging the nerves. And fourth, when you raise the flap, you have to be careful. See, around 6 centimeters
Please keep silence.
Around 6 centimeters below the extraordinary canal. See, this is extraordinary canal.
Yes.
6 centimeters below, you will find the greater auricular nerve. See this?
Yes, very clear.
Coursing on the surface of the sternomastoid
Yes.
artery. So all these things are important while making the incision and raising the flap. See this now?
Yes. Actually, flap should be started elevating from the lower end to prevent cutting of this greater auricular nerve.
Yes. Because the posterior branch of this nerve is important for the auricular lobular sensation. It is more important in females.
More important of females or males?
यार कॉटरी वाला बंदा कौन है? गुरु गुरु सुन तो कुर्सी लेके यहीं बैठ जा, हिलना नहीं है, नहीं चला।
ध्यान से सुनना, ध्यान से सुनना।
See, that is the greater auricular nerve. Keeping in that in mind, you can raise your flap accordingly.
क्या हुआ? तो होगा। अच्छा, तो भाड़ा में वक्त बस में है। क्या? नहीं, हम अकेले ही आए हैं, तुम तो वही थे। लवली कहाँ है? नहीं, लवली नहीं, लवली वहीं पे। वहीं पे।
एक नॉन वेज वेज है किसी जगह का
नहीं कर रहा है,
नॉन वेज है ना, वेज है तो
कौन भेज देता है? क्या भैया, राकेश बाबू, व्हाट आर यू डूइंग?
हाथ से पकड़,
पार का डिटेक्शन अंदर आप
देख रहे हो मार्का खाते हो भेज एक भाई हमको भी दे दो। अरे मिल जाएगा, अरे आ जाएगा, आ जाएगा, छुटकी से जाएंगे।
हेलो,
हाँ हेलो, आवाज नहीं आ रही सतीश, we are not getting your voice.
Yes, yes, yes. So this flap raising is an important part for many regions, I told you. Can you see the posterior branch of the greater auricular?
Yes, very clear.
Very clear?
Yes.
Leaving this behind, you can raise your flap anteriorly.
Hmm.
See this? I have left this behind. And now you can raise your rest of the flap. The only important thing is it should be right onto the glandular fascia.
Yes, 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 yes. Super.
Keep the full thickness of the SMAS. See this? This is
Centralize the
gland.
picture. Centralize the picture, please.
See right onto the gland fascia.
Yes.
Unless in malignancy where it infiltrates the skin, then the scenario is different. See this?
Yes, very clear.
So, number one. Number two, don't go beyond the parotid surface.
Okay.
Can you see the parotid tissue?
Yes, 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 very clear.
Keep an eye not to go beyond the parotid tissue.
Not to enter the parotid tissue.
Not to go beyond anteriorly.
Anteriorly, okay.
If you go into the muscle surface, you can damage all the branches.
Yes.
Because they run on the masseter muscle. See this? What I am trying to show you. This is the gland where the gland tissue is ending. Can you see?
Yes.
That is the masseter.
Yes.
All these branches run over the surface of the masseter. So this, while anterior flap raising, you should not go beyond the surface of the
Masseter.
beyond the surface of the parotid gland. See, this is the parotid tissue.
Okay.
Don't go far anteriorly. I hope this point is taken or not.
Yes, yes, very well taken.
Don't go far anteriorly, otherwise you'll end up damaging the branches. Okay?
Yes.
Now, this posterior branch, I'm cutting this anterior division.
Okay, yes.
That goes to the skin.
Yes.
That's why all these patients have loss of sensation on the side or on the surface of the parotid area for some time until the superficial sensory nerves regenerate. See, I am taking this away from the posterior division. See this? See this? This posterior division is left behind now. Okay?
Yes. ना खाना है ये क्या है ये?
Now, see the most important landmark
That's
is the tragal pointer.
Tragal pointer.
Tragus. इसके लगा दे सूचर एक सूचर लगा I will keep this lobule away. See the exposure?
Yes, very clear.
So in exposure, there was lot many key points. So the anterior extent, the thickness of the flap, the posterior division, the incision, everything is important. The most important thing now comes in tumor removal is the facial nerve preservation. Parotid surgery revolves around preservation of the facial nerve, identification and preservation. There are many landmarks we have discussed several times. Our technique is a convergent approach. Taking two landmarks, one from above, one from below, to converge onto the facial nerve. So the landmark should be reliable. The thing, once you consider anything as a landmark, the most important thing is the accessibility of the landmark and the reliability. what I am trying to show here is the tragus,
Yes.
the lower end of the tragus. That's the lower end of the tragus. Okay. Hello.
Hello. Yes.
Yeah, this is the lower end of the tragus. One landmark will come from below, and that would be the digastric.
Digastric muscle.
See now, so simple. Go to the vein. Go to the anterior edge of the sternemastoid and deeper. See this. More. See the sternemastoid.
Yes.
Go to the anterior edge of the sternemastoid.
Centralize the picture, please.
Yeah.
What is the magnification of?
See, under microscope, I'm using the minimal magnification, so you can I can show you the maximum, field. In between, I will increase when I have to show some important structure.
Yes. This is vein. Anterior branch.
Oh my God. See the facial now, right there.
Oh.
Unusually lateral.
Lucky.
Can you see this? Oh, lateral.
It came very early.
That's why I always use the artery parallel to the nerve and not any sharp dissection. Never.
It came before we thought.
My God.
It means the tumor is lying in the deeper tissue. Tumor must be lying in the deeper tissue.
No, it is superficial only. It looks like.
Then why it came so easily?
Anatomy can be anything, boss. See now, this is the upper division.
Yes. This is a normal presentation. Don't you think, Dr. Satish?
Abnormal.
Generally, we don't see this type of thing.
I have bipolar. अरे यार तुम
हुआ तो पहले निकल गया
उसी लेवल पर
क्वांटम का लेवल
See, this is upper division. Always lift the tissue, not give a traction on the nerve. मेरे को दे. Always give traction on the tissue, not on the nerve. It is the traction most of the time which is responsible for weakness.
Yeah. So everything. दूसरे साइड का पिछला नरवा है इधर से ना कुछ करना होने की जरूरत है इसमें आप cannot come out like that. एकदम सवाल नहीं.
See the upper division branches.
Yes, very clear.
This one going up is the frontal branch, this one. Most important is this zygomatic one.
Yes. वही तुम्हारा आई को सप्लाई सेंट्रल तुम्हारा फ्रंटल को सप्लाई करता है तो फ्रंटली होता है तो फ्रंटली होता है ना.
See this?
Yes.
So our gland is almost away from superiorly from this branch. See, your direction of the forceps should come lateral.
नहीं यार, नहीं तो खोल, नहीं तो है फीमेल।
See this?
Yes,
It is deflected away.
pyridectomy is going to be completed before staphylotomy. In lesser time.
Now see, lower division has multiple branches.
Yes, yes.
See the picture through the microscope.
Yes. डायगेस्ट्रिक खोलने का मौका ही नहीं मिला है। यार टाइम तो खोलने में लग जाता है। फाइबर नर्व लगता है।
See, I have left this rima. This is marginal mandibular branch.
सब इसी में मार्जिनल सबसे नीचे वाला है। एक दो तो आ गए कितना मानते
See all the branches?
Yes, very clear. A traumatic dissection all.
The facial was funny.
Just like expressions.
You just see now, staying away from all these branches with good cuff of normal tissue around the parotid. काट ही नहीं दिया। So that's the lesion.
Why the facial nerve was lying so lateral in this case? What could be the reason?
How can you? Yeah. Region, how can you tell region to the nature? It was unusually lateral, I would say.
Unusual. It's very, very unusual. Not seen.
So never compromise with the exposure. So no bleeding?
Yes, excellent. Super. यार खाने के बाद खत्म हो गया शरीर। कन्वर्ट करने का मौका ही नहीं लिया।
आई वो सिंपल ही था, मैं ज्यादा जल्दी हो जाएगा।
पॉइंटर तक समझता है कॉस्मिक चला सकता है, कोई दिक्कत नहीं। हाँ, उसके लिए 1 सेंटीमीटर इंफीरियर है, 1 सेंटीमीटर मीडियम चलाते तो पता नहीं मिली जाते सबके पता नहीं सर, हमको लग रहा है ना कि निकला वहीं से, लेकिन तुरंत सुपरफिशियल हो गया। मैंने एग्जिट इसका सही जगह पर हुआ होगा, लेकिन तुरंत लेटरल हो गया।
तो मुंह चौड़ा तो नहीं है, कहता ना बता कि बहुत ज्यादा चौड़ा है।
खत्म, मोटिवेशन खत्म नहीं हुआ, सब सर्विस खत्म हो गया।
साला का पहले
हम लोग का चिकन खत्म हुआ सर, यहाँ केस खत्म।
पहला बात देखा होगा ना, जरूर निकल पाते होगा।
नहीं होगा सर, बहुत डर जाएगा। पेशेंट यही आ जाता है, उसको लगेगा उसको 2 घंटा पहुंचने में हम लोग का चिकन खत्म नहीं हुआ, हम लोग का चिकन खत्म नहीं हुआ तो केस खत्म।
डायरेक्ट यही आए, डायरेक्ट रिश्ता पॉजिटिव रिश्ता है क्या सर? बोल रहे तुम दोनों का कोई रिश्ता है? बोला हाँ पॉजिटिव।
गड़बड़ रिश्ता लग रहा है। राकेश को कभी नहीं छोड़ता है, दुनिया को छोड़ दे, वो तो सत्येंद्र बोध को छोड़ दे, लेकिन तुम उसको नहीं छोड़े।
दोनों में काला कपड़ा।
आप मेरे लिए बात किए सर्जरी के लिए, बात करते मेरा भी सूट आप तय कर देते। हाँ
बात करेंगे,
करके हमको बताइएगा कितना 1000 मिलेगा पर सर्जरी। ये अच्छा होगा, वर्किंग लंच में हुआ तनख्वाह भी सिंपल है नहीं सर?
ज्यादा दे दिए, इतना भी ड्राई टाइप का लगे।
2 रोटी दाल सब्जी।
आज आप यहाँ से कंप्लीट ENT सर्जन बन भी
देखिए फेस देख लिए, फेस देख लिए, थायराइड देख लिए, पैरोटिक देख रहे हैं।
सुनाई का जांच सत्येंद्र बोध क्या सोचेगा,
लेकिन
वो सुनाई का जांच करेंगे, हम सर्जरी कर देंगे।
ईयर बचाओ देख
एडवांस ENT सेंटर ना, एडवांस सेंटर हो गया, थोड़ा समझ ही नहीं आया हम लोग क्या लिखते हैं।
आप लिखिए सुपर है,
हम लोग लिखते
बेसिक बेसिक
एप्लीकेशन सुपर से ऊपर,
सुपर
सुपर से भी ऊपर ये
नहीं। आप लिखिए जो कहीं भी होगा वो हम करेंगे नहीं सर।
सबका इलाज,
हाँ जो कोई नहीं करेगा वो हम करेंगे। नहीं यही आप लिखिए सर, जो कोई नहीं करे। हम जानते हैं परसों आपका कार देखे बुध को गाड़ी वो आई हुई थी आपकी बेटी, तो परसों हम कार देखे, हम सोचे आप ही ऊपर हम चले गए देखे हुए तो हम आधा घंटा हम लोग बैठ के बतियाए, फिर चाय चाय पी के वापस। But she thinks broadly.
बहुत ज्यादा घर लेके जाते बता दीजिए। हाँ एड्रेस लेते चल जाएंगे सर। हाँ लेते चलिएगा सर, गाड़ी में ला केवल चावल ना एक ही पैक करना है। हाँ हाँ वही है ना, जैन साहब कैसे ले जाएंगे एक मंथ 5 किलो के लिए भेजा जाता है। 2 आदमी चला गया
हेलो हेलो
Yeah. Hi, sir. Yes, sir.
Hello.
हेलो ऑडिटोरियम।
Yes, sir. Yes, sir.
Am I audible in the auditorium?
Yes, sir. We can hear you, sir.
Yes, sir.
Are you getting CT scan on screen?
Yes, sir.
Yeah,
We
yeah.
can see, sir.
So this is about the next case. We have seen 2 FAST cases with different anatomy and findings. Third one is with another interesting findings. We have 7 or 8 FAST cases in the workshop with all different, variety of cases. So this case, let us focus on the CT scan first with some positive findings, different from the others one. This is frontal sinus on coronal. Then to begin with, these are 2. See this frontal sinus. It looks like 3 frontal sinuses. Now, how to get to know which one is frontal, which is something else or what? That is possible only on the dynamic imaging. See this. Now focus. This is frontal sinus. This is frontal sinus.
Yeah.
And can you see this middle one cell? मेरा cursor आ रहा है screen पे? Huh? Yeah. Can you
Yes,
see
sir.
this
We
cell
can
in
see
the-
your cursor, sir.
Can you see this middle cell on the screen?
Yes.
See what is this? Anybody?
Hello?
Yes,
This
boss.
interfrontal septal cell.
Yes. See this, how big it is.
Yes.
Let me go back to the previous picture, the anterior most. Looks like 3 frontal sinuses. And see what this frontal cell has done to the frontal sinus outflow. It has pushed this right side frontal sinus outflow far laterally.
Yes. Yes.
See this, how big this is? Pneumatizing the intersinus septal cell.
Very, very.
And see, it is communicating with the right side frontal sinus. Can you see now?
Yes, sir.
See, communicating with the right side frontal sinus. And this is the frontal recess now, once the beak has gone.
Yes, sir.
Again, this is the beak. This is the intersinus septal cell communicating with the right side cell. And
Yes,
it
sir.
has, the beak has gone and now it is draining in the frontal recess. So, the right side anatomy is interesting. Showing the huge intersinus septal cell. Looks like bigger than the frontal sinus. And that is frontal sinus. This is pure frontal sinus and now it is frontal recess. So, the intersinus septal cell is much bigger one. On the opposite side, what we see, this is the level of the beak. If we come anterior to posterior, this is the level of the beak. And at this level above the beak, there is one cell in the frontal pathway above the level of the beak.
Yes.
This looks like type 3
Type 3.
frontal cell or Kuhn cell. Now, how to differentiate this is, see, there are group of cells in the frontal drainage pathway. Some of them are anteriorly attached to the frontal drainage pathway and some are behind. How to know which cell is this? So, we'll take the help of sagittal.
Sagittal structure.
See this. That will absolutely clear what kind of cell it is. See now, my cursor will take on this cell in the sagittal plane. Can you see this cell in the sagittal plane?
Yes.
See this cell? This is anteriorly placed. Can you see?
Yes.
Attached to the beak and frontal drainage pathway is behind this cell.
Yep.
So, when you are operating from this side like this, you have to go behind this cell and get rid of this.
Okay.
Widen the frontal pathway. See how the frontal drainage pathway, let me show like this, remove this and let me show this. Frontal drainage pathway is from here till here. Can you see?
Yes.
1.15 centimeter. Out of this, let me remove this. Out of this, from here to here, 8 millimeter is occupied by this cell.
Okay.
So frontal sinus is draining from behind this cell from this narrow pathway. Now to get rid of this cell, we come from here with a 70 degree. We will see this cell. We have to go behind this all the way up.
Yes.
And then get rid of it anteriorly. Now, with the rotation from here with a 70 degree here, we have to go almost 1.5 centimeter up with our instrument to go behind this. If you are experienced, you can see this cell and you can pass your instrument behind and get rid of this.
Yes.
If you find difficulty in accessing, you can drill away this beak. See this beak?
Yes. Okay.
You can drill away this beak and get onto the cell directly.
Okay.
That will require a draft procedure. But I am quite hopeful that I'll be able to get rid of this. See this cell?
Yes. Yes.
Get rid of this cell from inside only.
The right side is wide.
Pardon?
Right side appears to be wide frontal, and the left side it is compromised.
Right side?
Appears to be wider frontal recess.
Yeah. See, right side, this is intersinus septal cell.
Yeah. Yes. Yes. Yes.
Opening in the frontal on this side, narrowing the frontal recess like this.
Yes.
Left side is a type 3 cell, narrowing the frontal recess. See,
Yes.
all these things are complicating the frontal drainage pathway. In the previous two cases you have seen, the first case we had a supraorbital cell, we had an intersinus septal cell. Second case was straightforward. The third one, this is type 3 cell and this is intersinus septal cell. And see, once the frontal recess starts, this is the supraorbital cell. Can you see?
Yes.
See the maxillary sinus in view. And this is the cribriform plate here, and this should be the supraorbital cell.
Okay.
I think it is clear to differentiate amongst all these cells to everybody now.
Yes, very clear.
Let me show you on one of the presentation. Our case will start in 5-10 minutes. Let me show you. See this. See this?
Yes.
This is a simple Aganegi cell. And above that is frontal cell. See, this is the simple Aganegi cell. You can see here.
Yes.
This is the simplest situation. All these cells, let me go back. Yeah. There are group of cells which are attached to the anterior wall, pushing the frontal drainage pathway behind. What are those? Kuhn cells and Aganegi cell. Then there are cells which are attached posteriorly and they narrow the frontal recess from behind. Those are suprabular, supraorbital, and frontal bular. Suprabular, when goes in the frontal sinus, it becomes frontobular.
Yes.
Am I audible?
Yes, yes, very much.
So these are the group of cells. Now, how they look like? See this. This is the Aganegi cell. Simplest situation.
Yes.
Like in the last case.
Yes.
Just go behind it, get it out, and you have a wide frontal pathway. So this drainage pathway is there and the cell is anterior to it. These are anterior group of cells. Now to add on to the complexity, Kuhn has described variety of cells pneumatizing this frontal bone here in the frontal recess. See this again, one cell above the Aganegi. This is frontal recess type 1 cell.
Yes.
Another cell above the Aganegi, but it's still below the level of the beak. Now you have tier of cells, 2 or 3 cells above the level of the Aganegi. Can you see?
Yes, 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 yes.
Further complicating because you have to clear the frontal recess, you have to individually clear all these cells. So this is Kuhn type 2. Little difficult, but still below the level of the beak. Then this is frontal recess type 3 cell. The cell is going above the level of the beak you have seen just now in our next case. And there the cell is going above the level of the beak.
Yes.
Once cells go above the level of the beak, what we have to do? We have to go above and get rid of it. We have to go above and beyond the cell. And that is the difficulty we are going to encounter. See this. This of a cell which has gone above and beyond the beak. The next case is similar to it on the left side. See this? Now, add on to the difficulty further. If you have an isolated cell or the cell which is gone further beyond, more than the half of the height of the frontal sinus. Now, if the cell has gone beyond 50% of the height of the frontal sinus, coming from below and going all the way is very, very difficult, sometimes impossible. And that situation, what we need to do is drill away this beak which is posing difficulty. Drill away this beak posing difficulty, and then the cell is in front of you. That is draft. In type 4, mostly the draft is required for adequate cell removal and establishing the drainage. I hope it is clear. Hello?
Yes, sir. Very clear.
Now, there are group of cells which are attached to the posterior wall. See, above the bulla ethmoidalis, this is suprabular cell. Now, what this cell is doing? This is narrowing this pathway from behind.
Yes, yes.
The frontal drainage pathway is here, and this is narrowing from behind. Now, you can't afford to go behind the cell and fracture it out. If you try to, you'll end up breaching the skull base. So, if you find a suprabular cell like this, coming from here, you have to open up this cell and flush with the skull base, rather than trying to go behind it. And sagittal section will unveil it completely. That's the most important, section to clarify whether it is attached to the anterior or posterior wall. Now, if this suprabular cell goes beyond up right into the frontal sinus, now adding on to the difficulty again to reach out to the cell above and beyond and flush it with the posterior wall. This may require a draft again. So again, you can't afford to go behind. Be careful. Identify on CT scan. Get the sagittal, not only print out, get the dynamics so that you can see exactly where the cell is extending from where, like I had shown you just now. So this is frontobular. Now, if you have a cell like this, how will you differentiate whether it is a type 3 or frontobular? On coronal, they look like same. How can you differentiate? How can you differentiate? This is, I will tell you, this is supraorbital cell. See this? This is frontal sinus. This cell is behind and lateral. You had seen in the previous case.
Yes.
I told you that is behind the frontal sinus and lateral. You had seen in the last case.
Okay.
That is supraorbital, pneumatizing the space above the orbit.
Yes.
See this? Now, intersinus septal cell you have seen twice. So, they pneumatize into either of the frontal sinus that you have to see on a dynamic picture. Now, whether it is a frontobular or a type 3 cell, how can you differentiate? See, this type 3 cell is attached to the anterior wall. It is a much anterior anatomy. And once you see it is attached to the anterior wall, you will find the agarneji below. When it is a type 3 cell, it is far anterior, you will find the agarneji below, and you will not find the frontal maxillary sinus pneumatized. That means you are too anterior with a cell going above the beak. That is type 3. When you find the maxillary sinus below, more posterior anatomy, cribiform coming into the picture, then it is a frontobular cell. So basically, both the cells are rising up in the frontal sinus. One attached to the anterior wall, one attached to posterior wall. Both have a different, treatment strategy to get rid of. Only thing is to differentiate, and CT has a role. A dynamic CT, multiplanar CT on DICOM has a clear answer to differentiate whether it is a type 3 attached to the anterior wall or whether it is a frontobular attached to the posterior wall. This is how you can differentiate between these two cells. Anything before we start? Hello.
Yes, sir.
Yeah. So this is the case here today. What we have seen, this is the intersinus septal cell, this is type 3 cell, complete opacification of the entire ethmoids, complete. And a good type 2 cribriform plate, I can say, that's the interethmoidal artery. That's the interethmoidal artery, more pneumatized on the right side, below the level of the skull base as compared to the left. See, larger postethmoidal cells. Yeah. Another interesting finding. See, this is postethmoidal cells. If you follow these postethmoidal cells, yeah, one of the postethmoidal cell is still going up behind. There could be ONOD, bilateral ONOD situation, where this postethmoidal cell has gone beyond the anterior margin of the sphenoid. So this could be ONOD. Once there is ONOD, the optic nerve comes to lie in the lateral wall of the ONOD, then the lateral wall of the. Let me show you. That's interesting. See this on axial. This is optic now coming into it. Or let me show you soft tissue.
Yes, sir.
This is an interesting situation to understand the ONOD. Now, let me first show you the optic now. See the optic now.
Yes, sir.
That is the optic now. That is the optic now. And what happens? Once there is an ONOD cell, this ONOD cell, this is a postethmoidal cell, the sphenoid is behind. This ONOD cell comes to lie in contact with the ONOD rather than the sphenoid sinus itself. So you have to be careful in that situation because ONOD is a postethmoidal cell. If it is coming in contact with the optic now, you have to be careful not to disorient and protect the optic now. So that is another scenario. So that is all about the positive findings in this particular case. So as compared to the previous two cases, this is another interesting situation. So let's start this case. Any questions before that?
No, sir.
No question, sir.
Okay, let's go ahead with the surgical part. Hello.
Yes, sir.
Yeah. Are you getting the endoscopic picture, sir?
Yes.
So, so without any preparation, and I'm going to use the Merocell same adrenaline soaked Merocell pieces for the preparation. This is left side. You can see the polyps.
Yes.
And same on the right side as well. Which side you want me to do first?
Sir, use the mic.
Hello. Hello.
Yes, sir. Right side, sir. Start with the right side.
Right side. Okay. May I know any reason for that? So this is the initial preparation.
Yes. Satish, please explain uh, how to decide which should be done first, which should be done later on.
No, no. See, we have to operate upon both. But yes, when it comes to decide, sometimes you have a gross deviation. You can operate on the roomy side first, then correct the deviation and go to the opposite side.
Yes, yes.
Here I ask because both sides have different findings. So I ask for any specific reason if you want me to show first anything. See, the nasal cavity has opened up.
But
See, after the decongestion, the picture has dramatically changed.
yes,
See, unlike the previous turbinate, this turbinate looks floppy. Can you see?
yes.
I appreciate Farooq's idea of keeping number of cases in a row so that people can see variety of situation one by one. So every case is different. So here we have to deal with a floppy turbinate now.
Yeah.
Unlike the previous cases, the turbinate was good.
Good afternoon, sir. This is Dr. Kranti from AIMS Patna. If you can hear me. Hello.
Shanti, how are you?
I'm fine, sir. Sir, just got a bit sick a few days back.
Oh, really?
Yeah. Sir, I have a question. When you are operating unilateral polyposis or unilateral nasal diseases, what do you do with the opposite nostril? Do you, like, if in case you have to do you decongest? Is there a concept of rebound congestion or something like that?
No. Operating on unilateral diseases for what? Sinusitis.
Yeah.
So if the opposite side is normal, you don't have to do anything practically.
So you don't decongest any on the opposite side?
Not really. For why? Why? Because decongestion is not.
Yeah, it's just a habit that people usually, would decongest the both sides. And I've seen that.
No, rather, I would not even touch the opposite side if it is normal.
Yeah. And how long do you do this merosil decongestion? Like around
Yeah, 5 to 10 minutes.
5 to 10 minutes.
I am ensuring that the marrowcell is applied on the mucosal surfaces everywhere. See, this adrenaline is applied topically. That's it. See some cheesy secretion coming.
Yeah.
So on the right side and the left side, the situation as compared to the previous case is different. The turbinates are problematic, looking problematic. Now let's first debride the polyp and explore the anatomy.
So what is your plan for floppy turbinates?
Variety of ways.
Okay.
Sometimes we Bolgerize, sometimes we do a partial resection. Sometimes you can suture them also.
Yeah.
So depending upon the condition of the floppy turbinate, we have to take a call. Now see another important thing.
Yeah, totally polypoidal. Yes.
The first thing I would mention here is, particularly in the upper part, not to do anything. This patient must be having olfaction issues also.
Yes.
Because this mucosa in the olfactory region is affected, inflamed, leading to the olfactory loss or something. See this?
Yes, sir.
Once you remove the overall inflammatory load and the topical steroids start penetrating, this should revert back to normal. So this mucosa should not be, or even the polypoidal, or even the polyp in this region should not be disturbed to invite fibrosis. This should not be disturbed. Otherwise, it may invite fibrosis and then lead to permanent loss, olfactory loss. So in these situations, this olfactory region inflammation should be left undisturbed, and our future topical therapy should take care of this. This olfactory loss is mostly visible, mostly. See, there are two ways of olfactory loss because of the sinusitis. One is a conductive loss, another is a sensory neural loss. Conductive loss means because of the polyps, whatever air you inhale, whatever smell, whatever substance to smell is not reaching to the level of the olfactory mucosa because of obstruction due to polyps or any region, tumor, whatever. You remove the obstruction, whatever mucosa which is uninflamed, it is going to come back. That is conductive hearing loss. Another is sensory neural hearing loss. Means the inflammation which has involved the paranasal sinuses has involved the olfactory mucosa as well. And part of that may have gone to the neural level also, made it irreversible. That is beyond your control. That's why many a time patients ask, will my olfaction come back? What you can do, simply give him a course of 10 to 15 days of oral steroids. Let the things, the inflammation return, let the inflammation reverse, come back, and see if the patient olfaction improves. Any sign of improvement of the olfaction after the oral steroid challenge gives you a good idea that it is a conductive loss, or it may be sensory neural but not irreversible, and that it can be taken. You can prognosticate your patient accordingly.
Sir, in these patients of CRS, what you are operating, what is your pre-operative protocol for? Do you use steroids pre-operatively for some time and then take them for operation?
Yes, always. See,
So what is your schedule, sir?
yeah. So for polypoidal sinusitis, always steroids, and depending, see, it is not hard and fast because there are other issues also. Sometime, yes, once very well planned, minimum 7 days.
Okay.
Sometimes you have to do early for patients coming from long distance. You may not be able to give 2 days, 3 days, or whatever. So, but it should be given at 7 days, ideally. Of course, our choice is prednisolone. 7 days, and it really helps a lot in
Polypoidal cases.
in polypoidal disease. In non-polypoidal, there is no point.
No point. Yeah.
Steroids hardly have any role. Yes, you can give a course of antibiotics. In polypoidal also, if there is secondary infection along with because of the blocked sinuses, whatever, you can add on an antibiotic also.
So your antibiotic for polypoidal cases is almost similar, like the what we use as macrolides, or is it something different?
No. For polypoidal, a broad spectrum covering the Staph aureus.
Okay, Staph aureus, yes.
For polypoidal.
Yes, sir, got it.
Yeah. And we never give macrolides.
Macrolides for, yes. Elevate.
The IgE is low. That's important to investigate, to prognosticate. If your IgE is high, your macrolides have practically no role. So, macrolides work by affecting the neutrophilic activity solely. You know, if the patient's IgE is very high, that means eosinophilic disease, and macrolides have hardly any role. See the kind of oozing. You never know the kind of pre-operative preparation, like you asked just now.
Yeah.
How the pre-operative preparation for every patient, because this is workshop.
And the other thing is your thoughts about using hemostatic agents, like because there was this this has been thoroughly very much researched about the role of tranexamic acid, not in US but in European countries and Australia as well here, regarding the role of tranexamic acid.
Yeah, we have
So
also
what-
gone through.
Yeah.
But see, there is no recommendation so far from anything.
Yes, true.
Studies are done, but no recommendation. No studic studies. So people have been trying tranexamic acid and other hemostatic agents. May get benefit, but we have never tried, and I can't say for that.
Do you try it even if in cases like it's been bleeding at least for a day or two of IV Tranexa, and then have you seen any effect?
See, all these agents, if you
Yes, sir.
see how they work, they prevent, they are anti-fibrinolytics.
Fibrinolytic, yes.
So they prevent fibrinolysis. And they have a value practically when there is too much of blood loss.
Right.
Like the patient may be going in DIC or something.
Yeah.
When there is a massive blood loss, in those kind of situations, you can think of. But normally, I don't see any practical role of all these agents in a sinus surgery. For BP. See, this is a hypertensive patients. We are waiting for the BP to come down. The BP
So what is your 200 plus? Okay, that is very high.
Yeah. Your question?
So what is your recommendation for the trainees to keep? What is the BP blood pressure level which you prefer for your patients?
Normotensive.
Normotensive. Okay, you do not go for hypotensive anesthesia.
No, never. Only reduce cardiac output by means of
bradycardia. So
bradycardia. Yes.
bradycardia. True. Sir, for again trainees, if you can, tell us when you're seeing this kind of polypoidal mucosa, there are times when the middle turbinate itself is so polypoidal. How do you differentiate, and what are the basic landmarks you look at to prevent that the turbinates are saved or the important structures are? So if you can just, give your certain tips and tricks for that.
Yes. So, turbinate, like I've always said, are most important structures for your orientation. Sometimes turbinate become the site of disease, like concha bullosa, hypertrophic turbinate, or sometimes the turbinate becomes thinned out, atrophic, or floppy, like in this patient. So turbinates have varied presentation and their identification is very important, which is difficult mostly in massive polyposis situation. So the CT will guide you first of all if there is any concha or any hypertrophic bone. See, this enlargement of the turbinate is not always because of the concha bullosa. Many a times because of the hypertrophy of the turbinate bone also. See, because of the BP. What are the other ones?
Ooze is now it is a bit stabilized.
Yeah. So let me first go to the opposite side and then we'll come back over here. The opposite looks better.
Yeah. I think that's always a good way to do CRS, because if one side is oozing, better pack it, do the other side by the time it actually
Always good.
Yeah.
You can save time, you can identify the landmarks better rather than operating in the bleedy situation.
Yes, sir.
Same thing we are going to do in this case as well. This case, the turbinate identification is not difficult. We have already seen. Many a time, the uncinate identification becomes a problem.
Yes.
But turbinate, ultimately, you can go to the axilla to identify.
Yes, but
uncinate becomes difficult sometimes. And this turbinate I had shown you is not very stable. See this?
Yes, it's very
Not
floppy.
very stable. So ultimately, we'll have to do something to it. And I have reasons to do, some sort of partial resection, because see there medial to it above.
Yes, and there's a lot of
disease. So I will do a partial resection so that my topical steroid will approach the olfactory region much better. So rather than a pure bulgarization, a partial resection will be more helpful in such a situation. That's my point. Because the ultimate goal in such disease is making the steroid reaching to the paranasal sinuses and olfactory region. See that? This turbinate is going to obstruct the steroid reaching there. Can you see?
Yes, yes, sir, we can see that.
So let me show you what is my partial resection. Keeping the axilla intact.
So you are keeping it intact to keep the anatomical landmark in view. And
Yes,
yes.
always, never chop, never chop.
And axilla is also important to have your landmarks to your frontal sinuses.
Yes, always.
Sir, in such polypoidal cases also, do you go for those the concept of intact bulla, or you do the frontal at the
Yes,
last?
intact bulla is a different philosophy.
Yeah.
Intact bulla is for frontal sinus.
Only frontal sinus diseases.
Yeah.
Okay.
Section and all that.
Yes, sir.
Intact bulla has nothing to do with this.
This kind of CRS. Yeah.
Now see, my olfactory region will be
free,
much better exposed to the topical steroid reaching there.
And so you are not touching the polypoidal mucosa on that side, isn't it? Are you going to debride that also?
On the
medial side of the
yeah, that I would avoid.
Okay.
Unless there is gross polyposis, I would avoid.
Okay, sir. That's an important point which you have discussed.
More you do over there will invite fibrosis. Potential of giving a permanent olfaction loss.
Olfaction loss.
So better not to give raw area into that. Once topical start reaching there, this will revert back to normal. We have seen this scenario reverting back to absolutely normal mucosa.
That's a very important point you told us, sir. Because we very enthusiastically do this, and later when they complain of anosmia, it's a big problem for the surgeon.
Then you can't do anything.
Yeah, you can't do anything. Anosmia is one of the most difficult things to treat. And post-COVID, we have seen how difficult times they give us as ENT surgeons.
Yes.
Sir, along with this, also tell us something about the management of inferior turbinate enlargement. What is your protocol? What do you do about it?
Inferior turbinate enlargement.
Yeah,
Yes.
in case like you have a lot of septal deviation, both side turbinates are boggy, in the posterior aspect, it is very sort of polypoidal. So what do you do with your inferior turbinates?
Yeah. So many times in allergic situation,
Yes, sir.
we do need inferior turbinate, management. Now there are many ways, depending upon the situation of the inferior turbinate.
Okay.
Sometimes it is bony hypertrophy, then obviously we do a partial resection.
Yes, sir.
I mean, partial resection is very safe, and that's the only answer. If it is a boggy hypertrophic, then it is different situation.
Okay.
And in that situation, we add on posterior nasal neurectomy also.
Okay. Okay.
When there is a boggy turbinate, inferior turbinate, allergic, because posterior nasal neurectomy is a selective neurectomy to the nerves, postganglionic nerves supplying the turbinate. And that's a very simple procedure I can show you at the end. In less than a minute, you can finish. That's it. Without any complication, I would say.
Okay.
And that helps in, reducing the stimulation to the inferior turbinate, the glandular stimulation.
And the bogginess will obviously come down with time.
Yes. You can do mucosal coagulation also.
Okay.
Along with that. This turbinate doesn't need, this inferior turbinate to me doesn't need any treatment.
Yeah, this seems to be, the corona is fully nicely visible.
Yeah.
You don't have to do much about it.
So I will show you at the end, remind me of the
show us the landmarks and how we do it.
Posterior nasal neurectomy, yes. That's a selective neurectomy than median neurectomy.
Okay.
Median neurectomy is hazardous many a times, can lead to dry eye.
Dry eye.
But this posterior nasal neurectomy is selectively affecting the nasal and the palatine glands, nerves, and it doesn't give to any such complication. Very simple and safe operation.
So I think you have shown it so beautifully. For so long you are trying to decongest, use coagulations. For resident, it's so important to understand that you just don't have to keep on operating in bloody field, which really makes it very hazardous, endoscopic sinus surgery. You need to have patience. So that's what sir is doing. He's doing it beautifully, the way he is decongesting every time. And then also using coagulation or any coagulation devices to, yeah. So this is very nice, sir. Yeah. And if you wait enough, and what about the irrigation you are using? Is it warm saline or is it the normal saline, sir?
Normal saline.
Normal.
We, for that matter, since you asked,
Yes,
we
sir.
never use and recommend warm sinus disease.
Okay, so
We
that's
are operating for the sinus disease.
interesting. We have been using warm saline for decongestion. So.
No, not for sinus disease.
Okay.
Because here we are dealing with a compromised mucosa. There's an immune compromised disease.
Yes, sir.
Affecting the mucosal immunity. You know, and this warm saline can further affect the ciliary activity.
Okay.
That we use in tumor situation with the normal, immunity of the mucosa when you deal with the tumor. Now see on this side, the landmarks. This first prominence belongs to
Medullary crest.
the second one and the only mobile structure in the entire lateral wall. See this?
Yes, sir.
This is turbinate. Sorry, the inferior, the uncinate process. Uncinate process.
Yes.
In between the uncinate and the bulla.
Hello.
There is inferior, and in between here, laterally the infundibulum. So my first step in the surgery, like we have shown since morning, if you witness, is the infundibulotomy. Infundibulotomy is one process wherein through the uncinate process, we open up the infundibulum, wherein the maxillary sinus ostium opens. So you can carry back biting, first biting forceps. See this?
Yes, sir.
Bite through it. Come anteriorly unless you come across the hard bone. If you come across the hard bone, you need to stop. Because anteriorly this is nasolacrimal system. That's my point. And we are not supposed to bite through it. In case you have accidentally bitten the nasolacrimal duct, suppose, it can invite fibrosis and cicatrization and ultimately epiphora after a couple of days. See, this is the inferior horizontal process of the turbinate, this uncinate process.
Uncinate process.
Which I am taking off. This is the horizontal uncinate. I can take with the through biting also. See this taken up?
Yes, sir.
Completing this middle meatal antrostomy. Now, the size of the middle meatal antrostomy depends upon the pathology there. If you have too massive a disease inside requiring more, surveillance, more steroids inside, see, you can evert this mucosa out. See this?
Yes. To always enhance the epithelialization. Mucosalization, sorry, not epithelialization.
See this middle meatal antrostomy. Now, I don't see any massive disease, so I am not enlarging it.
Okay.
Had there been a massive fungus or something, what I could have done? I could have enlarged to type 2. Type 2 means I would remove this medial wall completely until it flushes to the posterior wall.
Okay.
Type 3, I can flush it, removing the part of the inferior turbinate to the floor of the nose to give additional gravitational drainage. That's my point. So, according to the need, you can take a call. There is nothing hard and fast. See, everything you have to address according to the pathology. So this is simple middle meatal enterostomy. Now next step, as I said in the morning, the next step is this is the upper part of the uncinate. This is one of the most important now. Go further, and it takes you easily in the beginning of the surgery to the lateral limit of your entire sinonasal corridor. And see the movement. Go behind it and fracture it anteriorly. This is the safest movement for at any step in sinus surgery, when your movement away from the critical structures behind. That's the bony plate. See this? And now at this point, what you have to define is immediately lateral to it is the lamina papyracea. So that is your medial limit of the entire lateral limit of the entire sinonasal corridor. See the lamina?
Yes.
Can you see there?
Clearly visible, sir.
See the plate there? So that is your lateral limit. Now, at the beginning of the surgery, we are on our lateral limit. See this? See the lateral plate very clear?
Yes, very clear.
So that is your lateral limit of the entire, sinus surgery. So now we have, in our medial limit, we have turbinate. In our lateral limit, we have lamina. See this?
Yes.
So that is one of the, I would say, amazing guide. And don't forget this upper stump of the uncinate. Band ho gaya.
So the upper stump of uncinate will also help to somehow guide towards the...
Yes. So that we don't deviate far medially to hit the skull base.
Yes, sir.
See, once you work in the frontal sinus region, there are a lot of interesting structure all around. That's why frontal sinus is challenging.
True.
Orbit is in close proximity. Skull base is in close proximity. Its strategic location, you need to use angle instrument with angle telescope, which can disorient you if you are not used to it. Then if you are not oriented, like in the previous case, I had shown you the relationship with the anterethmoidal artery. So there are so many challenges in the frontal sinus that we must know and accordingly address the situation. After every step, move with the marrow cell to get the best view. See, at every step, you have to be do something to improve your view. Now, at this step, I'll change to 70 degree. I have my medial and lateral limits in view. Yes. See with the 70 degree. Can you see the lateral limit lamina?
Yes, very clearly visible.
And here is the stump of the turbinate.
Yes.
This is your bulla. Here.
So can the external camera show the way you are using the instrumentation? Many of times when in the learning curve, using 70 degree with a instrument is what is challenging because it often crosses. So if somebody can show as to how
that's why the cadaveric workshop are important to get used to instrumentation. So now I am working here up with a 70 degree. I had shown in the previous case in detail what all to be taken care of. See this. Number one, the beauty of 70 is you can keep your both the limits in view. See my left and medial limit in view. See both?
So currently are you using a curved deep rider blade?
Yes, that's 60.
That's 60, okay.
Now see, I am between my medial and lateral limits. staying between medial and lateral limits, you have to look for the beak. Simple.
Frontal beak, yes.
When the beak is there, the frontal sinus is immediately behind the beak. As the beak ends, let me show you. Let me reduce this cell a little bit to show you better. See this. One second. See the beak there. This particular patient has a cell riding over the level of the beak. In this particular patient.
Can you use a curate and show us more clearly? Yeah.
See
Okay.
what I am trying to show you. This is beak.
Yes, sir. And now you're going medial to that.
Yes. Can you see this beak?
Yes, yes, yes. Very clearly, sir.
So what you see here, can you see this cell?
Just behind.
It looks like sinus, you know. It looks like frontal sinus.
But it is not. Okay.
It is 100% not.
Yeah,
Why?
it is more medial. This will be, yeah, it will be more medial. Yeah. Frontal sinus.
Not only that, we had seen in our CT scan.
That is the pathway.
This is one of the cell. And see this wall of the cell.
Yes, sir.
See the wall of this cell. My frontal sinus opening is medial to it.
Medial to it. Very true.
And this cell has narrowed the frontal outflow.
Okay. The one which was visible in the CT scan. Very true.
Yeah. So what this cell has done, it has narrowed the frontal sinus.
Outflow tract.
But this cell is sitting on the mouth of the frontal sinus. See, that is frontal sinus, true sinus.
Very, very true. Very nice.
For all those guys, I'd explained all the variety of, frontal sinus cells. Again, anybody has any doubt? See, that is the frontal sinus, true frontal sinus, and this cell is sitting on the mouth to narrow this opening. This is sitting on the mouth of the frontal sinus to narrow it. That is type 3 cell. Now you have to get rid of cell to go beyond and fracture it out. What's my point? Now, if it is too big, getting beyond that cell is a real difficult job. Let me show you patla dena back. Now I will just clean the area and show you step by step, so that you will never forget. See, for everyone, this is your frontal sinus drainage pathway. This medial one. And this one is a cell which has narrowed the pathway till here. If I widen this, my pathway will be bigger. Can you see?
Yes, sir.
Let me just a minute back with the marrow cell, clean the area, and give you a perfect picture there. Now the challenge is how to get rid of this cell. That is the maxillary sinus. That's the lamina. That's the axilla. I hope you are oriented.
Yes, sir. Perfectly oriented. So the take-home message is that one should always try to explore the medial pathway. When you get a cell, you should go to the medial pathway and search for the real frontal sinus opening.
Yeah. Now see, this is your sinus and this is the cell. This is the cell which has narrowed, you know. this cell.
And so you're making them one. That means outflow tract, you are enlarging it. By
See, I have gone beyond this cell.
Yes.
And getting it out. See
Yes.
this?
Yes, yes. Very nicely done, sir.
I should not leave a remnant. And imagine how wide would be the frontal sinus pathway.
Yeah. And the steroid can easily penetrate that area as well.
Yeah, see, still there is a
one chip there, yeah.
Yeah, remnant is there. Because the challenge is to go up and beyond that. See that?
Yes, sir.
This all planning came in my mind from the CT scan. Simple. See this? This cell, this remnant is still there. See this?
Yes, sir. Yeah, you're using RAD60 to do this debriding. Yeah, very nicely done, sir. Excellent.
Now see the true frontal sinus.
Totally in view, completely.
See the frontal sinus? That's the frontal sinus per se. Can you see that?
Yes, sir.
See how big it is now. Earlier it was a narrowed opening because of the type 3 cell. If you remember the CT scan, everybody. Dr. Kanti, did you see the CT scan?
Yes, so when you were explaining, I came online. I did see, and you explained it beautifully. And actually, it's matching. The finding in
that was a type 3 cell.
Yes, which was
See, this is
narrowing the
my
frontal
beak.
outflow.
See my thick beak.
Yes. So will you drill that or just leave it?
No, not really.
Not really, huh? But the pathway is already so enlarged, yeah.
The anterior to posterior where the beak ends is the frontal sinus.
Frontal sinus.
This anatomy can never change.
Beautiful.
See this? Yeah. Wide opening. Give the widest possible. So this side, the interesting fact was the type 3
Type
cell,
3
which
cell.
we have removed and made a frontal sinus outflow pathway unimpeded.
So sometimes I've struggled when I'm operating frontal sinus, as even for a lodged up very laterally placed fungal balls. So as I keep washing most of the time. It takes so much time. It's almost like delivering a baby.
Have a hydro debrider.
Okay, with a lot of pressure it goes inside.
Yeah, it has a jet.
Okay.
It is meant for that situation only.
Okay.
Now see the widest frontal drainage pathway. See now no cell is coming in the way.
No.
I hope everybody has understood how to get rid of type 3 cell from below. See that? See the wide frontal opening. That is wide opening of the frontal sinus. Now, section. Give me reverse. See my limits for the frontal again, everybody. Laterally lamina, medially middle turbinate, and anteriorly this beak. That's my point. Now I will flush little bit of the skull base here with the reverse blade, the so-called adenoid blade, which we never recommend for the adenoids, for that matter. Yeah, flush the skull base. See, my cutting edges are under view. I am not pressurizing anywhere. Yeah. Or the see, just flush this posterior table with the ethmoidal skull base. See this? That's the posterior table, what you're seeing?
Yes.
Don't worry about the anterethmoidal artery, it is far behind still.
Yeah. Slightly posterior to this edge, yes.
Yes. See this, how big the opening is now. So, what is the, compromise one can do here by not flushing this with the posterior table? Yeah. See behind, this is ethmoidal skull base.
Yes,
See
sir.
the mucosa,
Yes.
the ethmoidal skull base. Can you see the mucosa there?
Yeah.
That is ethmoidal skull base. I am using the reverse blade. That's the beauty of this blade. It is safe, done under vision. That is the posterior table of the frontal sinus. And this is flushing the. See the posterior table of the frontal flush with the ethmoidal skull base. Can you see very clear now?
Very clear, sir.
That's the beauty of the reverse blade. See that? Completely flushed. Now I'll come to the bulla and ethmoidal artery part. Until now, you don't have to bother about these two things. Now, this is my bulla. See this? Give me. And this way, I am reaching to the skull base behind. Whenever you use debrider, never use pressure. Allow the tissue to fall into it. See the level of the skull base. Yeah. Clogged. The moment I remove this remnant of the bulla, you'll find a different picture. That is my area of the anterethmoidal artery. I've almost cleared that. Can you see the level of the skull base now?
Yes, sir. It is all coming in one line, yeah.
Yes. See now, what I'm trying to say is,
And the inclination.
see the posterior table there?
Yes.
Then the beginning of the ethmoidal roof. Can you see here?
Yes.
And that is the supraorbital recess there.
Yes, and just the anterior model is posterior to that.
This is the supraorbital recess.
Yes.
And caudal to that, this is the anterior model.
Anterior model. Very nicely seen, sir.
Caudal to that.
Yes. And that is why when you are opening the frontal, usually people are very scared that anterior, but anterior model are usually posterior to the to that
supraorbital
level.
cell.
Yes, always posterior.
Always posterior to the supraorbital cell.
Yes.
So this is the level of the anterethmoidal artery. See how the skull base is coming. That is the posterior table. That is supraorbital cell, and that is the supraorbital cell. This is supraorbital recess where my instrument is going.
Yeah, the one which you showed in the CT scan.
Yeah, like a 120. I will show you. This is a recess, not very deep, but still wherever I can go, I will show you with an angle divider. This
But
is
are you
not
going
very
to
big.
write that? Is it necessary or you want to just?
No, no, not. See this. What I am
Yes.
trying to say, frontal sinus is anterior. Supraorbital recess is behind.
And that is the supraorbital recess.
Yes. Can you see that up?
Yes, beautiful, sir. Beautiful visualization.
Now, if you want to widen it, narrows the frontal sinus outflow, you can remove the party wall. That's it.
Yes, sir.
See this. Let me show you. I am showing you to the people who find difficulty in identifying supraorbital region. See this section. Let me show you. Find out. Let me clean it. Wait a minute. Oops. Now, wash. Yeah. Yes. Leave it. Leave it. Now see. That is frontal sinus above. This is supraorbital recess below. Can you see behind?
Yes, sir.
Now, if this supraorbital recess is too big and narrowing the frontal sinus outflow, you can remove this party wall. Can you see this? What I am doing?
Yes, yes. So that the whole track becomes one.
Simple. 120. I intensely showed you how to deal with. See this? I have communicated as a. Is that clear or not?
It is very clear, sir. Very clearly visible.
Now, this supraorbital recess and the frontal. See, I have further widened the frontal sinus drainage. Simple as that. In case needed, you can do it. Okay? And immediately caudal to this. This is my anterior modal artery.
Yes.
See? That is the bone over the artery. Can you see? Section they want to put it. Just to show you where the vessel is. See the frontal, supraorbital communicated together. Reverse. Can you see both the things together? And this is the bone. This is the bone over the artery.
Artery. So, but do you remove this bone routinely or you just
No.
show us?
Just to show you where the artery is.
Okay.
See this? So that nobody gets confused ever. See the artery. Can you see the vessel there?
Yes. The soft vessel. If you can just go it a bit there.
Band hai. So now the whole anatomy is clear. Never forget this. Most anteriorly, the frontal sinus above. Behind that is the suprabular cell and supraorbital recess pneumatizing far up. Can you see? I remove the party wall and made them together, join them together, and immediately caudal to this suprabular cell or supraorbital recess, whatever, is the anterior modal artery. Is that clear or not? This is me, which is very, very useful in sinus surgery when you work the frontal and the anterior modal skull base work. See, there's wide openings. See now, the patient irrigation will reach all sinuses thoroughly without any obstruction. See my remnant of the middle turbinate above, help keeping away from the skull base. Can you see? Zero. Any doubts? Changing to 0 degree. See with the 0 degree now up to the. See with the 0 degree. Now what? Maxillary sinus work you have done. Frontal sinus centrethmoid we have done. Now the work left is postethmoid and sphenoid. Very clear? Any questions so far? Hello.
In the chat, sir, I cannot see any question, but might be the audience has some.
Yeah.
Live audience.
So now this is the lower part of the bulla. I am taking off and defining my lamina here, lower down. Now I'm back with a 0 degree. See that the lamina, defining the lamina? Now the most important work before I go behind, which I am always defined, I mentioned in the last case, is to define orbital floor or the maxillary line. See this? Never forget. Yeah. बंद है यार. See, always define this orbital or maxillary line. Line of roof of maxilla or floor of the orbit. That's a life-saving line. Can you see the level of the orbital floor? Can you see the level of the orbital floor?
Yeah, now it's visible, so very nice.
This one.
Yes, yes.
That's a very important landmark for the further work. Safe work. Immediate straight blade. Now we'll be doing the straight blade. Straight blade. See above. Here we have seen define the maxillary lines. Now utilize the maxillary line. I will go behind. Yeah. In the maxillary line, let me show you. Remove this first. See, that is the skull base above. To go into the postethmoids, I will not go above there. I may hit the skull base. In the maxillary line, I will go in the postethmoids. See this? See in the postethmoids, this is middle superior turbinate.
Yes.
This is your superior turbinate. Can you see?
Yes, yes, very clear.
First landmark. Second thing, I will not do this postethmoidectomy first. I will do some safety, exercise, because there could be onodi cell, anything else behind. I can enter into the sphenoid and damage. What I will do in the line of the maxillary lines. See, I am removing this lower part of the superior turbinate as well. Stay close to the septum. Stay close to the septum in the maxillary line. Can you see?
Yes.
I have to go and see the sphenoid sinus first. Simple. I have to define the sphenoid sinus before going further into the postethmoids. Give me section periosteum. See this?
This is not a prepared case.
See this? See, this is your septum. Go along the septum. Never go above the level of the maxillary line. If you try to go above the level of the maxillary line, there you can be in the plenum sphenoidal. And here, just along the septum. Just along the. Pardon?
What is the cause of so much bleeding in this case?
Yeah, it is hypertensive patient, boss. Hypertensive patient.
Oh.
And that is the reason we had experienced so much of bleeding all the time. But
it
not
is
going
just according to the.
Yeah. You have seen in the previous case hardly any bleeding. It depends. But still every time we are landmarks and then going, not blindly. So here, utilizing the maxillary line, now I'm entering into the sphenoid sinus. That will be a guide for posterior work. That will be an amazing guide for the posterior work, as if I stay at this point, I can remove anything anterior to it. Got my point?
Yes.
Without any problem.
Is there any role of image guided system in this type of case?
Yes, always.
Because
if you are disoriented,
image guided is available here, no?
Yeah. If you are disoriented any point of time about the sphenoid sinus,
yes,
you can use that and confirm. For that, any sinus. So that's a good teaching tool. In my front, sphenoid sinus is there behind. Okay? Now, anything anterior to it, I can remove safely. Got my point? Now, all this is garbage now. अच्छी देना 0 डिग्री नहीं ले आप. बंदा. I'm getting a different blade. Now I can remove all these septation staying anterior to the sphenoid sinus without any fear of damaging anything behind. Without any fear of damaging carotid or optic or anything behind. Remove everything anteriorly and remove all these cells and flush with the limits. See, don't leave the septations. has to go. All these. The wide openings. Once you have a metabolic disease, you have to ensure complete steroid penetrating all these areas. You have to do a lot of to make sure that the steroid is reaching there. Changing the blade. What cell is this? Anybody?
Heller cell.
Yes.
But sometimes posterior and posterior quad cell enters the maxillary sinus.
Yes. See the skull base all the way.
Very clear.
नहीं है
Yeah.
blade is clogged. Look. मजा नहीं आता ब्लॉक है section the blade is clogged I think. Take all these cells in the ethmoidal region need to be opened. See, I'm flushing all these cells. See how these cells are being flushed. Oh, the sphenoid is little abnormal. So that's the final thing we have to see. All cells in the ethmoids have been flushed. See this? Cells. Yes. See, so many cells and the sphenoid is almost able to understand. The sphenoid is, see, so thick bone.
Very thick bone, yes.
What do you see?
Unable to cut it.
Yeah, that's why I had to use some instrument who can open.
Used to Carison now.
I know it is difficult to engage the Carison even. Suction करना. See how thick the bone there is. That was the abnormality in the sphenoid. See, looking like a flat bone. Hello?
Hello?
Now will be the complete job. Once I widen the sphenoid,
Okay.
you need a good
Sphenoid punch, yeah.
yeah, sphenoid punch or Stamberger punch or
Yes. Carison, this one. Very thick, actually, the bones are very thick and
yeah. That's why I told you the sphenoid is a little challenge.
three hand technique. Who is your assistant?
Tetwa.
Tetwa. What a name, yaar. Tetwa. Tetwa. Now.
See the sphenoid sinus now?
Yes.
What a thick bone it was. And once I am widening, I will widen to the
Limit.
limits. Is Dr. Kranti online?
Yes, sir. I'm online. I'm watching it, sir.
You see the difficulty for the sphenoid?
Yes, I did see that, sir. It's very thick bone here.
Very bone.
So would you drill that part? Would it be easy for you to use a drill there?
I could drill also. I had the option of drilling. So, lagana. See now, if you recapitulate, see now where the frontal sinus is. Factory region. Can you see?
How will you address this polypoid tissue on the
Steroid. See the skull base, complete skull base.
Yes.
Dawa and Hawa.
See the complete.
Yes, sir.
Carison.
Yes.
This bone is so thick.
So that could be because of the osteitis also, or it could be just the normal anatomy.
No, it could be abnormal.
Most of the time, osteitis.
Yeah, this is abnormal bone. This is never normal.
Too thick. Yeah, too thick. Good evening, sir. Ashwini, sir. Good evening.
See now we have adequate sphenoid opening now.
Yeah.
Yeah, the brighter.
So can you show the landmark for posterior ethmoidal? Just the landmark.
Ethmoidal artery.
Yes.
Post-ethmoidal artery generally passes through the thick post-ethmoidal skull base, we know.
Yes.
And there are many ways people calculate the landmarks for the post-ethmoidal artery. But the most reliable is when you see the optic now,
Okay.
roughly 5 to 6 millimeter anterior. to it.
Anterior.
That's the most reliable thing you can consider rather than calculating from the
Measurement.
anterior or anything. Wash. So that's the final size of the sphenoid. See this?
Yes, sir. Beautifully done.
Wide, full wide.
Sir, and then if you could just tell us your protocol for post-operative douching and what is the duration you explain, all the things about the post-op care of your cavity.
Post-op is important. See, to me, this is the beginning of the treatment for the patient with PRF.
Very true.
What is that cell lying just in posterior superior part of the sphenoid sinus? Just on the area of the septum. Posterior part of the septum, there is cell lying.
Section there. This is part of the post-ethmoidal cell only.
Part of
the post-ethmoidal cell
Yes,
only.
that cell.
See, that is post-ethmoidal skull base. That is anterethmoidal artery.
Yes, yes.
Post-ethmoidal skull base, that is one of the post-ethmoidal cells pneumatizing the skull base. This is sphenoid sinus. Widest possible opening to the sphenoid we have given.
Yes.
See this?
Yes.
All cells flush. See this maxillary sinus wall. See this maxillary sinus for the full entry of the steroid. And see this. So this was little challenging, but ultimately you see the picture, the full house face. See the type 3 cell you saw?
Yes.
Type 3 cell was the important thing in this case. Dr. Kranti just finishes the sinus surgery on this side.
Okay.
Now, about coming to your question about the post-op protocol. Post-operatively, see, this is steroid-dependent disease. That's why I said this is the beginning of the treatment. Never counsel your patient that you will operate, you do sinus surgery and he'll be all right. You have to counsel, this is a steroid-dependent disease, this is an immune complex disease, this is an inflammatory disease. Wherein so far, what we have, the inflammatory cascade, the pathway, at every point of the cascade, inflammatory cascade, the only thing which works. Now, you give your patient oral steroid, they improve, but you can't give for life.
Yes.
So the best, strategy for us now is to do something to make topical steroid penetrable. See the final picture.
Yes. Very clear.
Dr. Satish.
Yes, sir.
How this immunotherapy these cases respond with?
Sir, immunotherapy is for allergic rhinitis.
Yes.
Allergic rhinitis is a comorbidity in 50 to 60% polyposis patient. It's a comorbidity.
Yes.
It means the patient is allergic to certain allergen that invites IgE mediated response. And for that, at entire side of the cascade, the steroid works. And antihistamines, ultimately, histamine is released in the circulation, antihistamine blocks receptor to prevent symptoms. That is the role of antihistamine. Only to control the symptoms of histamine, which is. What's my point?
Yes.
Immunotherapy is basically sensitization of the allergen by giving low dose of the allergen by various means, sublingual, subcutaneous. So that is sensitizing of the patient who is allergic to the allergen. It has nothing to do with CRS. See my final picture.
Oh, I see.
You see with a 0 degree, everything in front of you. Boss.
Yes, yes, fantastic.
Yes.
To the opposite side. Yes. So, boss, expect little more bleeding in this case. We can't help it. But so in these situations also. So immunotherapy will deal with only allergic rhinitis, and that is a sensitization to the allergen, basically, to the individual who is allergic. It has nothing to do with allergic rhinitis. Secondly, coming to Dr. Kranti's question about a post-op protocol. So, this disease is immunocompromised situation of the inflammatory disease. Steroid is the answer. And to make the steroid penetrable, we are doing sinus surgery. By means of sinus surgery, we are serving three purposes. Number one, we are opening the sinuses, we are establishing the patency and drainage of the sinuses. Number one, for their good health, which are already blocked by polyps or anything. Number two, by means of removing the polyps, mucosa, rigid mucosa, the pus, fungus, whatever, we remove the inflammatory load also. Third is give an avenue for the topicals to penetrate. So now what is inflammatory load? I mentioned before the case started. Any patient who is requiring oral steroid for their symptoms to control, that means the inflammatory load is too high requiring oral steroids. If the patient can maintain on topical steroid preoperatively on nasal sprays, there is no need of surgery. You know it. If your patient can manage CRS patient with saline wash and topical steroid nasal sprays, because pre-op setting only nasal spray can be given, nothing else, the sinuses are closed otherwise, and patient can maintain symptom, means his inflammatory load is not so high, why to operate? And that is why the indication for surgery is when your conservative management doesn't work. That means the inflammatory load is too high. So now by means of surgery you remove the inflammatory load. Now since the only weapon is steroid you have, now we have in surgery we have to do a work in such a way that our topical steroid should penetrate everywhere. Why did I make all these openings so broad, so big? So in post-op, when a patient start douching with a steroid, in a particular position we will suggest it will reach everywhere. So in post-op, the only thing required is steroid dosing depending upon the need, depending upon the mucosal eosinophilia, depending upon the overall inflammatory load, and then under the monitoring of the post-operative monitoring, because this requires a lifetime monitoring, can reduce the dose as well as frequency of the irrigation as the need of the steroid decreases. We have to treat comorbidities. Like for example, if patient is aspirin sensitive, you have to desensitize. If the patient is allergic to fungus, fungal sinusitis, you have to desensitize it. Patient has a comorbid allergic rhinitis, you have to treat it by immunotherapy. Patient has a severe vitamin D deficiency, you have to treat it. Patient has a defined immune system, you have to improve it by means of probiotics, prebiotics, so many things. So you have to treat the underlying cause also to reduce the need of frequency and dose of topical steroids. So it's a full inflammatory load is high, you have to give oral steroid. My point, so irrigate with the steroids thoroughly post-op. The beauty is with the topicals now and the post-operative setting, the topicals can penetrate the depth of the sinuses the chances of systemic side effects are very low. Yet, steroid reaching to the area where the mucosa needs. This is how the goal of sinus surgery. I hope it answers your question, Dr. Kranti.
Yes, sir, it does answer. That is what we are also saying.
Now, coming to the opposite side, that's the bulla, that is again the deformed uncinate process. Can you see this?
Yes, it's perfect.
Mobile
Actually,
structure is
more
uncinate.
deformed. Yeah, more deformed than
Mobile
the
structure
opposite.
is uncinate. Give me the reverse biting. So, opposite side of the type 3 cell, this side of the intersinus septal cell. Now, see, coming anteriorly until you reach the hard bone. This, that's the middle meatal antrostomy. Now you have seen couple of times today. Nothing great. So we can discuss the questions in between anytime. Feel free to interrupt me. Anything which improves the immune system will have a positive impact on the overall outcome. Anything which has a negative impact on the immune system will worsen the situation. And the best thing to improve the immune system for sinusitis is to rule out any severe vitamin D deficiency. To improve the immune system by probiotics. You know, our body's immune system is governed by the gut microflora. Gut microflora are the principal, thing behind the healthy immune system. So we have to improve the gut microflora by means of giving probiotics. Probiotics are, see there's some purulence in the sinus. Probiotics are ready-made bacteria, healthy bacteria. You can give. Our gut has more than 4 trillion bacteria, healthy bacteria. Which means of many processes maintain the healthy immune system. Probiotics are ready-made bacteria. Find lot many preparation with 2 billion, 3 billion bacteria. They are good for immunity. And prebiotic is what? Is not the bacteria. Prebiotic is basically substrate for the good bacteria, for the healthy bacteria to grow. So that way, you can feed the good bacteria with the prebiotics for their healthy bacteria's growth. So we have to do something in the post-op for these patients to improve the immune system. See, I have taken the upper part of the uncinate. Can you see?
Yes.
And this is what is this structure here?
Lamina paprecia.
Yeah. So, see the same step I am doing. The middle meatal antrostomy, then removing the upper part. And at the same time, you have to define the lateral limit of the sinonasal corridor. While removing the upper uncinate, see this? Define the lateral limit. See, that is lamina. Simple. So simple to define lateral limit so early in the course. See this?
Yes. Very
And
good.
staying along the lamina is safe for the skull base. See this? I am staying along the lamina. Yeah. Now see this turbinate. See this turbinate and see the disease lateral to it.
Yes. No.
I will not do anything to disease in the upper part belonging to the olfactory system, but see this turbinate with a disease lateral to it. I'll, as I did in the previous case, will do something because my topical will not reach there if the turbinate remains there. See this? If this turbinate falls laterally, my topical will not remain in the, will reach in the olfactory, in the ethmoidal area. So this turbinate is a problem, and since I want this olfactory mucosa to, I will do something to part. I am removing for part.
Are you going to remove this turbinate?
Partial, like did on the opposite side. See, this is essential in this particular patient with the disease in the olfactory cleft. And I am not going to do anything to this disease in the olfactory cleft to give any kind of fibrosis or scatterization or scarring, because that may be permanent. Now, with this area now exposed to the topical steroid reaching to it, post-operative topical steroid will take care of this.
Yeah.
And this will revert back to normal. In a couple of weeks, this will come back to normal with good olfaction. So this is the ideal indication for the turbinate management, this partial turbinectomy. Otherwise, had this olfactory cleft been clear with no olfaction issues, I would bulgarize it.
अच्छा है नहीं जरा
नींद आ रही है? See, this is middle metal enterostomy.
Yes, very wide.
This is your lamina. This is your turbinate remnant.
Yes.
And this is your olfactory region. Flush. And now is the time to look for the frontal. So this patient on this side has an interesting finding of a large intersinus septal cell. Large intersinus septal cell. So just trying to improve the field a little bit more. After this, the next case is going to be a.
Next case is going to be a
Autosclerosis, most likely.
okay.
The conductive hearing loss. Changing to 70 degree. See this now? Now I'm changing to 70 degree. इसमें लगा है 120 भी रखना. See now. See this is again to reorient you. That is your lamina papyracea laterally. 40 लगा था. Let me show you one by one. See, all anatomy at this point of time you have to bring out from this disease area with the available landmarks we have. That is your lamina papricia. Can you see again?
Yes, very clear.
This is your olfactory region. This
Yes,
is your middle turbinate.
yes.
And see, this is the space between the middle turbinate and the cell.
Mhm. This is little difficult situation.
Yeah. See how it opens up. So I'm keeping my middle turbinate as a lateral limit, medial limit, and taking away that cell. At this point, the most important thing I need to keep in mind, go above and go onto the beak. I always tell you the most important landmark is the beak. See that? Take you to the beak. Back there. Yes. Hello?
Yes.
Yes, boss. Now see the beak.
Yes. Excellent.
Could you see something?
Yes.
This is your beak in the middle.
Yes. That is the big.
And where the beak ends?
The frontal
that?
will be just behind that.
Frontal sinus.
Yes. So what you have to do is define your medial and lateral limit, and in between them, go for the beak in the midline. Let me show you much better. In any of the most difficult situation, the beak is the savior. Let me show you. See, that is lamina.
Yes, that is lamina.
That is your
Part of
turbinate,
middle turbinate. Lateral
which
part
I
of
have
middle
kept
turbinate.
as a guide. Which I have kept as a guide.
That is yes.
And see your frontal sinus up there.
Yes. And there is extension of the interfrontal cell.
Yes, I will show you in detail that.
Yes.
See how much of the disease here, blocking everything. See your frontal sinus.
Yes.
Still a lot of work is required to be done here. See my frontal up there? And beak is my guide. What a wonderful landmark beak is. Can you imagine? फाइन डालता है. See now. Want to show you something. That is intersinus septal cell. Hello?
Yes, yes. Sir.
Yeah, let me show you the intersinus septal cell medially.
It is not, it is looking like extension of the frontal cell into the septal cell.
Yeah, there is clear cut, communication. Let me show you. Let me remove this polyp there.
On CT, there was a wall between this, no?
The communication was there. See this?
Yes, yes.
Now, give me the 60.
Yes, yes, not clear, very clear.
I will make it absolutely
large.
clear cut. So these are challenging frontal sinuses.
This is really challenging. You like to remove the beak little more anteriorly?
Yes. Not beak. That will not be required now, most likely. I will show you that. See, that is your frontal sinus.
Yes, that is
Now
lateral.
give me reverse. My reverse is the blade which is most useful now.
That one in the frontal sinus and this is in the frontal. Now the septum is seen. Yes, this is the septum. Yes.
Yes. Because of this cell, the frontal sinus was extremely laterally pushed.
Lateralized. Yes, that is the frontal cell proper.
See the reverse blade.
Yes. Yeah.
That's the reverse blade.
This is 60 reverse or 40?
40. Reverse is only 40. Now see. That is the frontal sinus. That is the intersinus septal cell in the midline. The intersinus septal cell is bigger than the frontal sinus.
Yes, yes.
See,
Interfrontal cell is bigger than the sinus.
120. See, huge cavities inside. That is frontal sinus.
Yes. This is mucopus.
That is frontal sinus. I'll show you one by one, which is what. This is intersinus septal cell. That is frontal sinus. This is supraorbital.
Yes.
All three in view.
In one.
Amazing case. And see, boss, remember when we started frontal sinus work, there was no landmark.
Yes. Yes.
What we took into consideration, remember, our middle turbinate stump,
Yes, that was the
our
most important.
lamina,
And beak.
and then beak. Yeah. With navigation, I will show you. We have a navigation, um, connected. I haven't used yet, but I can show you.
Have you already mapped one?
Huh?
Mapping has been done in this case.
They had already done.
Okay.
See, and now what I am doing?
Yeah.
This is flushing the posterior table. Give me reverse once more, and then I will show you all the three together in a simplest manner. So this patient was interesting on both sides. Opposite side at type 3 cell. One there. So I'm using once flush. Just to show you, I will flush this posterior table with the ethmoidal roof. See now the frontal with all the three cells cellularly around. Wash, give me a wash. So that nobody will forget the orientation of all these cells in future. So that see, this is my remnant of turbinate. Can you see? Hello?
Hello? Yeah.
This is the remnant of the turbinate I have left
Turbinate,
inside.
yes. Very small
one.
part. It is
This is
almost.
the disease in the olfactory region, undisturbed. Can you see?
Yes, very clearly.
And now go in the frontal. That is intersinus septal cell.
Yes.
That is frontal sinus. That is supraorbital recess.
Yep.
All the three things together you can see in one view. You can see now all the three things together.
Yes, yes, very clear.
So this was all about the frontal sinus on this side. The interesting one. And now, what is left interesting here on this side is the anterethmoidal artery. We have not seen yet.
Yes.
I'm least bothered about anterethmoidal artery unless the frontal work is completely done. Because we are not going behind. See how this disease is completely has messed up.
You are still working with 70 degree, no?
Yes. I love this scope, 70 degree. See this. All this ethmoids are completely, messed up with the disease. Can you see?
Yes.
So now what I am going to show you is the entire model skull base. And then we'll change to 0 degree. See, with massive disease, the bulla is the first thing which gets deformed.
Yeah.
Wash करना. See, I have my posterior table in view above. All these cells below has to go. Keep an eye on the posterior limit of the supraorbital cell. There exactly would be the interethmoidal artery. This is what I am going to show you. See the artery level.
Very clear. Anterior ethmoidal artery. There is cell above the anterior ethmoidal artery.
Yes,
Small
yes.
cell.
Yeah, give me the reverse to uncover this cell for you.
What name will you give this to that small cell?
Suprabular.
Suprabular. Okay.
But that is above the attachment of the bulla.
No, it is not attachment to it is not above the attachment.
See this. Let me show you the interethmoidal artery better. Okay. Yes. Okay. See this cell? I am with the reverse. मत डाल यार, ये पूल हो रखा है, रुक जा. That is the level. Here is the ethmoidal artery. See the vessel? See the vessel or not?
Yes, yes, very clear.
This is the vessel. See this?
Yes, yes, yes.
Just to show you. See now the frontal everything above?
Yes.
That's the supraorbital cell, and immediately caudal to that. See that? This is your interethmoidal artery. That is your interethmoidal artery, you see. Can you see the vessel?
Yes, very clear.
Yeah. So that is about the interethmoidal skull base. This is your lamina papyracea. This is your turbinate. And that is the ethmoidal frontal and the interethmoidal skull base. Once you have done, Then the final work is post-ethmoid and
0 degree.
yes. The same thing again, board by seeing again and again. Give me. See that now with the 0 degree. Having done this above work, now the remnant of the bulla below. See the remnant of the bulla. Post-ethmoidal cell. See the post-ethmoidal skull base. Behind the anterethmoidal artery is post-ethmoidal skull base. See that?
Very clear.
This is post-ethmoidal skull base.
Yes, 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 yes.
Now coming to the same landmark, we always mention cloud laga. That is orbital floor.
Your vital floor. Or maxillary roof.
Yes. Same.
Actually, once you say our vital roof, now we are thinking that you are working, going to work in orbit.
You must see this landmark. See this?
Yes, yes, very clear.
Basically, this surgery has a fixed steps if you follow properly.
लीक हो रहा है उसमें दे दे
There's so much of polyp there. Say it now. Now, once we have seen the orbital floor, what is there in front of you is the post-ethmoids.
Post-ethmoid.
See this?
Yes. What is the below cell that is lying just anterior? It's in the front.
Which one?
In the center.
And that is the ground lamella and the post-ethmoidal cells behind, which I am going to go through now.
Yes.
Remove chunk. See, laterally we have defined our limit superiorly as well as inferiorly. See this?
Yes, yes, yes. A lot of cells in this small piece.
Yeah. There is chunk.
Garbage.
Garbage with massive disease into it. See this?
Yes.
All this is unaerated cells.
Wow.
Very soon we are coming to the end of this procedure. See, this area should be thoroughly clean, otherwise. और ये पानी कैसे आ रहा है तुम्हारे? तो नहीं आ रहा क्या पंप से?
Suction not working. Blocked. First time.
It must have been clogged.
अब्दुल
Now see, reorient. रुक जा.
पानी कैसे लगा सब मशीन पे छो रहा है चेंज करो
चलो. This is the maxillary, post-ethmoid, and now I am adding
उसमें डालो
to this
Very tiring.
To the see, this is the maxillary line, utilizing the midline like this,
Yes. The maxillary line.
and entering into the posterior ethmoid. See this?
Yes.
Now, staying thumb. See, staying close to the septum. I am in the
Sphenoid sinus. Enter the sphenoid sinus.
yes. Now, see the interior of the sphenoid.
Yes.
Having seen the sphenoid, staying anterior to it, you can do any damn thing. Anterior to the sphenoid sinus ostium, you can never come across any optic nerve or carotid artery in life. Never. So that is the safest, landmark you can use. I'm removing these bones with the. No. That's the sphenoid. I'm now staying anterior to it.
Cool.
See now, I have to finally widen the sphenoid.
Yes. Retinoid EEG.
Rest of the. See this widening.
Is that posterior ethmoid artery?
No. That lies on the skull base, boss. Far behind there.
Okay.
This is far anterior. See now, you can see all sides. Maxillary sinus, posterior ethmoidal roof. This maxillary sinus. Work done anterior to it. The last thing left is widening. See this? This is widening.
Okay.
Now, to further widen this, see, this is a thick bone.
Yes.
Now, see the skull base, complete skull base. See how much of the work this patient required.
Yes.
Sure. See the sphenoid now?
Yes, very clear.
Enough 40. That's the interior of the sphenoid. See this?
Yes, complete.
But see, on both sides, this disease in the olfactory tract is not even touched.
Yes, yes. This is the olfactory area. Swelling.
Never do, otherwise the whatever is scarring you give is going to ruin. See now, looking at the disease profile, we know how much of disease this patient had. We have given him wide sinus opening, Dharmas.
Widest possible.
See the sphenoid, see the maxillary, see the ethmoids, and the frontal we have seen earlier. Everywhere widest possible opening. See this?
Yes.
Now, the access for the topical is so direct now. Train the patient in the lying head back position and see it is going to reach to the mucosa everywhere. Nothing more can be done to this patient. See this?
Yes, very clear. Everything is very widely open.
See this? To me, nothing more is required to be done. Both sides, we have done a full house job. See this? Opposite side.
Yes.
And this really required this much of job. This was not a straightforward case. Frontal sinus on both sides was challenging.
Yes.
See the picture now?
Even a sphenoid was challenging, especially in left side.
Yeah. Sphenoid was. See the limits everywhere. Is Dr. Kranti online?
Dr. Kranti? Involved with her child.
So that's the final picture.
Yes. Chalitali.
That's the final picture. It is full house fest.
Lost face.
Thank you for your attention.
Yes. Great surgery. We are enjoying it. And thanks to Dr. H.I. Farooq for selecting such a type of cases. But case selection is also very important for any purposeful workshop. Amazing selection of cases.
कुर्सी देना कुर्सी
कम से कम 2 केस खींच देना है अपने को 7:30 तक ओवर करना
हाँ करेंगे ना
है ना 7:30 तक फिर सब चेक कर देना
कौन सा है तो
इसके बाद दिलखुश कुमार जो आप बोल रहे थे वापसी अभी लिए नहीं जब पेशेंट इंड्यूस हो जाएगा तो हम ले लेंगे
ले लेना वो तो
अभी है बहुत कैसे अभी और होगा 10 होना है अभी 100 तो हुआ है 10 होना 60 को आज का 10 होना है
Hello, OT. Hello, from the OT. Hello.
Yes, 1 second, sir.
The next case is step is.
Just 1 second, sir. I will give the mic to sir.
Hello. Boss.
Hello.
Hello. Yes, boss.
Yes, dear.
Are you getting any microscopic picture?
Yes, yes. Now it's just started. Audiogram.
Yeah, so this patient has a moderately severe conductive hearing loss, bilateral, 37-year-old female.
37 years. Oh.
Yes, 37. And picture is, you can see the absolutely normal tympanic membrane.
Yes.
She's absolutely, pakadne. I hope the picture is good now.
Yes, it's very clear. Is there any overhang?
Glare कैसे आ रही है?
Glare.
Okay, now it's better.
Yes, it's very good.
So, एक choice छोटा लाना है. The plan is exploration.
Exploration, okay.
Yeah.
Bilateral conductive hearing loss, na?
Bilateral conductive hearing loss, hopefully otosclerosis. So for this exploration, our approach is transmeatal.
Okay.
Almost always. And our area of interest is posterior superior region. We all
Posterior
know.
superior, yes.
Yes, but we need to keep an option in case we need to go anterior superior. In case your malleolar ligament is fixed,
Malleolar
your
ligament is fixed.
malleus is fixed, or any other condition.
Okay.
You may have to expose the atic.
Okay, yes.
So my incision is a tailor-made incision, simple one. That involves a horizontal incision laterally here. I don't want a too short a flap,
Yes.
as we need to remove this canal wall overhang many a times.
Yes.
At the same time, don't want a too long a flap, making life too cumbersome. So this flap is roughly 5 to 6 millimeter lateral to the annulus.
Yeah.
And inferiorly, I will limit it, since we don't need to go inferiorly anywhere further.
So will you give the radial incision, na?
Your vertical incision.
Yes. Okay.
Because I don't need to go further inferiorly. And I can start elevating like this. See this?
Yes.
Now, the important is the superior incision, because superior, as I said, I may have to extend it further. So what I will do with this horizontal incision, I will make it little, curvilinear. I will not limit it anteriorly. Like we limited it inferiorly, will not limit it superiorly. You can further elevate if you want.
Okay.
See, reaching to the level of the annulus quickly.
Yes. Very fast. Are you using any speculum holder or someone is holding it?
Ramesh is holding Tetwa.
Tetwa. He's he's behaving like a robot right now. No movement. Assistant.
See, opening the middle ear from behind, that is annulus.
Tetwa is Hanuman of Satish Jain.
See, that's the chorda.
Yes.
So between the chorda and annulus, I opened up the mucosa. See this?
Yes, very clear.
And since I have limited inferiorly, let me utilize that so that I can push it forward
Okay.
to prevent coming this in my way. See this?
Yes, very clear. Round window is visible. Round window and infra.
Nicely visible.
Yes, infra.
See that? Now coming to the area of interest.
Yes.
Superiorly. I hope the picture is good.
Yes, very good. Little bit glaring.
Glaring,
but it is tolerable.
Tolerable.
It is tolerable.
Now see the chorda. See, that's the chorda.
Yes.
And that's the incus. Chorda is something you need to protect.
Yes.
And that is great. And there's a lot of overhang you can see. But it is nice. See this?
Small overhang.
Yeah, for this overhang, sometimes we use drill, sometimes accurate can work. Or you can use your Gaussian hammer also. Micro mallet and Gauss. See this?
Yes.
Because your APC, this exposure requires complete visualization of the oval window.
Yes.
I can see the glimpse of the tendon. See this canal wall overhang.
Yes.
See more and more superiorly, the incus long process is visible. What I can see the glimpse of the fallopian canal as well.
There is a question from the audience. Which is better, curate or drill? Better means safe.
Anything which you are used
Which
to.
one is safer, more safer? Curate or drill?
Curate also, if you do the outward movement, it is safe. Drill also requires good control, it is safe.
Mallet, micro mallet, good. Macro mallet and goji. But most of the people use this curate.
Yeah, that is stores curate.
Yes.
I'm removing the bone over the caudal canal.
Most of the time it gets cut with whenever it cuts. बचा क्या? Little trauma, but still serviceable.
Give me a cotton ball, small cotton ball. The nerve is intact, no trauma to the nerve.
Yes. Medium is injured.
Now, cotton ball, chota.
The name of the surgeon, they use conductor Lyons.
Pardon?
Yes. The workshop that is done by Lyon Group, International Lyon Group, LION. Lion
Robert.
Robert, yes. He uses small pick.
Yes.
He uses small pick in the area of especially cauda to avoid injury.
Good. Section there. See now, just keeping the cauda away. Can you see the fallopian canal and the...
Yes, little bit overhang also.
And you can see the pyramid very well.
Yes.
In my practice, right angle, I use a laser at two critical steps. And I'm so used to it. Oh, बहुत बड़ा है तो.
There is a connection between facial nerve and pyramid. They're small.
So laser is a useful tool to avoid unnecessary movement of the stapes into the foot, movement of the foot plate into the oval window.
Yes.
This is a surgery where you are going to deal with a bone which has a sub-millimetric diameter. Weight in milligrams. Can you see the otosclerotic focus?
Not very clear.
Anterior to the oval window, I can see. And see this pyramidal eminence. The facial nerve, the facial canal.
Yes.
And see, that is dehiscent. Can you see the facial nerve dehiscent?
Yes. There is a question, where is the site of fistula antifenestrum? It is a site of origin. Most of the time it is the site
so
of
what
origin.
I will do,
There is also a connection between the facial nerve and the pyramid in the posterior part.
no, that's a bony projection.
Okay, bony, yes, some bony projection is coming.
Yeah, the stapage is fixed. First, I will right angle then. See the separating the equidostapedial joint.
Okay. Using sickle knife?
I generally use a joint knife.
Let's see. This is small hook.
See that?
Yes.
See complete?
Yes, yes.
Just I don't have lasers today. We have a skeeter over here. Give me a skeeter for a while. You got nice weather. See what I can do. See this pyramidal projection?
Yes, yes. It has to be did in some cases.
Okay, nice. Could you see this pyramidal projection?
Yes, it is over projected.
Oh. Look. See, that is the posterior crus of the stapes.
Yes.
Since I am not having the laser oil, I am thinning the posterior crus.
Yes.
Could you see?
Yes, yes, yes.
So when I fracture the stapes, it would avoid movement of the foot plate. Could you see? I am
Yes,
drilled.
yes. Can you decrease the glare of little bit? Is possible because it's due to camera setting. It's very difficult to.
See this.
Yes.
Since I drilled the posterior crus, I could easily fracture it without mobilizing anything. Can you see this?
Yes, very nice. Centralize the picture, Satish.
See this. That is your suprastructure.
Yes. Which piston are you going to use in this case?
Titanium.
Titanium.
See the facial overhang.
Yes.
But still we have space to negotiate.
Either a mucosal fold or this bony projection.
Yeah. Bony.
Yes, that one. There is a huge difference in microscopic picture and on the screen.
Pardon?
There is a huge difference between the microscopic picture on the screen and microscope.
Yes, 100%.
Actually, we cannot project microscopic picture exactly on the screen.
पकड़ना? No. All got.
क्या बोला?
वो कहाँ है छोटा वाला? Here. Now see the facial now, which is decent. See, had we been having a CT scan before, I would know this fact.
It is possible. It is always possible to diagnose this condition on the CT with CT scan.
Yes, always. See now the foot plate.
Yes, very clear.
Now give me the piston gauge. For titanium is the piston I love for many reasons. Titanium is extremely biocompatible, so simple to use, and it doesn't need any crimping, the most important. And let me use the gauge to identify, to know that how much size piston is required.
Earlier, you were using 4.25 on the regular basis. One of the workshop we have told that.
No, not fix. Never fix. 4.5. That was 4.5. See, 4.25. exactly coinciding the middle of the depth of the incus. Can you see?
Oh, yes.
4.25. Fatapat. Now the challenge is number one, the facial nerve. See this?
Yes, there is overhang.
Gel form dena patla.
Align.
This is adequate space, I say, in spite of the overhang.
Yes.
Last week we did almost non-visible, foot plate.
So
And we could mobilize the facial nerve a little bit and put the piston.
do you like
See,
to
even if your piston touching the facial nerve is not going to give any palsy.
Okay.
Do you like to protect facial nerve by massage?
In those situations, you can push the piston up.
There is a question. There is a question that do you put any fascia when there is a dehiscence?
No, nothing. Nothing. See, underneath the facial nerve is the vestibule, like underneath the foot plate.
Yes.
And one of our patients recently put a facial nerve crossing the promontory at the lower edge. And we did a fenestra above the facial nerve.
So you are going to use 0.4 or 0.6?
This is 0.5.
0.5.
And the piston is 0.4. See, inferiorly in the central part. Without using any pressure, just like you're running on a cover slip. Patla, 22 number. See,
yes.
Without using any pressure, otherwise which may mobilize the foot plate. See that? Never suck on the fenestra directly. Can you see the fenestra?
It is visible, but it is not very clear.
See now?
Yes.
Yeah, I don't want to suck over it. It is very clear. Okay. See that?
Yes.
Now,
clear.
कहाँ है वो piston? पतली forceps नहीं है piston के लिए. तो काटा ना. There. And the last and the simplest part is the piston. So the length of the piston is very important.
Check. Let him apart. Let him do his thing. Yes.
The beauty of this piston is it doesn't need any crimping.
Most different part.
That's it.
Yes.
See the piston?
Will you put something to close the fenestra in this case?
A drop of blood.
That's all.
Blood is never going to enter the vestibule for that matter.
Okay.
The vestibule is full of fluid which we have not sucked at all. And vestibule has more pressure than the middle ear. Nothing is going to seep into it unless it is sucked.
Do you like to perform hanging and bending test in this case?
Bending cannot be done on titanium. Titanium cannot bend.
And hanging? Hanging,
Titanium, you can do hanging test. Hanging in the sense to ensure that piston has adequate length.
Yes.
See this? This is adequate and the piston is not coming out of it.
Okay.
See this?
Yes, very clear.
And you can see the piston very well in the fenestra.
Yes.
Yes. The beauty of the titanium is this clip holds the piston like anything.
And there is no necrosis of the long process of incus.
Yes, it holds
This is
only
another-
less than 30% of the circumference.
Yes. That is another big benefit of this titanium piston.
See the chorda absolutely intact,
Yes.
healthy. See that?
Yes. Yeah.
See the vessels over the chorda.
Yeah. Very good.
And just will drive a drop of blood and come out. Right? That would all the next. So the most important thing is the length of the piston. It should not be over long.
Okay.
If your piston is over long, it is a disaster because this is a direct fenestrae episiotomy. If your piston is too big, it will never allow the endosteal membrane to form underneath.
Okay.
So the length should not be beyond 0.3 to 0.4 mm deep in the vestibule. So the length of the piston is the single most important factor. That's why measurement is important to prevent an overlong piston.
What is the smallest length of piston you have used?
3.75.
Okay.
And we have used 5.25 as well.
Okay. But this piston, can we use this titanium piston for malleus episiotomy because it will be difficult to use?
For malleus, there is a different titanium piston.
Okay.
लगाओ ये सीडी है इसमें चलाओ ये सीडी है इसमें ये हेलो
Hello?
Yeah. So for malleus, there is a different piston.
Malleus
vestibular plexi piston, MVP piston from titanium. And that has a beauty of having a ball joint within it.
Ball joint. Okay.
So you can angulate the piston according to the need and give a, right angle stepidotomy in the sense, right angle piston in the sense,
What
the
is the
malleus
cost?
is quite anterior to the oval window.
What is the cost of that piston?
Is around 27 to 30,000 somewhere.
And here people don't pay more than 15,000 for a stepage surgery.
क्या हुआ ये नहीं वो डाइको में कैसे चलेगी रनिंग
चला
इधर देखो ऐसे चलाना है मुझे यस पीडीएफ नहीं चलेगा डाइकोम चलेगा बस वो डाइकोम नहीं दिखा रहा है यार क्या बताऊं मैं ये डाइकोम दिखाई नहीं रहा इसको मैं यहाँ खोलता हूँ ना ये देखो नो डाइकोम चलाओ आप कैसे चला है ही नहीं डाइक दोबारा डाल के दे दूँ डाइकोम हेलो
Hello.
Yes, boss.
What is next case?
Next case is what?
Is there, let us know about the hearing status of this patient right now. Is it the patient has been done in a local anesthesia?
Yeah, but he must have closed. This was a straightforward situation. I don't think any issues with the hearing.
Okay. What's next case?
Cholestoma. Hello.
Yeah. cholesteatoma.
Yes.
Is it extensive or smaller one?
I have not seen. Let's see.
Do you go for MRI in cases of cholesteatoma?
CT scan
CT
to
scan
see
is
the
okay.
temporal bone anatomy and.
Okay. I am asking about MRI. No.
MRI is required for Peter's bone cholesteatoma.
Okay.
Or cholesteatoma which has given some intracranial complication or something like that.
Okay.
Not uncomplicated cases, but CT scan is useful. CT scan is useful for all uncomplicated cholesteatomas. CT will give complete details of the temporal bone, cellularity regarding the extent of disease inside, any erosions of the canal or tegmen, sinus, any abnormality in the anatomy, facial dehiscence, so many things. So it is always useful.
Okay.
I will not say mandatory, you can do without CT also, but it is always good rather than getting surprises. डाइको में डाल के दो यार. मैंने बताया ना आपको. और लेके आ रहे हो?
भैया यहाँ आराम से देखिए. आगे
Hmm. Tetwa. फिर ये कैसे बनवाई तुमने? डिफिकल्ट नहीं है चढ़ना, डिफिकल्ट नहीं है चढ़ना,
इस पे ऊपर नीचे भी
ये समझ गया मैं।
हाँ और सबका पेज तो लेबर करेंगे तो नहीं आप बताइए कहाँ पे और ऊपर करना है और थोड़ा वेट छोड़िए आपका पैर अंदर जाए। हाँ
और कर।
हाँ एक मिनट आप बताइए। ओके वेट हो गया क्या सर?
90 है वेट, कम है मेरा 90 प्लस ही है।
निकल गया मैंने घटाया सर अपना।
हेलो
Yes, yes,
Hello.
sir. Yes, sir.
Yeah, hello.
Yes, sir. So the next case is ready.
Yes, it is appearing.
We have already opened the canal from behind by retroauricular incision, and let us see the inside picture now.
Okay. A brilliant picture. What is the radiological status of this patient?
Radiology, I think, was not done. I don't know.
What is your plan in this case, Dr. Satish?
Yeah. Let me see the findings first of all. Okay, looks like
So which one is
acute
superior?
cholesteatoma.
Okay. Superior.
Force देना.
Hey, कहाँ गए?
Yeah, I am just doing something to the exposure.
There is a little bit anterior canal wall overhang.
Yes, like that. Hello.
Yes.
Can you see the perforation in the
Yes,
attic?
perforation and cholestoma both. There is two. There are two
Attic perforation means cholesteatoma.
Cholestoma, yes. There is also a perforation.
Reason being the attic is lined by a thin membrane, epithelium lined membrane, and perforation there means has to be cholesteatoma. If you find any granulation or polyp in the attic, it is almost always cholesteatoma. See that the mesotympanum is intact.
Okay.
Interesting case.
Earlier there is a bubble there, so that was looking like a.
And see this in the depth of the attic, the cholesteatoma.
Yes.
Can you see the epithelium?
Yes.
Very clear?
Is there a retraction in the posterior part also?
Not really.
Actually, okay.
No retraction. But the cholesteatoma is there definitely. And attic cholesteatoma, interesting case. What I will do, I will show you the simplest way. We'll remove the epithelium. Cholesteatoma means epithelium in the middle ear, cleft somewhere. And since the mesotympanum is good, with the air inside behind the tympanic membrane, we can assume the present eustachian function to be good.
Yes.
What's my point?
Yes. What is the audiological?
Our policy for cholesteatoma.
How much the hearing loss in this patient?
Hearing loss, Farooq. So our policy for cholesteatoma, decision making for canal down, up is always complex. This is not always a preoperative decision. It should be intraoperative.
Okay.
The reason being, if you do intact canal or interiorization, your eustachian tube function should be good.
Yes.
And you know what happens? Every minute our eustachian tube opens, it drives the air inside the middle.
Yes.
And that air is absorbed by the capillaries in the mucosa.
Yes. Yes.
50 decibel. So that is how the normal physiology is.
Yes.
Now, in cases whether either the eustachian tube is malfunctioned or the mucosa is lost, there is no point in doing interiorization. It is going to fail. And then the entire technique of intake canal is blamed. You know?
Yeah.
There's always been a debate. There are certain people who are proponent of exteriorization
Yes.
in every situation. Certain people are, proponent of interiorization in every situation. Our policy is to take a call depending upon many factors.
Okay, centralize the picture a little bit. Okay.
Yes. Our policy is to take a call depending upon many factors, which I'm going to enumerate few of them. But the most important thing, if your eustachian tube is good and you are able to, save the mucosa, go for interiorization, otherwise exteriorization. Any of the doubt about both these issues means regarding the eustachian tube function or mucosal, if during the cholesteatoma removal, if you happen to remove the entire mucosa, there is no point. Even if the eustachian tube is good, it is going to drive the air in the bony cavity where it is not going to be utilized for physiology. So at the end of the surgery, we will take a call.
Okay.
Whether we are going to do interiorization or not. But looking at the middle ear condition with the air behind, I see the good prospects for interiorization. What's my point?
Yes.
Now my next target is, if I am able to preserve the mucosa maximum, I will go for it, otherwise exteriorize. Now it is not the technique which is at fault when interiorization, exteriorization fails. It is the selection of case and how you execute it. Both are important. Both are equally important. If the case is not selected on the merit, and then technique is not to be blamed.
In this case, you will raise your flap just like your interlay technique or with complete mucosal flap?
Yeah, I am just removing the flap, elevating the flap.
Along with mucosa.
And 10%.
Oh, you are doing in a local anesthesia?
Yeah. Very good.
Patient, thank you बोल रहा है. What is the age of this patient?
Age is 17, 18. %10 on.
मैं थोड़ा सा बोल गया
कैट में ना कुछ देता Here I am elevating the flap. Can you see the chorda in the canal?
Yes. We were discussing about that one.
See? That means this part of the canal is absorbed.
Yes.
To have exposed the chorda like this, unusually. दे दो फिर डाल दो हाँ ट्यूब डाल दो यार सोचे करो.
Do you like local anesthesia, prefer local or GA for this type of cases?
At our center we do all under local with sedation.
Local with sedation.
All, irrespective of the age. All ear surgeries. Sedation with good block. In the workshop, here they're intubating, it is better. So that
Never give vitamin.
doesn't bother us. So in any given situation, if the Eustachian tube function looks good,
Which medicine do you give for sedation in this type of patients for urological surgery?
I don't know, or anesthetist gives a lot of cocktails. I don't know exactly. But
actually, we have lost the definition of cocktail in Bihar.
he uses, I think, pentazocine, midazolam,
We
lot
don't
many
know what
things.
is cocktail. We do only know only monopoly. What is cocktail? We don't know cocktail.
So in this case, what we will see, Eustachian tube function looks good. If we are able to remove the cholesteatoma from the aortic or wherever it is going, preserving the underlying mucosa. If we can ensure complete cholesteatoma removal, preserving the underlying mucosa, we'll go for interiorization. Even if this way we may have to remove a part of the canal, we will reconstruct it. The main philosophy will be interiorization. But in any case, any doubts of cholesteatoma removal, any extensive mucosal removal, any doubts on the Eustachian tube function integrity, better exteriorization. And once you do exteriorization, excentrate all cells thoroughly, do a good wide meatoplasty, and then graft accordingly.
Are you using 10% xylocaine for topical application or 4%?
10% these days, 4% is I think not available.
Okay. No, with adrenaline or without adrenaline?
Plain.
Plain.
डाल रहे हो ना?
हाँ कीजिए सर।
करूं?
जी।
ओके, आ जाओ। ड्रिल किधर है? किसका नाम दिया? For sure. See what I'm doing? I'm elevating the flap beyond the aortic region.
Is the posterior part of the tympanic?
Beyond aortic region means anteriorly and posteriorly beyond the aortic.
Okay.
वो लगा दो ना। नहीं लगा दो ऑक्सीजन यार। सर्कुलर दिस वो सिकल और साइड।
When you like to remove whole of the skin in this type of patient, some people used to remove whole of the skin.
Oh yeah, you can, but most of the time it is not required to remove the whole skin.
There is no point actually.
See this. This is our area of interest where this aortic perforation is.
Yes.
Now I am elevating this skin anteriorly. See this annulus?
Yes.
And trying to enter into the middle ear beyond this cholesteatoma in the normal region.
Okay.
See the discharge?
Yes.
That is glue.
It means dysfunction of Eustachian tube.
Yeah, the glue is there.
Compromised.
Anyway, glue is not irreversible condition. Glue is never irreversible condition, you know. In glue situation, once you remove the glue and ventilation is established, it reverts. Unless there is some region behind, some nasal cause behind a permanent issue.
Okay.
Like for example, if it is a cleft palate patient, I would never attempt intercanal. See this?
Yes.
What I have done, I have gone anterior to it and this is the normal middle ear.
Yes, yes. Little bit matters mucosa accept.
Yeah. Similarly, I will go behind this perforation. Circular. See the chorda. The bone over the chorda is absorbed. That means the posterior bone is quite absorbed. We don't know the region. See the middle ear from here behind. You भी डाल दो ना यार.
वो देने लगता है.
See the posterior part of the mesotympanum. There is no cholesteatoma.
There is no cholestoma.
Okay.
Is that area adherent to the?
No, no, not adherent. This is just a little bit of the boggy mucosa, nothing else.
Okay, just a position.
So we have seen both sides.
Okay.
The middle ear is healthy.
Okay.
Now what I will do, simply convert into a central perforation. This attic.
Okay.
See, this is the flap is hanging on the malleus handle. See this?
Yes, yes, yes.
Then a malleus nipple. Malleus nipple. See, the entire flap is on the malleus handle.
Yes.
I have uncovered this skin from the attic completely.
Yes.
Because that is the area of interest. Now I have separated this flap from the malleus. See this?
Yes. Very clear.
Now, if I reposite it, see this.
Yes.
This will be a central perforation which we need to close.
Okay.
See this?
Yes, yes. Little centralized, please.
Yeah. Again, see simple what I am trying to say. I have elevated this tympanomeatal flap from the superior, adjoining posterior and anterior part. See this?
Are you going to inside out or outside in?
No, no. That will decide. See this? See this? The entire tympanomeatal cleft elevated.
Yes, 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 yes.
And from this region, from the area of interest where we need to drill and remove the cholesteatoma,
Okay.
and kept inferiorly. Can you see?
Yes. Inferior.
Now what has this given us? This area is now completely, you know, in our view to do anything, which is the disease area. Got my point?
Yes. No. What you want to convey?
Huh?
Are you going to drill the area, na?
Yeah, yeah, I will see. So first of all, this, see, normally this area below is the normal area now.
Yes, 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 yes. No doubt. There is
And
cholestoma.
I have elevated the flap along with the normal area.
Yes.
I have segregated this from the disease area now like this.
Okay.
Okay?
Yes.
Now we'll focus on this. See this?
Yes, yes.
So what I will do first, I will remove this malleus. I will remove this malleus. See this? And see the cholesteatoma. See the cholesteatoma inside.
Yes. So going into the middle ear also.
See this?
Yes. Would you like to remove this chorda in this case?
Yeah, chorda is useless here. In such inflammatory disease, the chorda itself becomes inflamed, no? Figures. See the cholesteatoma in the atic. Now we don't know till behind where it is going. Now we have two ways, either to follow this cholesteatoma behind or come from behind. See that? That's what you were asking, boss.
Yes. One of the delegates is very anxious about this. One of the delegates is very anxious what he will do, inside out, outside in.
You can go by any way. Ultimately, you have to reconstruct it, whatever. So, see, I am enlarging the canal first of all. We'll reconstruct it later. Okay, then.
This is canaloplasty only.
See this?
Yes.
डाल दो हाँ यार
सर कैमरा फोकस फारूक थोड़ा सा कैमरा फोकस करवाओ जरा से
हाँ कैमरा इज नॉट फोकस
little bit more picture
More?
little bit no yes no yes okay no
yeah let the anesthetist put the tube first.
Okay.
The patient is not cooperating.
No. Focus from the camera.
Yeah. Just 2 minutes.
Don't
Boss,
change.
2 minutes will come back once the anesthetist puts the tube. Let the anesthetist put the tube.
Okay. Going under GA.
Yes. So now the goal is our tympanomeatal flap is pushed inferiorly. Inferior area is all good. The area of interest is atic. So I'm doing eticotomy from inside. And let us see how the cholesteatoma is going behind.
Yes. So which technique do you prefer? Inside out or outside in?
Anyway, it doesn't make any difference, boss.
No. What is your preference? In this case, what is your till now? What have you decided?
Yes, so I am doing eticotomy from inside.
Okay.
And follow the cholesteatoma till behind.
So that will be inside out.
Yes. So the goal is to remove the cholesteatoma until it is extending behind, preserving the mucosa.
Okay.
If I am able to preserve the mucosa maximum, I will show you the plane between mucosa and the cholesteatoma.
Yes. Sometimes it is easy to.
Yeah, if the mucosa is preserved, I will reconstruct this canal with the cartilage and put my flap back.
Okay.
What's my point?
Yes. At once you reconstruct the posterior canal wall. Now, will you like to go for repeat one MRI after 6 months or 1 year?
Not really, unless you are not very sure about complete removal, unless the patient is developing symptom,
okay,
or unless the patient wants himself that he doesn't want to take chance. But MRI cannot pick up a sub-millimeter cholesteatoma. I mean, 3 to 4, 5 millimeter cholesteatoma up to 5 millimeter MRI can miss.
Okay.
So for cholesteatomas, MRI is required if it is extensive and if you have a high suspicion. If you are not sure of complete removal during the first stage. Let us see how once the cholesteatoma is removed, then you tell me if the MRI will be required or not.
Chances of skip lesion in such kind of cases?
Not really. The cholesteatoma, is a skin which is coming from the canal inside the middle ear.
Sometimes
So
you see that the disease is there in the adductus, in between the tip and the editors, there is granulation tissue.
That's
and
why I
the
told
tip is-
you. That's why I told you.
Yeah.
That's why I told you that we will ensure complete removal first, and then we'll decide this. Ready?
Yes.
So let's first ensure the complete removal. इसे एक साइड पतला दो और ड्रिल see this? Okay. See, fall cholesteatoma. Hello.
Yes, it is going beyond editors. Let us see.
See, completely occupying the attic. What now? Doll, circular. Can you see? This is all
Granulation.
hypertrophic mucosa.
Thickened mucosa.
This is all hypertrophic mucosa.
Yes.
Inflamed mucosa, you can say.
Yeah.
This is inflamed mucosa.
No.
And cholesteatoma is not extending beyond there.
Some people use a cotton ball to rub
Yes.
the area, to clean this.
Then you end up damaging the mucosa.
Yes.
Then you make a mop of the entire area. पतला देना है पतला
Most precision instruments. Never use cotton and rolling this back.
वो दे ठीक है बेटा. Can you see the epithelium? Hello.
अब करते कौन मना करेगा किसी को?
Hello.
Yeah, hello.
Can you see the epithelium being elevated?
Yes, yes, yes.
See this again. This is important. See, this is epithelium.
Yes.
Being elevated, leaving the mucosa below intact. Can you see?
Yes. Is the cholestoma going into the sinus tympani area in this case?
Yeah, towards the oval window.
Yes, appears to be.
See this plane.
Yes. But there is no mucosa.
There is mucosa underneath.
Anterior in the anterior part only, na?
Yes, this is all mucosa underneath.
Oh, okay. कॉटन बॉल से खाने का जो वो जो स्पेस है
I am not using a sharp instrument. See the... Now give me diamond. I am using a blunt instrument to elevate the cholesteatoma.
Yes, yes, yes.
Under microscopic vision.
What is mesna? Do you know? Have you heard about mesna? Satish?
Yes.
What
Yes,
is this
yes.
What is this mesna? I have not heard.
Mesna breaks disulfide bonds in cholesteatoma
Okay.
and helps easier elevation of the cholesteatoma in the difficult situation. See my cholesteatoma layer.
Yes, 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 yes.
Okay. So mesna we use in Peter's bone cholesteatoma sometimes when you have cholesteatoma which is riskier to be elevated from the critical area like carotid artery, dura, some vessels. So in that situation, mesna is helpful. Nothing going beyond. I am not removing unnecessarily the cells behind, which are not culprit.
Okay.
You know?
Yes. So here.
And that is my plane of removal of cholesteatoma. in this region. Give me cotton ball. See, the thin mucosa is left. Break देना। Thoroughly बढ़ेगा। See this cholecystoma in the oval window. Hello?
Yes.
See this cholecystoma in the oval window.
Yes. Will you like to drill little bit overhanging area?
Yeah, थोड़ा दे पतला. This overhanging area you mean?
Yes. That will make the work easy.
My facial is there, you can see.
Yes. It is not easy. Far away. Facial and far away.
Circular. Figures, please. See my epithelium layer.
Yes.
See this?
Hmm.
See the mucosa in the entire oval window region.
Yes. Very clear now.
See the underlying mucosa. Cotton ball. Okay. Now anteriorly.
Yes. No,
Patli diamond.
There is a question, what is the status of processes coliformis in this case?
Let me see again and tell you. See now the only area which is left is the anterior one. Let me uncover it better. See this?
Yes.
Mucosa everywhere.
Yes.
See this epithelium? नहीं वो
No.
Process.
Is that cholestoma or mucosa?
No, epithelium, cholestoma.
Cholestoma.
See this plane.
Okay.
See this plane
Yes.
coming out intact.
Camera setting is not proper, dear.
Not proper?
Camera setting is not. We are not getting very good quality. You must be seeing very nicely, but it has to be adjusted from the camera side, not from your side.
See now?
Still not what we used to see.
You have a habit of seeing in the Pentero.
No. I am talking about the picture only.
You have bad habits. Yes. Now.
Yes.
Give me a wash. See, my attic is covered by mucosa all over.
Yes. So some important pictures. Anatomy, sorry. Facial nerve, lateral semicircular canal.
I will. See what I'm ensuring.
Yes, round window.
See now, what do you see? Complete removal.
Yes, very nice.
Peeling of the mucosa. See, everywhere the mucosa is completely removed.
Yes.
Oh, sorry, the epithelium is completely removed, leaving the mucosa only below. Can you see this plane?
Yes. So how are you going to do ossiculoplasty in this case? Are you going to use cartilage or some?
Yes, cartilage. What I can ensure now, there is no cholestoma.
There is no cholestoma now.
Anything into it. Okay. Regarding the anatomy, see this. This is old window here. This is facial now. This is lateral semicircular canal, attic. This is the anterior attic. That is the Eustachian tube area. Okay. Hello.
Yes.
Now, the thing which is left to me is the reconstruction. Reconstruction of the canal as well as cartilage.
There is some thick granulation or.
Yeah, reconstruction of the canal is never a difficult job because you have to leave the space below and you can cover by the cartilage. You can leave the space below for aeration.
Okay.
Because we have not removed any cell behind. In canal down, you have to exenterate every cell.
Yes.
Why this decision making is required? Because both the procedures are good. It's not this is the tendon of stapedius. It's not the fault in the procedure. It is how it is executed and for indications. Both techniques are good. Both have their disadvantages also.
Yes.
Canal down, the patient requires lifelong follow-up. Swimming is a big problem. Recurrent discharge is a problem unless a very good cavity is fashioned. Hearing is a problem better hearing can be reconstructed with a more middle ear space that is in the intact canal. So canal down has its own disadvantages and people look for intact canal and interiorization. Interiorization has its own disadvantage. Number one, if you are not sure of complete removal, better don't do it. Secondly, there should always be a, your patient should be told of a need of a second look. Always. You must tell patient at least in case required a second look is required or planned. Third is aeration. If the canal intact surgeries can survive only on aeration. If aeration is not good, it cannot survive. It cannot work. Whatever canal you reconstruct, it is not going to work if the aeration is compromised. So everything depends upon aeration.
Centralize the picture, please.
Yeah. So I have a very good condition now for the reconstruction.
Yes.
See my middle ear?
Healthy mucosa.
Yes. So now what I am going to do, I am going to use my cartilage for for the ossiculoplasty as well as canal reconstruction both.
जहाँ से तक ड्रिल कहाँ को देखना क्यों देखना नहीं देखना ना कहाँ को देखना
For ossiculoplasty, we have only foot plate situation. No ossicles we have. For ossiculoplasty, I will use L-shaped cartilage from foot plate to, this is our choice of ossiculoplasty. For many reasons, I will tell you. It gives reasonably good hearing reconstruction along with maintaining the middle ear space. And more importantly, it is a stable assembly.
Sir, is there any way to see the potency of the mastoid bone as such by using fluid and all that? Clear.
So see that the mastoid is open from here.
Up to the tip, sir. Up to the tip.
There is no point in doing that because we have not. I am leaving it undisturbed without disturbing the cells. See here.
Okay.
All the cells are there. The cellular labyrinth is there, which is left intact down the eustachian tube.
Okay.
Which is left intact down the eustachian tube.
Yeah.
To aerate. That's why I didn't disturb. This is interiorization.
Okay, sir. Thank you.
Now the most important thing is the ossiculoplasty and canal reconstruction. Cotton balls. And I will use my cartilage. That is our technique. See, for any ossiculoplasty, the most important thing is the middle ear space and the stability. Stability of the ossicle is important, or whatever chain you reconstruct. If it is not stable, it cannot work. That's why the TORP and PORP have gone to disrepute. Stability is a big issue. Stability has always been a big issue for them.
Hello.
Yes.
There is oval window. So have you got any experience of that one? Have you ever
Pardon?
used?
Pardon?
Shoe, oval window shoe, foot plate area shoe.
Shoe is different to stabilize the ossicle. See, let me show you the ossiculoplasty the way you want. That's the shoe has also gone to disrepute. Because stability is again a question mark.
Recently, there was a workshop I was watching that was being relayed from somewhere else. They were using that. So,
Yeah, shoe is an old technique, not a new one. So first of all, what I'm doing,
and that shoe was invented by one of our own Indian surgeon.
Maybe I have not seen. So that is the tactics to stabilize the lower end.
Yes.
That's it. We'll stabilize both the ends of the cartilage and make sure that it is very well, stable. We'll create a chain of ossicles like natural. Close to, not exactly, but close to. See, this is tragus. I'm making an incision a few millimeter medial to the tragus to save its cosmetic value.
Always avoid using tooth forceps for holding this tragal cartilage.
Yeah, that's why the non-teeth is being used.
You change it immediately.
You have ample of cartilage in and around the ear. Hello.
Yes.
Now I will harvest some more cartilage. This is to,
The canal wall.
I'll harvest some more for the Reconstruction from tragus.
From the same area.
No, from the concha.
Okay.
I told you we have ample of cartilage in this region. We have ample of cartilage in this region. काट नहीं रहा क्या? Knife. छोड़. Give me some other knife.
Are you removing part of the cavum concha or Simba concha?
Simba.
Simba.
सही लगाया.
हम सब कुछ. Huge piece of cartilage is being removed.
Yes, you can remove as much as you want. Think another piece of cartilage. Hello.
Yes.
Now we'll make the use of both of the cartilages. तो सलाइन में डाल. वो भी दे, दोनों सलाइन में डाल के वो बैठ दे काटने के लिए.
Have you come across cartilage necrosis or flap necrosis or graft necrosis?
दूसरा देना.
Hello.
Not really. Cartilage survives so well, and we always leave a perichondrium around it. Always, I will show you. We have seen cartilage for years together in the patient without giving any problem. You must have also seen in long-term follow-ups.
Yes, yes. But there is, I have faced some immediate cartilage necrosis.
There could be some infection or something. Usually not. See, this one piece I have taken.
Yes, for ossiculoplasty.
Yes. See the perichondrium on both sides? Hello?
Yes, yes.
See the pericardium on both sides.
Okay.
Can you see very clear?
Yes, yes, yes.
Even one side is adequate. At least there should be on one side. See this cartilage roughly, and we'll show you how to use this. Leave it. Hello.
Yes.
I will use this cartilage from the oval window to the inferior annulus.
Inferior annulus, yes.
Let's see. आगे तो बना है. Drill. I'll make a facet on the inferior annulus for this cartilage.
Okay. We'll drill with the drill, no?
Yes, yes. See, the middle ear is so good.
Yes, 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 yes.
See the middle ear.
Yes, very nice.
This technique I learned from Dr. ABR Desai.
Yes.
And then we modified a little bit also, which I'll show. Dear friend Ashim does a lot. And we have been doing for years now. Touch and go. Just touch and go. Just touch and go. See the facet we have made?
Yes, yes, yes.
Now give me the cartilage. This broad end in the oval window.
Yes. Is the size of the cartilage in the area of oval window is proper or a little more?
Pardon?
Is it larger? Is it adequate size?
Yeah, yeah.
In the oval window area, that's a part that is going into the oval window. Then little appears to be thicker, wider, you can say.
No, I will show you. I will show you.
Centralize the picture, doctor.
Yeah, yeah.
It's like to see the round window reflex. That will.
Yeah, yeah, yeah.
Then do the job.
Will not leave without that. Will never leave without that. Give me the drill again. Drill again. Yes. Befitting in the facet. Now what we will do, give me knife. I will cut the cartilage to the partial thickness to give it like a joint. To make it like a joint. See this? Hello?
Yes, yes. Half cut. opposite side of the pericardium should be intact.
The pericardium and the cartilage also up a little bit.
Yes. Take a new knife.
I don't want overcutting.
Yeah.
Yes. This is a very gentle cut, you know.
Yes.
We have to use the spring of the cartilage for the transmission. You cut through and through, it is not going to effectively transmit. We have to use the tensile strength of the cartilage.
Now it is accept. Little bit.
Yeah, if you cut through and through, it is not going to work. Now see.
Yes, very stable. Very stable. Very stable.
This flap is going to come over it, and then see. See this. If I press this, see. This works like a joint.
Yes.
See this?
Yes.
Now the advantage, number one. This will remain in contact with the TM all through.
Yeah.
To give it stability and to maintain the middle ear space underneath. See the middle ear space? And since there is perichondrium all the way, this will help in graft uptake also. There's a great support to the graft in case you use graft.
Yeah.
In case you use in the perforation. Now see, you press here, it doesn't go completely in and out.
Yes.
If you use a torp or porp, can be dangerous.
Okay.
See this? This is not going to press the foot plate completely. Even if you overpress, see this?
Yes, yes.
It is never going to go and subluxate the foot plate. This cartilage rim is there to transmit the
sound.
See this rigidity. See this?
Yes.
It is like a chain. It works amazing. It is so stable at both ends now. You can see. Hello? Hello?
Yes.
It is so stable. See the oval window below.
Yes, 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 yes. Very nice.
See the oval window below. It gives in and out movement like this. Got my point?
Yes. No confusion at all.
See, it gives movement on the oval window. Okay?
Okay.
Now I will place it later on.
Okay.
Now I have two things left to do. One is a little bit of the graft to the central perforation we have created.
Yes.
And then cartilage for the canal. See this? That's the central perforation, you see. Now canal is widened, so cartilage will narrow that. See that?
Yes, yes, yes.
And rest will be covered by the graft. So what I will do? Scissors.
We'll cut that area.
Yes, yes. And my graft will cover. And this gap will be filled by cartilage. See that?
Yes.
Now I need cartilage. There way.
Will you like to raise the elevate the anterior canal wall little bit so that you can increase the length of this flap?
No, not really needed. Let it be attached to. See, I've already elevated from below.
Okay.
See this?
Yes.
I have two pieces of cartilages which I have to cover. This defect from above.
It's a very big piece.
Yeah, use. वो दे दूसरा वो दे पहले. Yes.
Centralize the picture, dear. Picture is not centralized.
Not centralized?
Yes. Yes, it's okay. Good. Giving cut in the posterior part can make the job easy.
It will. I want to use the pressure.
Okay. And there is Dr. Bhavani in his hour. I think you must be knowing of that person. He used to split.
Yes, he knows. He does various ways.
Yes. He used to split the lower part and the posterior part of the cartilage in two pieces. One is to go into the mastoid, another on the.
Many ways. Sudeep Munjal does little different.
Yes.
There are many ways to do the same thing. थोड़ा और देना. पतला कर दो.
Can we use soft tissue to do the same job?
Yeah, you can see. If aeration is good, whatever you do, even if you don't use anything, and reconstruct, put your graft and it may work. If your aeration is good. It's a matter of aeration only. Doesn't matter. It is going to see the aeration will go from underneath. Hello?
Yes.
And it will keep everything stable. So it's a matter of aeration, you know. Cut. इधर से भी कर. हाँ. I will harvest the graft. This is just a rehearsal. See, you must be thinking where I am trying to fix it. No need to fix it. Yes, like this. Let me first harvest the graft. Hello?
Yes.
I'll quickly harvest the fresh graft.
Okay.
पकड़ जल्दी. काट लेंगे थोड़ा. See, we'll just harvest a piece of fresh graft to cover everything from canal side. So just this is to cover everything from the canal side. Continuous, just now one by one we'll place everything. First of all, this graft. This spread. See, we have adequate temperometer flaps. Hello? Except superiorly. Can you see?
Yes, yes, yes.
This is the area which we have to cover. Give me. Give me. Now I'm placing this graft. That's the fascia graft. Hello.
Yes, yes, yes.
काट लेते वो देगा दूसरा वो ऑर्टिकल वाला pickle pickle Yes. That is the osteoclastic cartilage.
Yes.
Be fitting in the oval window and both the ends.
Yes.
ये मेरे बेटा My aeration from to the mastoid will go underneath from this. I'm not using a big cartilage. For the hello.
Yes, yes. Now it's appear nice.
Yeah, I'm not using a
Yes.
big one.
Yes, yes. That is sufficient.
Now, as long as your aeration is good, it is going to work like anything.
Yes, it will work.
See the cartilage below. So stable.
Yes, yes. Very much stable. Cemented.
Gel form. This is the gel form anterior to it. I have to fix this. This is the assembly. Hello?
Yes, yes. Very stable assembly.
Because it is stabilized at both ends.
Yes.
This is not something which you have put directly onto the foot plate.
Yes.
It will never allow the foot plate to get submerged because it has a sort of joint. So it is safe also. See, this cartilage is there. Hello?
Yes, yes. Very nice.
This is stable.
Very elegant looking.
And you have an adequate canal also.
Yes.
And below there is a wide aeration.
Yes. Wonderful. Is there any more surgery after this today? For today, there is more surgery after this? Hello? OT?
Farooq.
Farooq?
No.
No.
So according to Farooq, this is the last case.
Yes, yes, yes. It should be last case.
See this lateral end of the flap and the graft. See, this is the cartilage. See this? Hello?
Yes, yes, yes. Will you like to do
Automatically-
metoplasty? Hello, Satish. Will
Yeah?
you go for metoplasty in this case?
Not really.
Not really. Okay.
See, we have almost same canal size now.
Actually, already Pankaj
See this cartilage. This cartilage, you must be thinking I never stabilized anywhere.
Yes.
See this cartilage.
Yes, yes, it's wonderful.
And this flap and the graft is stabilized on this cartilage.
Yes.
This will epithelize and give a normal contour to the canal. Below is the aeration and the ossiculoplasty is in contact with the drum. Hello?
Yes.
So this is all about this case.
Yes.
Thank you.
Good evening. Hello. Ashwini boss. Hello.
Hello.
Yes, sir.
Hello, Farooq.
Yeah.
Dr. Farooq.
This concludes to the.
Is there any dinner or
session.
still working dinner?
Uh,
Are you going to convert dinner into a working dinner?
I have requested Jain sir so much, sir. Please do not give us another working dinner today. So we'll be having a banquet dinner, and all are invited. The time is around 8:30. We'll go to around 8:45 onwards. The venue I have already posted in the AOI Bihar Jharkhand group. So it will be a banquet dinner and inaugural function. So all of you are invited. Please come. ठीक है boss? क्या करें? दूर जबरदस्त हो गया तो अभी कहाँ चलना नहीं चलना बैंक पे
Hello, OT. Hello, Arvind. Hello.
Hello.
Arvind, so we are closing from here, huh?
Okay, okay.
Huh.
करना गया मुश्किल लग रहा है मुझे तो कौन सा करेंगे ठीक है मुश्किल खुश था मैंने वेब से कर लिया